Very warm welcome. Hello and welcome. I'm Dr. Neera and I'm your host for this conference. On behalf of Swasth Care, All India Institute of Diabetes and Research, Managed Health Foundation, I want to welcome you all for this first ever international conference, Innovations by NGO in Diabetes Care. So to set the context, I would want to invite Mr. Rajesh Sharma, Managing Trustee of Managed Health Foundation, to welcome and introduce as Organizing Secretary. Mr. Rajesh Sharma.
Good morning, ladies and gentlemen. Myself, Rajesh Sharma. It is my pleasure to welcome you on behalf of Organizing Committee. I'm Organizing Secretary of this conference, Innovations by NGOs in Diabetes Care, which you will be there with us for next 3 days from 12th to 14th of August. And the conference is being organized in collaboration of Swasth Diabetes Care, All India Institute of Diabetes Research, and Managed Health Foundation. Managed Health Foundation is working in areas of early diagnosis, public awareness, patient support, advocacy, and continuous medical education programs. I welcome all of you to this conference, and it is my pleasure to share with you that we have participants from 31 countries across the globe, from India, 249 cities, and there are 687 NGOs, organizations, hospitals, societies across the world are participating in this. And there are 125 faculties who will be delivering the scientific content over next 3 days. There are 2,000 plus delegates and being continuously added. And it is my pleasure also. There are a lot of people who want to work for the cause of diabetes. We have the registrations of 225 volunteers who wish to contribute for the cause of diabetes. Why this conference? Why all of us, so many people are excited and interested in getting to work for? When governments world over are working, for example, in India, government has rolled out one of the biggest biggest healthcare program, Ayushman Bharat, for about 50 crore people, that is precisely 10 crore families, getting coverage of 5 lakh for the treatment. At the same time, Government of India has also rolled out national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke. We call it NPCDCS. You can see all across India, this has been rolled out. So government also want to work with this program for prevention and control of the chronic diseases. It is a major healthcare challenge. And from the government side, Honorable Health Minister and Ayush Minister will also be joining for the conference. So when government is working at such a large level, why all NGOs need to contribute? Besides the government efforts, NGOs play a key role in prevention and management of diabetes across the globe. Large number of NGOs are working in diabetes world over. This conference aims to address the multidimensional challenges in diabetes care with better prevention, screening, management, pre-diabetes care, early diagnosis, and improving access to care, to discuss the challenges, to work on the possible solution and encourage activities done by NGOs in diabetes care, and also to encourage innovations from the NGOs. We hope that this conference will bring us together in fight against diabetes and its complication through collaborative advocacy work at national as well as global level. And this will also open doors for collaboration to work together for diabetes prevention, screening for early diagnosis, improving access to care at district level, and complete treatment, increase the adherence. I would also like to share with you few glimpses of innovations. In the innovations which are submitted by various NGOs from across the globe, they are artificial intelligence based. You have patient adherence program like smart nursing with diabetes friendly behavior, which reminds you. Then you have different programs like hyperbaric medicine, different mobile applications. There are programs for education, engagement, and empowerment. This will be rolled out over next 2 days. I would like to introduce you to the SWEET Awards, which have been instituted with this conference for excellence in diabetes care. These awards are in 7 categories for NGOs working directly or indirectly influencing, impacting, or making difference in diabetes care. They have nominated, and these awards are in 7 categories: in prevention of diabetes, excellence in diabetes foot, type 1 diabetes, diabetic retinopathy for prevention of blindness, diabetic nephropathy, gestational diabetes for the upliftment of diabetes care in resource limited areas such as tribal and slum. We have got several submissions in these. These are glimpses of submission. This will be presented during the conference, and we have eminent jury who will be selecting the awards, which will be presented during the valedictory ceremony on the last day. This kind of programs are not possible without the grace of Guru. So in my all programs, I always have my Guru, Gurudev Shri Ravi Shankar, who will be joining live today from 5 to 5:20 p.m. We have blessings from Dr. H.R. Nagendra, President Vyasa, during the inaugural function. We have blessings from Sadhguru during the inaugural function and valedictory. And I'm grateful to my organizing committee for working hand in hand for last 7 months. We started working for this conference from January, and a lot of work has gone behind, right from searching for the organization at national and international level in different areas. So I'm grateful to my organizing committee, organizing chairman, Dr. Mayur Patel, my co-organizing secretaries, Dr. Yash Patel, Dr. Sushil Patel, who have been working tirelessly for last several months. So what you can expect from this conference? We have organized sessions in different sets as per the requirements and of the organization, right from setting the expectation in the first session, talking about needs, unmet needs in diabetes care, expectation of different stakeholders from NGOs, then to how to handle the disease progression and its complications. We have we are touching upon the issues like living with diabetes, psychosocial issues, marital issues in patients with juvenile diabetes, and of course, how local innovations can impact outcome in resource limited settings. We have also incorporated faculty. We have also innovated faculty from cross specialties, learning from cross specialties, how other specialties have taken care at the district and regional level in transforming the service delivery. We have interesting session on training and education opportunities for a diabetes NGO volunteer. We have interesting session how to uplift the NGOs to the international level. This will be delivered by international experts in the field who have been working for last several years, as well as national experts. We are also felicitating the awardees in diabetes care who have received Padma Shri Awards and other awards. With that, I welcome you all to the inaugural function, and I request for your very active participation over next 3 days, and I'm very confident that with this we'll be able to contribute little more in the diabetes care. We'll be able to learn from each other, and ultimately this will result in the enhanced diabetes care in different parts of the world. Thank you.
Thank you so much, Mr. Rajesh Sharma, because it is really an innovation in field of diabetes, participating and getting together all the NGOs in this field. Om Asato Ma Sadagamaya, Tamaso Ma Jyotirgamaya, Pratyorma Amratam Gamya. Any auspicious beginning has to be with the blessings of God. Let's pray. Oh Lord, lead me from the untruth to truth, darkness to light, and death to immortality. I request all the dignitaries present over here to join us virtual lamp lighting. Over to you. Thank you. Oh Lord, be with us during these 3 days to make a much better impact on society and patients living with diabetes. With this, we move on to our felicitation ceremony, inauguration ceremony. We would want to felicitate the leaders, the thought leaders who have worked in this area of diabetes for years and decades and really made an impact in people with diabetes. So I would want to invite first Dr. C.S. Yajnik, felicitation of Padma awardee. Dr. Yajnik is Director Diabetes Unit, KM Hospital, Pune. He is founder member, the current president of Sneha India, Social of Natal Effects on Health in Adults, founder member and trustee of International Society Development Origins of Health and Disease. Dr. Yajnik, please, few words from you.
Thank you.
I'll move on to felicitate Dr. Sudhir Shah. Dr. Sudhir Shah is consultant neurologist, professor and head neurology, VSG Hospital, Ahmedabad. He is also director of neurosciences, Sterling Hospital, Ahmedabad. Dr. Shah, please.
Thank you very much. I really appreciate. It is important to educate masses not to take medicine rather than to, promote
Contribution in this
treatment of.
field. We are privileged. Yes, sir.
Am I audible?
Yes.
Yeah. Okay.
Yes.
So what I'm trying to say that I first want to congratulate the whole team for this wonderful attempt. I want to thank for considering me for this coveted award, and I want to tell that I myself have selected the healthcare services or industry for the simple reason that my father and forefather all were in medical branch, and luckily my both daughters are into medicine. One other one is neurologist and the second one is a physician. So, and I want to tell that healthcare is not the priority of only doctors. Healthcare contribution can come from a common man, from NGOs, from government and public patient partnership and whatever. So let us make an attempt to improve the health and education regarding health together and improve the total health scenario of India and the world. So I'm sure this conference would go a long way in educating people and creating a big impact, at least in prevention and management of diabetes and its complication. Once again, I want to thank each one of you for this massive effort. Thank you. Thank you so much.
Thank you so much, Dr. Shah. Words of wisdom. Thank you. Thanks a lot. May I request Dr. Yachnik? I can see you, sir. If you could share a few words with us.
Thank you, madam. Again, I'll begin by thanking the committee for selecting to felicitate us. And I'm very grateful to the committee, not only from my behalf, but from my department, my hospital, and the other organizations which I represent. You have mentioned SNEHA and the International Society for DOHAD. The philosophy of our research has been that the diseases like diabetes originate very early in life in the mother's nutrition, in the mother's metabolism, her stress, and a whole lot of environmental effects that the baby faces in utero. And this was well known to the ancient Vedic wisdom. We also know the story of Abhimanyu, who learned how to enter the Chakravyuha while growing in the mother's womb. And we have resurrected this based on the science which was developed in the UK by Professor David Barker, who proposed that fetal programming was the initiating event for diseases like diabetes, heart disease, blood pressure, cancer, and so many. And therefore, the prevention of diabetes is not to be started in 45 or 50-year-old people, but intergenerationally by improving the health of the adolescent girls, the pregnant mothers, and their young children. And this will provide us a lasting solution, not only to the problem of diabetes, but also other non-communicable disease. And this is what I will say tomorrow in my talk. It's never been too early. It's never been too late, but earlier the better. And what better country than India to lead in this research? Thank you.
Thank you so much, sir. Nothing can be a better example than Abhimanyu. And I fully agree that the learning has to go on till the end of our lives. Thank you so much. So next, I would want to felicitate Dr. V. Seshaya, the father of gestational diabetes mellitus in India. Dr. Seshaya is already a distinguished professor of Tamil Nadu MGR Medical University for lifetime. He is first Department of Diabetology in the country at Madras Medical College. He is founder and chairman, Dr. Balaji and Dr. Seshaya Diabetes Care Center and Research Institute, Chennai. Dr. Seshaya, sir, it's such a proud privilege to have you with us. Please share a few words with us, sir.
Are you able to hear me?
Yes, sir.
My dear friends, Neeru Gupta, nice to see you here after so many years. I'm very happy. Dr. Mayur, he was known to me for more than 30 years, and I'm very happy to be Agni case, one of the pioneers in this country in the field of diabetes pregnancy. I'm happy and honored to be present here, and I'm choosing for this felicitation. I consider it a great honor. I entirely agree with Dr. Yagini. You cannot prevent diabetes in the world, and as he suggested, that fetal origin of other diseases, everything starts from the womb. So we call diabetes fetal origin of other diseases. So I coin the word fetal origin of other diseases and also focus on the fetus for the future. That is the only way. So I'm very happy here in one sense that I'm speaking to the NGOs organization. I consider them as these people as a God's messenger. Because anything what you do in the government or in the hospitals, it is not going to help anybody. Only NGOs should be able to carry the message and spread the message to the world. The only way, as Agni was telling, and I am also totally agree with him, want to prevent diabetes, we must take care of the pregnant woman and check her blood sugar and keep under control. Probably this future generation may be diabetic-free generation. Hope this conference will be able to get this message to the NGOs, to all the public also. Thank you very much.
Thank you so much, sir. Such a proud privilege to be with you, and thank you for being with us, sir. May I have next slide, please? It's a pleasure and privilege again to felicitate Dr. Amrish Mittal, sir, Padma Vibhushan, Chairman and Head Endocrinology and Diabetes, Max Healthcare Saket, New Delhi. Sir, would want to hear from you, sir.
Dr. Nira, he's not there. I think
Okay,
we are
great.
waiting
No
for
problem.
him.
No problem. If he joins, we will definitely would invite him as and when he joins. But meanwhile, let's go ahead with other awardees' names. We understand the commitment and then ongoing work that is there. So we would want to felicitate Dr. Anup Mishra, sir, Chairman, Fortis Hospital Center of Excellence for Diabetes, Metabolic Diseases and Endocrinology, Chairman, National Diabetes, Obesity and Cholesterol Foundation, and he's also President of Diabetes Foundation. Heartily congratulations to Dr. Anup Mishra, sir, for his work and contribution in field of diabetes. Next, please. Next, please. Thank you. We are so privileged to felicitate Padma Awardee, Dr. Daya Kishore Hajra sir, founder, president, Agra Diabetes Forum. He is initiator of APIDS Agra Preventive Intervention Diabetes Study. Thank you so much, sir, for your significant contribution in field of diabetes and making a difference in people with diabetes. Let's hear from Dr. Hajra, sir. Thanks so much to Dr. Hajra, sir. Do we have the next awardee? Immense pleasure to felicitate Padma Awardee, Dr. Shashank Joshi, sir. He's Chair, International Diabetes Federation, Southeast Asia, endocrinologist, Joshi Clinic, Lilavati Hospital, and Bhatia Hospital. It's a proud privilege to work with Dr. Shashank Joshi, sir, during the times. So would love to hear from you, sir. Heartiest congratulations, sir, and for your immense contribution in field of diabetes and even in COVID, what I hear on day-to-day basis. Thank you so much. Dr. V. Mohan, sir, Padma Awardee. He is Chairman and Chief of Diabetology. Everyone knows Dr. Mohan, Dr. Mohan's Diabetes Center, Specialty Center at Chennai. We have so many centers around India, the V. Mohan centers, and he's of academic international repute person. So it's a proud moment, sir, to facilitate you in this conference, sir. Heartiest congratulations. Thank you so much, Dr. Mohan, sir. Let's move on to the proceedings of the conference now. I would want to invite Dr. Mayur Patel, sir. He is Chairman, Chief Diabetologist, Swasth Diabetes Center, All India Institute of Diabetes and Research. Dr. Patel will be delivering presidential address, sharing his experience of 45 years in diabetes care, training, education, awareness, train the trainer programs, creating a workforce in healthcare management. Dr. Mayur Patel, sir, over to you.
Namaskar. National as well as international faculties, esteemed guests, I suppose I am audible.
Yes, sir.
Yes, sir.
Okay. National as well as international faculties, esteemed colleagues and friends. International Conference on Innovations by NGOs in Diabetes Care being held for the first time. The aim of the conference is to know innovations and activities of NGOs working in the field of diabetes. We believe that understanding challenges and collaborating with each other will lift the standards of diabetes care. In turn, it will help millions of people with diabetes. It's a proud moment for the organizing committee and for me personally to see the enthusiastic response to the conference. Participating stakeholders are medical professionals, governmental organizations, NGO leaderships, volunteers, leading national as well as international experts, social and scientific researchers, CSR leaderships, financial institutions, and pharma professionals. On behalf of organizing committee, I extend you a warm welcome. I'm sure that all of you will make this conference a memorable event. Today, I'll be sharing my experience of 45 years in diabetes care. Frankly speaking, narrating 45 years experience in 15 minutes is difficult, but I'll try to justify. Let me share my screen. I'm sharing my experience of 45 years in diabetes care. From the childhood, call it an inspiration or call it inheritance that I had from my parents. I was interested in social activities. The family I hail from strongly believes that service to mankind is service to God. Since 1977, a span of 45 years, I have served through various positions, from National Service Scheme leader to chairman of community projects in various organizations. During undergraduate days, as a founder leader of NSS, we organized various medical diagnostic camps, several Know Your Body camps, and participated in flood and drought relief camps. During residency, we organized 21 blood donation camps, 55 medical camps in rural and urban slums. Some of these places were lacking even basic amenities like water and electricity. Nearly 10,000 people benefited out of it. I am practicing as a diabetologist for last 36 years. In spite of having a busy practice, I have not lost sight of my social goals. Swasthya, where I practice, is a first of its kind, having the state-of-the-art technology, providing all specialty services related to diabetes under one roof. It is unique in western part of India. Our aim is preventing and reverting diabetes as well as other lifestyle diseases by reviving Indian culture, advocating traditional food, meditation, and yoga as a way of living life. 30% of our patients are under control without any medication, and remaining 70% doses are reduced by 30 to 40%. Over 350,000 patients treated over a period of 36 years is a living testimony to our dedication in the field. Our mission is to achieve excellence in clinical care, education, research, community services, and helping needy patients. As a leading teaching institute, we offer various courses to medicos and paramedicos. We impart education to patients and their relatives and masses in general. It is only institute in the entire state of Gujarat conducting basic and clinical research of international standards on diabetes and related complications. We provide a first-class training environment to scientists. We are helping needy patients through our personally raised funds. As a part of community services, we initiated Stop Diabetes program, that is diabetes prevention program in the state of Gujarat. In this program, we train healthcare providers, we train doctors, we train paramedicals, and this trained personnel, they share their experience with their colleagues and train their team members to organize camps. We also train school children. They act as health promotion ambassadors in the community and pass messages to at least 10 families. We also educate people and increase awareness levels. We use different types of media. We have produced low-cost educational material and we distribute it to the public free of cost. With the help of this trained personnel and the education awareness campaign, we identify high-risk people from the community and we screen them for diabetes. Those who are having diabetes and pre-diabetic conditions, as well as those who are at risk but not having diabetes and pre-diabetic conditions, we call it pre-diabetic conditions. We subject all these people to the lifestyle modification. Those who are having diabetes, we screen them for the complications and offer appropriate treatment. If we look at the impact of this project, over a period of 3 years, we trained 1,500 doctors, we trained 4,800 health workers, we tested 41,000 people for diabetes and trained them for lifestyle modification. 8,300 people were screened for complications and they offered the appropriate treatment. We conduct lifestyle modification camp, 2 to 3 camps in a year. In each camp, nearly 1,000 people, they participate. We encourage them to perform yoga scientifically, systematically, sincerely, regularly, without fail, with interest. We ask them to follow healthy lifestyle and encourage them to reduce weight by 10 to 15%. In the year 2003, we organized giant yoga and lifestyle modification camp in a cricket stadium. Nearly 8,000 people participated. We tell everyone that diabetes can be conquered with healthy lifestyle. We also organize yoga teachers training program, which is 21 days residential program. To make people more aware about diabetes, I have written 3 educational books in local language and 100,000 copies have been distributed free of cost. I also contributed in a handbook on diabetes mellitus for healthcare workers. Primarily based upon our experience with Stop Diabetes program, we initiated Conquer Diabetes program. In this program, improving access to diabetes care for the poor through innovative public-private partnership in the state of Gujarat. In this program, we selected 3 model areas: urban slums, rural district, and tribal blocks. Each area is having unique challenges. In urban slum, they have healthcare facilities nearby, but they are not using because they have other priorities in their life. In rural areas, for minor illness, they have to travel long distance for getting the appropriate treatment. And for tribal areas, they don't have knowledge, they don't have literacy, and they don't have even money. In these 3 areas, we train medical officers, we train paramedical workers, and we run diabetes awareness campaign. Diagnostic facilities and therapeutic facilities were made available in the government centers. In a span of 1 year, 20,000 people with diabetes benefited. Those patients, they need expert advice. They were connected to Swasthya with the specialists through internet. So no need to travel long distance. It cuts short time as well as the money. For children with type 1 diabetes, we have Make My Life project. Our aim is, instead of hiding the disease, they should feel confident about the disease. We provide best clinical care, screening, early detection, intervention, and prevention of complications of diabetes at free and subsidized rate. We have, in addition to all these facilities, we provide them psychological, career, and marriage counseling. Due to social stigma, children, especially girls, had difficulties in finding their life partner. Therefore, for the first time in the world, we started marriage bureau, and many children, they are taking advantage of it. As a part of Make My Life project extension, Dr. Yash provides 360-degree support before pregnancy, during delivery, and after delivery. As an overwhelming response, families of newborn male babies, they decided to give name of their babies Yash. Another baby, Yash name was given. In India, amputation of the limb is usual outcome of the diabetic foot lesions. We have developed to save a leg, and we call it Project Shravan. We have developed 10-minute procedure combining medical, social, religious ritual in which anyone from the family can watch and wash the feet of the patient at least once in a week. We believe that with proper care, 90% of the leg can be saved. We have revived the age-old culture of foot care and footwear. International organizations have endorsed that Project Shravan is a cost-effective way of saving a leg. As far as the achievements are concerned for the health system, if you look at the long-term achievement, there is a change in morbidity profile due to NCD in the community, decrease in cost of care, and a better reputation of the health system. If you look at the achievements, patients and communities are concerned, on the long run, early detection and prevention of complications, reduction in mortality, improved quality of life, and reduction in the rate of leg amputations. We have observed that beyond city limits, due to social stigma, within 5 years, most of the children, especially girls, were untraceable. Because of the Make My Life project, we are able to save children, especially girls, with type 1 diabetes and help them to live long, healthy, productive, and cheerful life. We reduce morbidity and mortality in mother as well as fetus during pregnancy, and prevention of diabetes in mother as well as babies in later life. We encourage and train thousands of people for yoga and healthy lifestyle. For our activities, we have received several awards at state level and several awards at national level. Our center is recognized by International Diabetes Federation as Center of Excellence for Diabetes Care and Center of Education. Our center is also recognized as Center of Reference and Center of Collaboration for Type 1 diabetes. Our institute is approved by Gujarat University and affiliated with the University of Toronto for research purpose. These are some of the photos of our activities: giant yoga camp in the cricket stadium, public awareness program, type 1 diabetes children camp, Project Shravan, doctor training program, diet exhibition, drama or bhavai for diabetes awareness, diabetes camp, and school children training. Media also witness and publicize our activities. With the help of doctors and paramedical workers trained by us, we are planning to start new low-cost treatment centers for management of diabetes in every district so that people don't need to travel long distance for getting proper diabetes care. We are planning to establish a resource center for people from every strata can get routine as well as advanced level of care for their disease. We are thankful to all the collaborating organizations and thousands of volunteers from NGOs, associations, private companies, and educational institutions. The way may be cumbersome, but together we'll make it. We believe that clinical management of diabetes has now significantly more options than ever before, but everything will fail if lifestyle is not adhered. Therefore, final message: eat less, eat on time, walk more, sleep well, and
Health
smile.
is not just an absence of disease.
Thanks for
Health
patience
means,
hearing.
the word health comes from the word whole. When an individual human being feels complete, physically, mentally, emotionally, spiritually, that's when health is. When the life within you is bouncing with vibrance, when the life within you is effervescent, that's when health happens.
So let's have the
If we have to build this into a human being, this has to happen at the earliest time in his life. If healthful living, how a human being can live healthy, what he should consume, what should be the nature of his practice, and different aspects of how he should sleep, how he should wake up, all these things were built into our culture in the past, but in the last generation we have distorted this heavily because of certain Western influences which are only about treating the disease, not about creating health from within. Nobody can give us health. Health is our responsibility. This has to be brought into our curriculum, that every child in this country should learn how to generate health for himself, not wait for a healthcare system to help him later in his life, but he must become the main healthcare provider for himself, because health can only be organized from within. The earlier it is introduced, the better it is. It is important that we as a nation, all that we have is a large mass of people, these 1.25 billion people. If we have a healthful, focused and inspired population, we as a nation can become a miracle. If we have an unhealthy population, which will naturally be uninspired and not ready for action kind of population, we can become the greatest disaster. Right now, India is moving towards this disaster rapidly. It is time to turn it around by bringing healthful ways of living at the earliest point in one's life. So the school systems, the education system has to introduce as to how a human being can live healthy. This has to happen to this country because large-scale movement towards ill health is happening, and it is something that we can ill afford. It is not something that this nation can handle. The richest nations in the world, like United States of America, their health bills are sinking their economy. We need not move in that way. Right now, we have a youthful population, but not very healthy. It's time we bring health and manifestation of health into our school systems and make it work for us as a nation. There are two types of ailments. One is infectious, another is chronic. Infectious diseases are those which happen because of an external invasion. An external organism invades the system and causes certain trouble, which has to be dealt with medication. But chronic ailment, what it means is, our own body is creating the problem. The disease is being manufactured in the system. This is common knowledge that every cell in the body is programmed for health. But why would it cause an ailment? Something very fundamental has gone off balance, or there is a certain level of misunderstanding within the system itself that instead of creating health, it's creating ill health. And we may be incubating this misunderstanding in so many different ways. When I say misunderstanding, not misunderstanding or understanding of your mind. On the cellular level, on the elemental level, there is a misunderstanding. So these things can be altered just by bringing about a certain balance in the system, activating a certain level of inner energy and accessing the innermost dimension of who you are, which is the very maker of this body. The very maker of this body is within you. When this is so, if there is a repair job to be done on this body, should you go to the manufacturer or to the local mechanic? Because the problem is being generated from within, it is very important that an inner solution is found for this. The inner engineering process is just about this, that you find access to this deepest dimension of intelligence and competence within ourselves, which is capable of generating this body, creating this body from what kind of material? If you eat a piece of bread, it turns into human system in a few hours' time. So there is that dimension of intelligence and competence within this, if only you found access to that. Health is not even something that you have to struggle with. So finding access to this has many steps to be taken. The simplest step that one needs to take is that one becomes open to the possibility, first of all. Thinking and understanding that for all the problems that I have, there is an external cause and there is an external solution is a very foolish way to approach the whole process. For ailments, chronic ailments like diabetes, hypertension, cardiac ailments, asthma, allergies, obesity, eating disorders, and many of these kinds which are all essentially generated from within, all these things can be quelled from within if only we are willing to pay a certain level of attention to the innermost dimension of who we are. Inner engineering is a powerful process of approaching the inner core of who you are in a scientific manner, and this is definitely a way to create a healthful life. Manner, and this is definitely
Great message. All our problems are own invited
a way
problems,
to create a
and we have
healthful
to take charge of ourselves. No one can
life.
do good to us, rather we ourselves. Let's move on to session 2 now. That is unmet needs in diabetes care, expectations of different stakeholders from NGO groups. And for this, I would want to invite our chairpersons, Dr. B.D. Mankad, Professor and Head, Department of Medicine, PJ Medical College, Ahmedabad, and Dr. Arun Saxena, Senior Consultant Physician and Diabetologist, Vedika Hospital, Ahmedabad. Over to you, Dr. Mankad and Dr. Saxena.
Thank you, ma'am. Thanks for your warm welcome. And we are literally feeling very proud and privileged to have this conference of diabetology, one of its kind, first time in the Gujarat and India. I would like to invite Dr. Sushil Patel, who is a consultant diabetologist at Aksar Diabetes Center, Baroda, and he will be speaking on expectations of our diabetologist or endocrinologist. Over to you, sir. Dr. Sushil Patel, sir.
Thank you, Dr. Arun Saxena sir, and thank you, the team. Being a part of organizing team, I also like to welcome you all once again on this beautiful conference that is first time organized, first of its kind conference that which is not focusing on all the drugs. We are not discussing the drugs for the first time, but we are discussing something else, which is already going on in the entire India and entire country in the world, but we are not aware. So this is the platform where we try to give some knowledge to all the NGOs, all the other workers who are willing to do some work for the diabetes care, and that which is for that this scientific program has focusing on all the drugs. We are not any person who is working in the NGO for the first time, who are running NGO, or those who are willing to work for already going on in the entire India and entire country and the world, but we are not aware. The first scientific session is that expectation of different stakeholders, different clinician from the NGO, so that what we actually want as a clinician, we can serve, we can ask them, and they can have some insight about these things, and afterwards they can actually apply these things in the field if they are not doing, or they will get some more insights about their own work. So my topic is that expectation of diabetologists from the NGOs. We all know that India is the second largest in the number of diabetic patients in the world. Currently, there are more than 77 million people of diabetes in the world. But the major problem is that only 40 to 50% of these people are diagnosed. Maybe in the urban area, there are 50% are diagnosed, but in the rural area, which is a bigger part in the country, there are only 40% of the patients who are diabetic, they are diagnosed. So if we say that in our routine communication, we routinely say that every second home is a home of diabetic person. But if this undiagnosed patient comes in the picture after the diagnosis, then we can think of that what will be the number. So the problem doesn't end here. That problem is really starting from here, that 70% of these 40% are actually on the treatment. So that 60% are undiagnosed, but those who are diagnosed, 70% are taking some kind of treatment, either allopathic or homeopathic or Ayurvedic or any kind of treatment. So remaining 30% of diagnosed patient, rather than even being the diabetic diagnosis, they are not taking any kind of treatment. So there is a huge gap. 77 million people are there with the diabetes, but there are only 21.5 million people are there, those who are actually taking the treatment. And again, the scenario is not ending over here. The scenario is like that only 30 to 40% of these people are having the HbA1c of less than 7. That is a target. So what we can see is that more than 60 million people are there where the blood sugar is not at all in control. So here is the first thing what we as a diabetologist expect from each and every one, not only the NGO, but each and every one in the world, that these people should get the diagnosis of diabetes done. They should be tested, and after the testing, they should be came in the picture of any kind of doctors so that they get the treatment properly. The first thing what I would like to start with the prevention of diabetes, where the NGOs can have the major role. So the first and foremost thing is the role of the healthy lifestyle. Majority of things what we had observed that NGOs are more behind the uh, uh, what we can say is the insulin provision or the glucometer provision, or maybe the complications of diabetes treatment. But the role of healthy lifestyle in the management of diabetes is as much important as the medicines. So the focus of the diet, exercise, and the yoga that should be done by the NGOs also, as well as the doctors. No age is barred with the diabetes. We are seeing the type 2 diabetic patient at less than 20 years of age also. So the type 2 diabetic patients can be diagnosed at lesser ages also. So what we have to focus is that role of diet, exercise, and the yoga, even in the younger age, is as much important as after the diagnosis of diabetes, just to prevent it. The special focus should be on the pre-diabetic patients. There are more than 40 to 50 million people with the pre-diabetes in the India, and these are the people they are ready to convert into the diabetes maybe in the next 5 to 10 years. So this is a special population where we have to focus on the prevention of the diabetes. But again, to diagnose this patient as a pre-diabetic, we have to test them. Otherwise, they will not at all come in the picture of any person, either the NGO or the doctors, and they are undiagnosed about their even the pre-diabetic status. So these are the four areas, major four areas where the prevention of diabetes should be worked. The screening of the diabetes. All the persons with the risk factor can use the idea or should be tested with the diabetes. We all know about the risk factors like the advancing age more than 35 years of age, then the obese patient or the patient with the other comorbidities like the hypertension or the dyslipidemia or the heart disease, and there are so many other factors also. So a simple tool like IDRS risk score, that is Indian Diabetic Risk Score, where you have to focus only on the age or the family diabetes and the waist circumference in the male and female. So this is the factor where you can simply calculate the risk of the patient or the person, and after that you can screen them or test them for the diabetes. Family members of the diabetic patients. This is the most important part, and this should not be missed for the screening of diabetes. Many of time when we organize the camps, what happens that the patient came for the sugar testing along with the family members, and when we asked the family members to taste for that blood sugar, they said that, sir, we don't have any kind of problem, we just come here along with our family members because they are diabetic, we are not diabetic, so we even doesn't want to taste for the diabetes. But these are the highest risk of for diabetic patients as being a family history of diabetes. So these people should be encouraged for the testing of diabetes, and they should be in our loop for the uh, sugar testing and the opportunities for the testing. And the opportunity screening is the most important thing. Those NGOs who are running the hospitals or those NGOs who are working in the other field than the diabetes, I request them all that for the opportunistic screening, what that means is that if the patient is coming with a recurrent fever, if the patient is coming with a recurrent urinary tract infection or the sudden weight loss, any other kind of illness, and you think that this patient is also at the high risk of diabetes, and you just take blood sugar for this patient either from with the glucometer, or if you are asking that patient for to go for some laboratory test, then you just add one sugar report also in that. So this is what we call as the opportunistic screening, and this should be done for the all kind of patients or where you are thinking that this patient is at high risk of diabetes. So screening of the diabetes complication. This is again most important thing in the diabetes management. Why? Because for all kind of diabetic patients, this is important thing. And mostly what happens that our type 2 diabetic patients, they are checking their sugar values, maybe fasting, postprandial, HbA1c also, or the random blood sugar. They are even monitoring their sugar level at home, but they are not monitoring their organs. So this is the most important part in the type 2 diabetic management, because the patient doesn't die of the type 2 diabetes itself, but it dies with the type 2 diabetic complications. And the complication once happen, then it will be the difficult to manage. If the patient has lost his eyesight, or if patient has to amputate his limb, then afterwards, or if the patient's kidney fails, and afterwards the life is miserable. So special tests are there that should be done once in a year. Fundus examination, that is eye test up, and the food examination, biothiometry, or the ankle brachial index, that is the blood circulation in the food, or the food pressure scan there if there are any abnormal pressure point in the food. These are the important reports for the food, and the serum creatinine level, or if there is any protein in the urine, that is from the urine albumin creatinine ratio. That is important reports for the kidney. In some kind of patients, you can approach for the ECG, TMT, or the 2D echo for the heart condition. So all these reports are required for any type 2 diabetic patient at the time of diagnosis also, and once in a year afterwards also. So this is a major problem with our community in the India, that the people, even the doctors, they are not focusing on these things. These tests are costly. Yes, it may cost around 3,000 to 4,000 rupees at any part of the India. But problem is that these tests are costly, and that's why the patients are not going for this test. But we have to understand, and you can educate the patient that this will prevent them for the further complication in the future if they can diagnose this complication at very early stage, and that can be managed at very early stage, and then they will not get their organ damage in the future. So this is a major thing. Another thing is that spreading the awareness about the diabetes. First and foremost thing is the signs and symptoms of the diabetes. So there are so many signs and symptoms are there about the diabetes, but the problem is that only 70% of the patients are undiagnosed, are not having any symptoms of the diabetes. Only 30% of the patient, and even these symptoms are mild. So majority of time, what happens that if the patient comes with the sugar value of 400 or 500, and is that, sir, we don't have any kind of problem, so this report is wrong and we don't believe on this report, so we don't have the diabetes. Or they are in the shock that rather than being asymptomatic, they are having the sugar values of 400 or 500. So we should give that proper awareness in the community about the signs and symptoms of diabetes, and even the asymptomatic nature of the diabetes. Awareness about the diet and the exercise. There are so many myths are prevalent about the diet and about the exercise in the community. Like if you are eating so much sugar, then you will get the diabetes. Or if you are doing this kind of exercise or that kind of exercise before food, after food. So proper knowledge about the diet and the proper knowledge about the exercise for the prevention of diabetes, and those who are diabetic, for the management of diabetes, it is a very much important thing. Awareness about the complication of the diabetes. This is again important. Like the people are only checking the sugar values, but they are not screening the for the complication, then it will be the difficult one. So the awareness about the complications are also important. Quit bad habits like the tobacco, smoking, and the alcohol. There are many NGOs who are working for this uh, bad habit things, like but the diabetic NGO, they are not focusing on these things. But if you are not asking that patient to control about the tobacco smoking or the alcohol, then there is no much benefit of diabetes control, because this all the things, this all the habits, bad habits will damage that organs of the patient, or the diabetes is damaging. So breaking the myths about the diabetes in general. Like there are so many myths are prevalent about the insulin, so many myths about the diet, exercise, and even the medications. Like the allopathic medicine will harm your kidney, or they are not safe for your body. There are so many Ayurvedic medicines. There are so many cures about the diabetic. You can read on the newspaper or even the social media. So you have to, being a present in the community, you should make the people aware about the myths of the diabetes in general, and general awareness about the COVID and diabetes link. So people with the diabetes, they are afraid of the COVID, because all of us right now know that the diabetic patients, or those who are uncontrolled, they are at highest risk of getting the diabetic COVID complications, and they are even at the higher risk of getting the death from the COVID-19. But similarly, at the same time, these patients refrain to go to the hospital or even do a teleconsultation with the doctor, even though they are uncontrolled, because they are afraid that when they go to the hospital, then they will get the COVID-19 and they will be at trouble. But they doesn't understand that even being at the home, they are at risk of COVID-19 and maybe at the complications. And we had witnessed so many patients, like those who are not even going outside the home, even if they get the COVID-19 and they get the serious. So during this era where we are predicting a third wave in the near future, so all the diabetic patients should be tested for the diabetes, and if they are uncontrolled, then they should be treated well with the doctor, either in person visit or with the teleconsultation. So what are we expect from the NGOs in the management part? So first, most important thing is the self. Being an NGO person, you should make the people aware that the self medication for the diabetes is always harmful. If I had prescribed some medication for one person, then that medication has brought down the sugar values in very good control, then that person will ask all the other family members or his friend circle that this medicine is good, you can take this. The people directly go to the medical store or even the Ayurvedic store and they are purchasing some medications from there to control the diabetes, and this is not a safe game. So this should not be done. Management of hypoglycemia. This is the most important thing what the NGO should focus on in the management of the diabetes, because the hypoglycemia is very much important in the part of the management of diabetes. The hypoglycemia is actually an alarming condition. The patient may get serious. They are not aware about the hypoglycemia management and how home. That is the most important thing. So whenever you are coming across any patient with the hypoglycemia, and it should be treated, it should be educated well. When to seek the early doctor's consultation. This is again the more important thing in the community, that whenever you are seeing a one patient and the patient is having the uncontrolled sugar, then there are all the excuses that is from the patient, like I had eaten so many mangoes in this season, or I have attended one marriage session maybe 10 days or 15 days back, and that's why my fasting and PP2BS at this point of time is high. So there are so many excuses are there on the part of the patient. So you have to be in a position to educate this patient that this is not so. You should consult a doctor, and even if you are facing any kind of complication about the diabetic and that symptoms of the complication, then again that the patient should seek the early current doctor's consultation. Awareness about the compliance with the treatment. Many times what happened that when the patient has visited a doctor, what happened that that patient is in the many some symptoms are there, or the signs of illness is there, like the weight loss or the weakness or the leg pain or the calf muscle pain is there, and after the getting treatment her or his blood sugar is in control, then what happens is that his sugar level will be controlled and his all the problems has been gone. So the patient is now in the opinion that now my diabetes is cured, my sugar level is in normal, so I should discontinue the medicine or I can reduce the dose of medicine. So it should be discouraged at the community level. And the importance of the regular follow-up with the doctor. Again, this is why this is important is that because the doctor will educate this patient about the diet or the exercise or the correct way of the lifestyle and correct way of the taking treatment or the medicines. So even if the patient has been diverted from at any point of time in his lifestyle or maybe they're taking the medicine, then the doctor can focus it again and that patient can be well managed. So regular follow-up with the doctor is almost important. Glucometer strips, medicines, and the insulin accessible to the patients. There are many parts in the India where the patient may not get the insulin or the medicine. In the accessible means that either the area doesn't has a medicine, or even if the patient is not affording this medicine or insulin or the glucometer in the strip, particularly the type 1 diabetic patient. So in and patient that in the NGO, even the glucometer and the strips, help in the diabetes complication management. Again, the diabetes management is a simpler one, but the complication management is a costlier one, and it is a time-consuming thing. So preventing the diabetic retinopathy and the treating the diabetic retinopathy, treating the patient with the diabetic foot ulcers, treating the patient with the diabetic kidney disease. So these all the things are very much costly things. And what I had witnessed in my NGO, that is AIIDR, where I'm working as a project manager, when we go for at some places for the donation or the fundraising, what we had observed that we are not aware about these diabetic complications and we do not want to give you fund for this diabetic complication. And for being there for the same reason, the patient may not get the enough treatment. So health in the diabetic complication management is again important. Specifically, if I'm saying about the type 1 diabetes, and then make insulin glucometer in the strips that is accessible to the patient, and break the myths about the insulin. There are so many myths about the insulin prevalent in the mind of the type 1 diabetic patients themselves or their parents. Like if the patient has started the insulin once, then it should be lifetime. Yes, type 1 diabetic, that patient should be on the insulin for the lifetime. That should be understood by the patient because it is not a habit, but it is a necessity. The second thing, insulin will harm his body, or there how many holes a person can make in his body with the insulin needles. So all these things should be, these myths should be broken in the mind of the patient and their parents. Proper insulin injection technique. This is most important thing as part of the type 1 diabetes management is concerned. Why? Because that insulin injection majority of time, maybe around 80 to 90% of the patient, they do not rotate the injection sites. And what happens that after a few years of injecting the insulin on the same site, there may be the lipodystrophy at the injection site, and this insulin will not work properly. There may be hypos and the hyperglycemia according to the injection site what the patient has chosen. So insulin injection technique is the most important to teach to the patient at the community level itself. Importance of the sugar testing. This is most important. For the type 1 diabetic patient, maybe 4 to 6 times in a day. And again with the sugar testing, with the carbs counting, if the patient is educated one, then if he or she can do carbs counting, then it is again a most important thing in the type 1 diabetes management. What about the other aspect of the type 1 diabetes, like the psychological counseling to the patient and to the parents at the time of diagnosis? The career counseling, what happens, what should be chosen as a career after the 10th standard or the 12th standard or even after the college, whether they can go in the field work or whether they should choose for the office-based work or they should choose not to work. And the marriage counseling that Dr. Mayur Patel has beautifully shown that he has started the first marriage bureau of the world for the type 1 diabetes patient. But being a community members, you can also counsel the patient and the family members about the marriage of type 1 diabetic children. The gestational diabetes, that is again important thing. Importance of the sugar testing during the pregnancy is most important thing. What happens in the rural area that majority of time the patient has not been tested. In the first trimester, it should be recommended just to check that the patient doesn't has diabetes pre-existing. If the patient has diabetes pre-existing, then it should be tested during the first trimester. The gestational diabetes is not happen in the first trimester, but there are so many misdiagnoses of the diabetes. So if the pregnant woman is there, then along with the other reports, the sugar testing should also be done in the first trimester. And the second and the third trimester is the ideal thing to check for the sugar testing. Importance of the sugar control during the pregnancy should be explained to the pregnant woman. Breaks a myth about the insulin treatment during the pregnancy. Again, the same things will happen with the pregnant. It will harm themselves and even their fetus also. Prevention of diabetes in the future. This is the most important thing, and it is missing as part of the community, even in the hospitals also, because these are the women who are at the highest risk of getting the diabetes in the future. But after the birth of the child, they are busy with the child care, and what happens that they will be neglecting about their own health, not check their sugar level maybe in the 6 months or 1 year, or even the 5 to 10 years. Afterwards, they are ignorant about their health itself, and they will get the diabetes in the future. But it can be prevented also, it can be delayed also. So role of the diet and the exercise in the pregnancy, again, it is important thing because in the India being a culture, there are so many sweet food which are offered to the pregnant woman, but it should be discouraged in the pregnant woman with the diabetes or the gestational diabetes. There are other sectors also, like the advocacy with the government, wherever needed, it should be done. Like this is a topic of discussion, the panel discussion in the future upcoming days, so I'm not going in the detail. Divert the CSR for the healthcare specifically to the diabetes, and even the CSR not in the healthcare, because whenever we are focusing on the diabetes, what I and I'm sure also said the CSR giving companies, they are not focusing on the healthcare and particularly the non-communicable diseases, particularly the diabetes, because being an asymptomatic disease, they are not feeling that it is a need of the community. So the majority of CSR is going towards the education or maybe the nutrition of the patients, but they are not diverted this for the prevention of diabetes or the treatment of for type 1 diabetes children or even the treatment of the diabetic complications. So wherever possible, we can do advocacy with the government, we can do advocacy with the CSR funds or India, and we can divert that fund specifically for the diabetes. So these are the some factors, some things where we should work. So focus of our work should be, the aim should be the early detection of diabetes and management of diabetes and management of its complications. So thank you again. Thank you very much. Thank you all of you for your kind listening, and thank you again to joining us over here. And I am hopeful and I'm sure that you will get more and more knowledge in the these 3 days about the
very informative talk from Dr. Sushil Patel. Thank you very much. Hello, am I audible?
Yes, sir, you are audible, sir.
Yeah, there is a question from Dr. Tanmay for Dr. Sushil Patel.
Sir, we can take a question at the panel discussion.
Okay, fine, no problem. So we will move on to our next session, and Madam will introduce our next speaker.
Thank you, Dr. Saxena and Dr. Sushil. It's our honor to have Dr. H.R. Nagendra sir with us. He is President, Vivekananda Yoga Anusandhana Samasthana Vyasa, Chancellor Swami Vivekananda Yoga Anusandhana Samasthana University. Sir, it's a proud privilege to have you with us. We want to hear your words of wisdom. Look forward to hearing from you, sir. Dr. Nagendra sir.
Over to you, sir. Dr. Nagendra, sir. Can you please confirm it whether our audio is audible to him or not? Hello?
Yes, Dr. Saxena, we are connecting with him.
Dr. Neera, you can invite the next speaker while Dr. Nagendra sir is getting connected.
Sure. So, Dr. Saxena, please go ahead with the proceedings. We'll intervene as and when he joins back. Dr.
Sure,
Saxena, yeah.
Yeah, sure, man. Sure, man. Can we have the slide for the next speaker, please? Yeah, so our next topic is expectations of dietitian from NGOs by Dr. Meenakshi Bajaj. She is a former dietitian and coordinator, Institute of Diabetology and Academy of Clinical Nutrition, RGGGH, and Madras Medical College, Chennai. Over to you, Dr. Meenakshi Bajaj.
Thank you so much, sir. Am I audible, sir?
Yeah, sure. Yeah.
Is my screen also visible?
Visible. Yeah.
Yes, sir. At the outset, I am grateful to Dr. Yash Patel, Dr. Mayur Patel, and Swasthya Diabetes Care Center for the opportunity to be part of this August conference. Now, the topic given to me is expectations of a dietitian from an NGO, combination of diet and exercise in GDM. You know, when we talk of GDM, we should only remember one term. I think it was a beautiful presentation by Dr. Sushil, so it will be a little bit of an overlap. But when we talk of GDM, we need to remember that if we prevent one GDM, we prevent the transgenerational risk of non-communicable disease. So usually we talk not only of macrosomia, we also need to remember low birth weight, because low birth weight, the lower the birth weight of the infant and the increased risk of development of non-communicable diseases because of fewer beta cells, fewer nephrons, fewer neurons, and the cascade of events fall in place. So when I talk of macrosomia, which is my biggest worry when it comes to complication of gestational diabetes, poor glycemic control during GDM, my sugars are high and I must worry, since within my womb, a child I carry must reduce the sugars before it's too late, or baby will end up being high birth weight. For a layman, it's easy for the person to understand when I say sugar baby or large baby or big baby, because that is easily visible to the naked eye of a layman. Obviously, we do understand that there could be, you know, a host of other complications like congenital anomalies, and the list just goes on. I don't want to go into those details. But as Dr. Mayur Patel very, very clearly said, you know, it is important that we need to, you know, prevent and control as well as manage diabetes. But the cornerstone is lifestyle management. If lifestyle management is not adhered, we may not be able to achieve our goals. So when we talk of gestational diabetes, we have the DIPSI guidelines talking to us about universal screening. I'll be going through a small story of a mix of ground reality and evidence-based science for the NGOs to understand that how nutrition is important when it comes not only in the prevention and management of GDM as well as the prevention and management of type 2 DM. So all women with GDM should receive nutritional counseling by a registered dietitian whenever possible. And lifestyle therapy for GDM reduces or results in a lower incidence of reduced birth weight, large for gestational age, and preeclampsia. So we understand that once anybody is diagnosed with GDM, she needs to be initiated on medical nutrition therapy at once. I'll take you down the memory lane for the past 49 years. The story begins in 1972, and I wouldn't say it ends, but at least we have the present data with 2021. We had a lady by name Mrs. X. She was 26-year-old female. She was 5 feet only. I want to say it in inverted commas. Her weight was only 34 kgs. So as per the BMI, she had a BMI of 15.11, which means she was severely undernourished. Now, fortunately or unfortunately, this lady, Mrs. X, is an educated professional living in an urban city. Not that she had any dearth of knowledge or access to healthy food, energy dense, as well as nutritionally dense food. She had the qualification and the income in order to, procure nutritious food. But what was her story? Her story was in 1972, she delivered a female child. That was her first pregnancy. And if you look at the picture in 1974, look at her picture at 1974, I think she must have gained about 1 or 2 kgs. She must be about 36 kgs only in 2 years' time. And the first pregnancy was she delivered a 1.4 kg female. It was a term child. She did not have any gestational diabetes, any complications. Her biggest complication was poor knowledge, poor nutrition knowledge. She herself is a qualified professional with a B.Ed and a principal of a particular college in an urban city. Okay, what was her problem? She was eating only dry chapatis and pickle throughout her 9 months of pregnancy. Okay, now she delivered this 1.4 kg female, and this female was born at home, not because of complications. It just happened that she was born at home, and the midwife, as soon as she did the delivery of the little one, she just left the premises saying, maybe this child may survive or no. And after a week, she came back to see whether the child was alive or not. Thankfully, the child was alive. Now, after the child was alive, we go through the history of this female child who was born, who was 1.4 kgs. Remember, she was born with fewer nephrons, fewer neurons, fewer beta cells. When she became pregnant, she was found to have gestational diabetes. Now, when she was found to have gestational diabetes, she was put on insulin, small dose of insulin. She went into recurrent hypoglycemia. Thankfully, she had access to nutrition. So she followed a split meal plan therapy throughout a pregnancy and delivered a 2.9 kg infant. But when the little one was born, the child had neonatal hypoglycemia, 39 milligrams per deciliter. So the child was handed over to the mother after about, say, 12 hours, and the child had mild lactose intolerance, secondary lactose intolerance. Now, this baby who was born, who was 1.54 kgs, after she delivered, she was GDM during her pregnancy. And till today, after 14 years or 13 years of her delivery, she has gained about less than 12% of her usual body weight. So thankfully, we know that when somebody gains more than 10% or 20% of their usual body weight post-pregnancy, they land up with type 2 diabetes as well as other complications walk in. So till today, after 13 years of her delivery and total age being 49 years, she's still a non-diabetic and non-hypertensive. Now, what about her sister? Now, this lady, Mrs. X, delivered, she had a second pregnancy after 2 years. She delivered a 4 kg female now. In contrast to the first pregnancy, which was 1.4 kgs, second pregnancy was 4 kgs. And during those days, 48 years ago, DIPSI was not existing probably. It was still working towards existence. It did not initiate the cause of universal screening. So this lady missed her diagnosis of gestational diabetes. And now what happened? She was pushed by her in-laws to eat not nutritious diet, thinking energy dense diet, lot of malai, lot of ghee, lot of cream, lot of milk, lot of nuts. That sort of a diet went in, which in turn showed that she was GDM and she delivered a macrosomic baby. Now this macrosomic baby, when she grew up, she became gestational diabetes with PIH. Unlike her elder sister, she did not follow medical nutrition therapy. Unfortunately, because of traditional religious, certain taboos in a certain sect of the community, she did not follow either insulin nor management for her PIH, because thinking that if she takes insulin, the myth that if she takes insulin or she takes tablets for her blood pressure control, she will ruin her pregnancy. So she was not on medical nutrition therapy, not on any anti-diabetic agent like insulin or medication for her PIH. She delivered a preterm infant who was 4.2 kgs. And once again, that preterm infant was lactose intolerant. And this second sister gained more than 30% of her usual body weight and turned up to be a hypertensive and a diabetic in 3 years post-pregnancy. So this entire story, this is not a false story. This is a true story dating 49 years. Now I will share the evidence behind this. We know that with maternal malnutrition, iron deficiency anemia is also a marker of insulin resistance. So probably Mrs. X had iron deficiency anemia and she was GDM, not diagnosed in time, and the daughter she delivered did not follow MNT, and today's date she's type 2 DM and hypertensive. So when a maternal malnutrition exists, she is going to deliver a low birth weight infant. This low birth weight infant is going to grow up and going to land up with gestational diabetes. And when this low birth weight infant is not fed protein well enough during her 0 to 2 years of age, or going to land up with a stunted growth, short stature, we have evidence to tell us that women who have had a short stature are more likely to develop gestational diabetes. That is one end of the other spectrum. The other end of the spectrum is if she's going to have poor glycemic control, she's going to land up with a macrosomic baby. And this macrosomic baby, when the baby is going to grow up, she's going to be at a high risk of non-communicable diseases. Now, I'll share a little bit of evidence behind this. We have to understand that where the NGO needs to work with us. We know that the evidence tells us that when a patient is having B12 deficiency and you're going to push folic acid without addressing the B12 deficiency, the incidence of gestational diabetes and type 2 diabetes is going to be on the higher side. The child which is going to be born to such a mother who is having B12 deficiency is going to be fed only with folic acid and not correcting the B12 is going to deliver a small, thin, fat Indian. And we have also a lot of evidence to tell us that you follow a low GI, low GL, more of fiber in the diet, which will reduce the risk of gestational diabetes. Also, there is some recent evidence to tell us that when you push in vitamin C rich foods in your diet. It could be the simple amla, it could be the guava, it could be the tomato, it could be the capsicum. All of these are low in GI and GL. They help to reduce or protect the pregnant women from developing gestational diabetes. And as I mentioned to you, Mrs. X was eating a lot of ghee, makhan during her second pregnancy. Not only did she have GDM, because suddenly she was exposed to too much of calories, and unhealthy calories like ghee, makhan would increase the risk of macrosomia in the infant. And today's date, we know that a lot of diabetic population are exposed to artificial sweeteners, which not only lead to gut dysbiosis, poor glycemic control, but also if you look at the babies in utero, they are at risk of overweight or obesity at the end of 7 years. And worst but last on the list would be if the GDM mother is not counseled on that there will be delayed lactogenesis. If there is poor glycemic control during pregnancy, there will be delayed lactogenesis 1, lactogenesis 2, which means the production of milk is going to get delayed, not to get disturbed. Pull in a lactation consultant also inside to emotionally counsel the patient that she will be able to nurse the baby. And we have evidence to tell us that breastfed infants do much better than formula-fed infants. So this is important concept which needs to be kept in mind. And another important thing is those who are overweight or obese prior to pregnancy, there is a delay in lactogenesis there also. And obesity and overweight with GDM further delays lactogenesis. Women who have had GDM are more likely 7 times to develop type 2 diabetes. They are likely to develop metabolic syndrome, chronic kidney disease. So what is my expectation as a dietitian? I would say in Tamil Nadu, we have a program called NCD Prevention Program developed by the Tamil Nadu Health Systems Project, wherein they provide a platform for training the trainers. So I would say develop, implement, monitor the vaccine to prevent GDM. What is the vaccine to prevent GDM? I'll tell you in the next slide. So we need course content, we need booklets, we need podcasts, YouTubes. There is a beautiful concept of Beti Bachao, Beti Padhao. I would say Beti Bachao from GDM, and she in turn will prevent the transgenerational risk of non-communicable diseases. Create modules on awareness of primordial prevention, facilitate behavior change, prevent maternal malnutrition, iron deficiency anemia, folic acid supplementation in absence of B12 deficiency has to be brought in awareness. Screen for anemia, different types of anemia, awareness on iron inhibitors, spacing calcium and iron, and stepping up vitamin C in order to improve iron deficiency anemia. Screen for PCOS, overweight, obesity on war footing in schools and colleges to prevent macrosomia. Catch them when they are young. Create apps for nutrition counseling at doorsteps with qualified professionals. Join hand with the network of professionals of food and nutrition and ensure that there is no maternal malnutrition. And physical activity, obviously, when it comes to gestational diabetes, it's a special area by itself. Unless it's contraindicated, we need to teach them how to go about with it so that it is safe for the pregnancy. And role of the counselor is at the clinic and in the community. Unless the NGO understands the risk factors as very beautifully presented by Dr. Sushil Patel as well as Dr. Mayur sir, we can prevent one GDM and you have reduced the transgenerational risk of NCDs. Power of nutrition as a most powerful vaccine to prevent gestational diabetes. Oh God, give me food which does not cause any disease, but also gives me strength. Thank you for your patient listening.
Thank you so much, Dr. Meenakshi. It was a pleasure hearing you. Valuable thoughts indeed. Dr. H.R. Nagendra, sir, we welcome you. It's a great honor to have you with us. Dr. H.R. Nagendra, President SVASA Bangalore. Sir, we look forward to hearing your valuable thoughts that how NGOs can contribute to make a difference in lives of people with diabetes. Over to you, sir, Dr. H.R. Nagendra, sir.
Thank you very much. I congratulate you for organizing this wonderful conference to see how we bring different stakeholders on a common platform and see that we bring the solutions to diabetes. My dear brothers and sisters, you'll be happy to know that Swami Vivekananda Yoga Anusandhana Samsthan Yoga University is devoted to take care of this diabetes with the aspects of using yoga as an adjunct to the modern medical system. And 3 years back, we had a pan-India survey that we did to find out the prevalence of diabetes in different parts of the country. In all the states, we had about 2.5 lakh people whom we scanned and found that the incidence of diabetes in the urban areas, in the rural areas, in different states vary quite considerably. And probably you might have heard that Dr. Mohan, who is an authority about this diabetes from Chennai, he had found over the last 10 years, the diabetic population has started increasing tremendously even in the village areas. Earlier, it used to be about 3 to 4%. Now it has come although 10 to 12%. And similar things also is found by us. And the prevalence has started coming up in a very big way. So that is the first thing that we did to have a complete database of what is happening in the country. And in all the states, 30 states, we scanned and we had the randomized trial to give them the yoga practice for about 3 months and see how they can improve. Now, out of this massive work that we did with the help of Ministry of Ayush and the Ministry of Health and Family Welfare, the entire team of volunteers, nearly 150 of them scanning around the country, we finished the entire survey within about 3 months. And that is the first record that took place. Then we analyzed the data and given huge number of inputs as to how the diabetes is spreading throughout the country. And out of that, we have now published nearly 40 research papers in reputed journals. And the American Diabetic Association 2 years back honored our Dr. Nagaratna, who is at the base of this entire work, saying that this is the best research for the year. And that shows that the work can be done in our country on a fast track. Normally, to take care of this type of survey in nearly 30 states with 2.5 lakh people will take about 10 years or 5 years to do that. But we have done that in about just 3 months, thanks to the large number of volunteers that our Indian Yoga Association were able to provide. And they go almost house to house in the villages, in the urban areas to collect the data and put them into things and analyze the data. So after 3 months, what we have found is that the people have improved quite a lot in terms of the diabetes in just 3 months. There is a significant difference between the control and the experimental group. It's an RC trial that we did. And this is the one that we have been able to publish in various things. And I can share with you all our research papers and others, and you can go through the details. So what is the main aspect that yoga addresses? In diabetes, most of you know, stress plays a very important role, and stress is an immunosuppressant factor. And when the immune system is suppressed, two things can happen. One is it loses its capacity, and another thing is has a distorted perspective. According to yoga, we say there is what is called as a viparya. Viparya is a wrong notion that we have. Seeing a ghost in a post, seeing a serpent in a rope, seeing the whole world has become yellow in jaundice. These are all viparya. Viparya means wrong knowledge. Patanjali defines what is viparya. Viparyaha mithya gnanam atadrupa pratishtham, he says. And seeing the wrong things with the wrong notion. And immune system has a wonderful capacity to decipher who is a friend, who is an enemy. And this clarity is gone when it is suppressed by the stress factors. And therefore, it thinks that enemy is a friend and friend is an enemy. What happens in diabetes is to think that insulin is an enemy. So when we take our food, the sugar level goes on increasing in the bloodstream. It sends signals for the beta cells of the pancreas to send the insulin. promptly the insulin is produced in the beta cells and it comes to the mainstream and the sugar level is maintained in the range that has to be maintained. But when it goes into a distorted perspective, it thinks that insulin is the enemy and the insulin is coming out of the beta cells in diabetic patient, then it thinks, hey, you enemy, you are going there. I will not allow you to go into the bloodstream. It creates an autoimmune barrier with a high insulin resistance. And the insulin is not available to the bloodstream. Sugar level is increasing. Again, it says, the sensor say, come on, what has happened? 10 seconds back, 15 seconds back, I have sent the message that you should send the insulin, but you have not sent. Again, the beta cells will reduce more and more insulin and start sending. And the autoimmune barrier doesn't allow to read that. So this is how the immune system gets completely confused. And why does it happen? Stress. Stress is not merely physical. No doubt a physical trauma can cause stress, a big loss in the share and all this, what is happening now, the financial collapse during the corona and all these things on the physical level. But more important is mental restlessness, emotional upsurges, deep-rooted psychological conflicts, anxiety, greed, jealousy, hatred, infatuation, arrogance, ego. All these things are at the base of stress. So stress is a very complicated, multi-dimensional challenge that we are facing today. And the technological era has given us tremendous amount of benefits in terms of conveniences. For example, we are having this entire conference online. Sitting in different parts of the world, we are able to converse and we are able to communicate and do fantastic things. All those advantages have come. Along with that, we have now very powerful pharmacological intervention and great surgical interventions available. Almost 5,000 types of surgeries which can replace every part of the body. With all that, we have no solution to this modern NCDs. There is diabetes, hypertension, heart problem, epilepsy, migraine, irritable bowel syndrome, anxiety, neurosis, and several. Why? Because stress is at the base of this modern NCDs. And stress is a multi-dimensional challenge. The knowledge that we have in the modern science, in modern medical expertise is essentially the physical. So how can you solve a multi-dimensional challenge with a one-dimensional solution? That is where we failure. Therefore, we must have a multi-dimensional approach. This is what yoga offers. Yoga works not only at the body level, but at the prana level, mind level, emotional level, intellectual, with a spiritual basis. Yoga is not just a set of physical exercises. Yogic postures are the ones that give very deep relaxation to the entire body. Then we have the pranayama, slowing down of the breath, reducing the breathing rate and reducing the metabolic rate, giving deep rest to the system. And the three cardinal principles of yoga, yogic postures, asana, the pranayama, the science of breath control and mastery, and calming down of the mind at the meditation level, and gaining mastery over the emotions to bring balance on the emotion. So these are the four streams of yoga, as Swami Vivekananda said, Gnana Yoga, Raj Yoga, Bhakti Yoga, Karma Yoga. Working with the intellect is Gnana Yoga, working with the emotions is the Bhakti Yoga, working with the day-to-day activities is Karma Yoga, working with the willpower is Raja Yoga of Patanjali. Using these things, we use what we call the integrate approach of yoga therapy. This integrate approach of yoga therapy is going to work wonders and works at all these levels to bring about the normalization. And once the viparya is reduced, immune system is going to blossom itself. So therefore, our idea was to measure what is happening to the immune system, and we measured various things, and we have been able to show that yes, immune system is getting back to normalcy. And these are the ones that we have done with evidence-based, with the biggest spread in all the things, using the randomized controlled trial, using the yoga, and we thanked, praise and record our grateful thanks to Ministry of Health and Ministry of Ayush for having funded this big project, costing almost about 12 crores of rupees, which these people provided. The Ministry of Health offered to take care of all the measurement, the blood tests and other things, and the Ministry of Ayush took care of the expenses related to the human things and travel and then taking care of them and all these things. And with that thing, we have been able to bring out this entire dimension and take place. And here we have in our Arogya Dhamma a 600-bed facility in our beautiful Prashanti campus, a 100-acre campus of Vyasa University. This is our residential headquarters. We have people who come there and they get wonderful results. The diabetes, very severe. People who are taking 80 units of insulin, they come here within 15 days, 20 days, they reduce insulin almost to nil and start moving towards the tablets, and after continued practice, they go home and continue and even drop. And such is the wonderful result that we have done. Hundreds and thousands of people who have come here for the program. Normally they come here for about 2 weeks and they get these wonderful results. Similarly, various other NCDs also are being tackled, and these things have been published. We have published nearly 600 research papers, and you can go through our website in which all these details are given. So in this background, we also have a number of conferences that we organize, and every year, we have conference in different parts. Every alternate year, we have got our conference here in Prashanti Kutiram. So in 2020, we had our international conference in Frontiers in Yoga Research Application, especially on diabetes. And this is how we are driving. And as part of this, we also have this year a conference organized by Asian Yoga Therapy Association in Singapore. And that conference is going to be September 26, 27, 28. And we have a pre-conference workshop for 1 week, post-conference workshop for 1 week, in which we bring the best yoga experts throughout the world. And they're going to teach them the yoga practices for various NCDs and for developing the wellness. Yoga for well-being is the topic. And we welcome you all to this conference. It's going to be a hybrid conference. People who are in Singapore, they're going to join. Others can join online, just like you all have been joining online for these things. Once again, I thank all of you for your wonderful inputs and hope that this common platform that has been provided by our Rajesh Sharma-ji will go a long way to take us forward in dealing with diabetes, and particularly in the meeting the challenge of diabetes. Thank you very much, and I wish you all the best. Dhanyavad.
Thank you so
Guruji.
much, sir. Yes, Rajesh, you want to add to?
Yeah, Guruji has given yoga a scientific approach, publications, and he has been into NASA before coming and establishing here Vyasa University. And I had an opportunity to meet Guruji again and again. And whenever I remember, I get blessing from you. Thank you.
Thanks, Rajesh, and thank you, Dr.
Thank you very much,
Nagendra, sir.
Rajesh.
So it was really, thank you so much for gracing the occasion. And I'm sure NGOs listening to you must be inspired and encouraged to do more in this area. Thank you so much, sir. Over to you, Dr. Saxena, for the next proceedings. Thank you.
Thank you, ma'am. So moving on to our next topic, expectations of a diabetic from a surgeon. Dr. Arun Bhai, he would be speaking on this topic. He is a consultant diabetic foot surgeon, Raisa Hospital, Hinduja Hospital, Mumbai, visiting professor at Amrita Institute of Medical Science, Kochi, and president of Diabetic Foot Society of India. Over to you, sir.
Okay, thank you. I will share my screen, please. Is my screen visible?
Yes, sir. Sir, your screen is visible, but your face is a little bit.
Yeah, okay. I'll just 1 minute. Let me adjust this. Okay. So thanks for inviting me. At the outset, let me thank Dr. Mayur and Dr. Yash Patel for inviting me. What I'm going to do in 15 minutes is just show in 2 sections what is its current scenario and fact check, and then what is the expectation. So this is the current scenario. India is epicenter of diabetes quake, and this is the current phase of diabetes in India, where you go to any hospital, you see this type of a patients who are more than 30% in any institutions. And this is what ex-director of WHO used to say, that Asians are young, ambitious, and diabetic, and they are dying early. And prevention and treatment of diabetic foot ulcers in India is a road filled with potholes and roadblocks. So this is India is in a transition. You see modern as well as ancient, and there is a rapid transition, and our diet habits have changed. I see a lot of my younger students eating this sort of a burgers, which gives almost 1,000 calories. I call this is a weapon of mass destruction. So this is something which we must understand. 2009 was a very crucial year when there were more deaths because of diabetes than HIV/AIDS, and that was the first year when, in the world history, the deaths due to non-communicable disease exceeded communicable diseases. So during human evolution, you had disasters, you had diseases, variety of, right from plague and smallpox. Now we are in a age of decay like diabetes. So beautiful feat like this, when diabetes strikes, this is what happens, and we need to understand this and prevent this, because this is a tragedy which is easily preventable. This used to be the treatment in early 19th and late 18th century for a diabetic foot infection. As of today, we have 74 million diabetic patients. We have 148 million feet to look after. As of today, we have 200,000 higher level amputation in the country. Tragedy is that 85% of them are completely preventable. They are due to infected neuropathic ulcer. Now, up to 25% of those with a diabetic foot ulcers will lose with the foot ulcers will have an amputation. And if you have a regular follow-up of a diabetic patient by community health workers, this is one study from America which shows that you can save huge amount of money where the podiatry workers or community workers can examine the feet. In India, any patient who has an infected foot ulcer spends 50% of his annual income on treatment. And these are the complications which you see of a foot. Out of that, you will see the foot has the highest number of problems. So foot ulcer is not a surgical disease, it's a complication of medical disease. So medical disease remains in the background even if foot ulcer heals. So you have to have a high index of suspicions, and these are like iceberg. And diabetic foot ulcer patients are very vulnerable. Cause of their vulnerability is neuropathy, immunopathy, and altered biomechanics. So this needs to be seen by a community diabetic foot worker who can diagnose this and give a preventive treatment. But there is a very narrow window of opportunity in these patients. And as of today, we don't utilize it because we have this unwritten policy, no complaint, no examination. Because the diabetic patients have neuropathy, they don't get pain, they don't complain anything. So nobody looks at their feet. And you see, this is our social situation. People in Bombay traveling, staying in slums, visiting various pilgrimage, going into the temples. All this affects, these patients can do all these things, but they have to take a proper foot care. So a simple thing like this, this is a callus, which is a precursor of ulcer and probably precursor of the loss of limb. This can happen only because patients are not taught how to take their care of their foot. And you have a rat bites in our hospital. We see routinely patients whose toes are eaten away. We are all fond of massage. Massage is dangerous in diabetic patients because it causes necrotizing fasciitis. People apply hot fomentation, get burns. They apply like this variety of ointments and macerate. People travel in the public sector buses and remove their footwear and keep the feet on the floor, which is a metal and which causes burns. People use herbal ointments, and herbal ointments can mimic gangrene like this. So you have to be very careful. You need a good community diabetic foot worker, which we don't have at present. And there are a variety of things which don't happen in a developed world but happen in India. You can see this example of a person who was a highly educated foreign written lecturer, saw on a WhatsApp that if you apply Rui ka patta on the toe, the diabetes will get control, and she lost the toe but landed up with a permanent kidney damage. A doctor applying leeches for the diabetic leg swelling, people using this acupressure sleepers causing damage to the foot. we have this sort of equipment to reduce the weight available in India, which is highly dangerous for diabetic patients. So the real social tragedy as of today is higher level amputation is cheaper than prevention of a preservation of a foot by foot salvage surgery. And see, we have this situation where, you know, we have a dilemma. How do we treat this patient and create a cadre of community diabetic foot workers? And we cannot have very, very highly qualified community health workers like podiatry workers who are there in developed countries. So the thing is that you have to have a people, even a 12th standard student who has no nursing education can be trained, and which we have been doing for last 25 years. So in this, in the larger interest of the patients and the society, you have to utilize the available cadre of human resources and train these people. And how do you prevent the diabetic foot ulcers? So these are current efforts and expectations. See, diabetic foot is a Cinderella of medicine. Very, very few people bother about it. You can see among diabetologists also, it is a Cinderella. You can see the amount of money spent on a research in diabetes as compared to diabetic foot. And patient education can prevent the foot loss or prevent the amputation. You can see this study, the huge difference by just teaching the patient to take care of his foot by the community health workers. So we need more community diabetic foot workers to prevent all these tragedies. And this is a principle which we used in training these workers, which is by a very famous guru of management who started the science of management called Peter Drucker. He said, if a trainee is willing, anybody can be trained for anything. And we have this in Amruta Institute cadre. These are not nurses, these are boys and girls who are only 7th and 8th standard pass. We train them for 18 months and they can practically do everything related to diabetic foot, even assist in complicated surgery. So you need this sort of a cadre everywhere. And it is not difficult to train them. You have a huge force of unemployed people, and you can train them in 1.5 years. It is an employment for them. It is also community service, and you can save the limbs of millions of diabetic foot patients. So we must remember deformed foot with a good footwear and is preferable to the amputated leg because it is likely to kill a patient. And all the diabetologists, everybody must remember that all the diabetologists tell the patients, walk briskly for 45 minutes to control your blood sugar. Many patients are walking for miles together when they have a severe neuropathy. So this is a dictum I think all health workers must remember. Faster the gait, higher the pressure. Longer the stride, higher the pressure. So diabetic patients' exercise schedule need to be changed as his diabetic neuropathy, which causes a loss of pain sensation and change in the foot structure progresses. And the distance in walking for diabetic patients should be measured in minutes, not in miles or kilometers. So these are the exercises on left side, right side, which should not be done by the patients who have a diabetic problems, what is seen on the left side. So you want to prevent this foot loss, then just adequate and proper understanding of peripheral neuropathy, altered biomechanics, and is very essential to prevent the higher level amputation. And this does not need medical education. I would like to stress again, this just needs a training for about 1.5 to 2 years of a person who has a basic intelligence and who is even not past SSC can do this job, and risk stratify which patient need a further expert care. Sorry. So we have set up this diabetic foot clinics, Diabetic Foot Society of India, in 4 public health hospitals in Chennai, Calcutta, Ahmedabad, and Guwahati. And these are managed by paramedics who do the routine foot assessment, teach the patient foot care, manage the small wounds, give them idea about the footwear. So this needs to be done. See, minimum one should do, if you see a patient as a healthcare worker of a diabetes who has a foot wound, the minimum you should do is to stop him from walking on the wound, because he literally walks to death, because that wound will get infected because of his neuropathy. He doesn't get pain. He will keep on walking, and then he will ultimately either lose the leg or even lose the life. And you don't need any technology. You just need to train a community health workers to examine the feet and give a proper footwear. So what you need is a care. You need a care of a foot. You need to teach the patient these 10 commandments developed by Diabetic Foot Society of India. If patient is taught to take this care every day, at the end of the day, and take these all basic points of care in the mind, then I think you can practically reduce by 90% the amputations and ulcers, which is a precursor of amputation. So this is a simple thing. It doesn't need any technology, doesn't need doctors, doesn't need corporate hospitals, multi-speciality, just a community diabetic foot health workers who will go to community and teach the patient how to do this. Surgery is not solution. Though I'm a diabetic foot surgeon for last 38 years, I can tell you that surgery is not a solution, because every ulcer is a precursor of a amputation, and ulcer is the beginning of the end. So you have to prevent it. The only way to prevent is to take a train the patient to take his own care and have a regular follow-up, early referral to specialty center in case patient gets into the problem. As I said, this is the current phase of diabetes in India. I call these patients of a foot attack. See, amputation prevention in 21st century is a team technology and tenacity. So you have acute coronary units, you have a stroke units, you need a very aggressive diabetic foot management units in all hospitals, including district hospital, where you have a physician, surgeon, and paramedic. That's all you need. And remember, time is a tissue. Unless you treat it aggressively, if the ulcer occurs, more tissue is lost and the foot is lost. And you must always check the circulation just by palpating the pulses in the feet. Also remember that callus, which is the hard skin, is like a benign breast lump. You have to remove it. And remember, as I said, that this is a problem which is because of a medical diabetes. It is not a surgical problem. So there is no remission for this foot ulcer. You can keep it in the complete remission, no cure. And remember, rapid healing of the wound is very important, because activity and mobility is a longevity. And that's why you need to bring in concept of 5-year ulcer-free survival in the community and among the family physicians. As you know, that patients of cancer regularly go for follow-up because they know that it can recur. Same concept has to be brought in here. Otherwise, we will keep on losing the limbs. So what you need is a sensitive pair of eyes and hands. That's all you need. We have a tradition of a foot care and footwear in our society, which we have, probably forgotten in urbanization and globalization. We have, diabetic patients' feet can be saved by simple footwear. We have footwear in politics, but not in diabetes. I think that needs to be changed. I would like to end by showing you this famous Sanskrit saying, which means one who walks, his fortune marches ahead. We want these all millions of patients of diabetes to have their fortune marching ahead. So we need to save their feet. Thank you.
Very good talk, sir. Excellent talk, covering most of the basic and useful information regarding diabetic foot care and its prevention and management.
Thank you.
It was really nice listening to you, sir. So our next topic is, what is the unmet need in the management of diabetic retinopathy among the diabetics, by Dr. R. Kim, who is a senior consultant, vitreoretinal services, Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. Over to you, sir.
Thank you, sir. At the outset, I would like to thank Dr. Mayur Patel and Dr. Yash Patel for inviting me to this August forum. So I'll just share my slides. Are you able to see my slides, sir?
Yes, sir.
Thank you.
Yeah.
Yeah, okay. So this is one area, that is the eye complication of diabetes is one area that's not usually addressed very often in the diabetic forums. And very thankful to Dr. Mayur Patel for inviting us to speak on this very important forum. Of course, all of us, especially all of you who are dealing with diabetes, are very well aware of the changing prevalence of diabetes in our country. If you look at the global estimates of diabetic retinopathy, there are almost 93 million persons living with diabetic retinopathy, and almost half of them, a little less than that, is having sight-threatening diabetic retinopathy. If you look at the Indian statistics, like the prevalence of diabetes among the diabetic retinopathy among the diabetes, various studies, most of them have been done in the south, is around 12 to 18%. The one done by us is on a urban, semi-urban and a rural population. So you see around 12%. In the urban population of Chennai, it's anywhere from 18 to 20%. But unfortunately, most of this disease is being identified too late for us to do any prevention or preserving the vision, because there are no early warning signs. This disease is very gradual in onset, identified most often on routine findings or when the patient presents to the ophthalmologist when they start to lose vision. By then it's a little late for any ideal treatment to be given. If you look at it, only 20% of the diabetics at any time examined will have any diabetic retinopathy at any given time. If you're looking at 100 patients, of these, only 20% may have vision-threatening condition. But since we do not know which of these 20% will have diabetic retinopathy, we need to examine every single diabetic at least once a year. So screening should be done at every opportunity, and it should not be left only to the ophthalmologist. So what are the challenges in diabetic retinopathy care? There are the lack of awareness among the physicians. This is one major problem. We have seen only 1.3% of the general practitioners actually use direct ophthalmoscopes to look at the back of the eye. Among the ophthalmologists, also only 50% actually practice dilated ophthalmoscopy. In one of the studies done by my friend Dr. Rajiv, it's shown that 54% of the general practitioners only were aware of annual dilated eye examination and referral guidelines. And only 1.3% of the general practitioners were using direct ophthalmoscope. There was very poor knowledge. Only one third had a good knowledge, and the hospital staff who were dealing with this had very poor knowledge of this referral. So if you look at why this is happening by physicians, because most of the time it's a lack of time to look at the back of the eye, look at the using an ophthalmoscope, lack of training in identifying diabetic retinopathy, or very fear of using dilating drops during your practice in general practice, lack of confidence in detecting the changes, and sometimes the fear of precipitation of angle closure glaucoma when you're dilating these patients. If you also look at the awareness among the people with diabetes mellitus, in a country like Singapore, which we say is developed, of the 272 participants who participate in the study with diabetic retinopathy, only 83% were aware that they were, 83% were unaware of that they had any diabetic retinopathy. We did at Arvind, we did a KP study some time back, and we found out that only 50% of the respondents were not aware of the risk factors for diabetic retinopathy. Even among the paramedics, only 20%, and in the community, 10% were aware that uncontrolled diabetes was a risk factor. So it's definitely the awareness is very low. And often we have seen that 45% of the patients with diabetic retinopathy who are attending the ophthalmologist clinic have already lost their vision before the condition can be diagnosed. This because we are doing very little to address this. How do we improve? Is to only by creating awareness among the physicians and the people with diabetes. We have been using these different medias target based on the community, or if you're addressing groups, or if you're addressing individuals, different methods to reach out to these people. But still we are far from reaching the actual target population. If you look at the referral network, 73% of the physicians said they usually refer the patients to the ophthalmologist for an eye examination, but this is in a very, very selected group. Nearly 55% of the patients stated that they regularly receive referrals from ophthalmologists after they have identified the diabetic retinopathy, but there's no definite mechanism for tracking or ensuring whether the referred patients underwent retinal screening once referred. So the non-availability of adequate trained manpower infrastructure in the primary healthcare settings is one reason. There is also lack of strict regulation on the referral system. We just did a small study some time back to see how the communication between the ophthalmologist and the diabetologist, it's very poor compared to American Society of Retina Specialists survey, which showed 55% of them communicate with their primary care physicians or diabetologists, while the Indian ophthalmologists, only 19% communicated to them. So there is something that has to be addressed. Diabetic retinopathy screening is plays a very important role in this, because screening for diabetic retinopathy cannot be limited only to the ophthalmologist. I actually say the onus of finding the case should not be with the ophthalmologist, but with the physicians and the diabetologists, because they are the first point of contact for these diabetic patients. Using technology like telemedicine, today we are able to reach out to these patients. They can be screened where they are being seen. And telemedicine, we have been practicing this for the last almost 20 years, where in the diabetologist clinic, we have trained one of the technicians to take fundus photos, send it to our reading center where our retina specialist reads these images, creates a report and sends it back so that the diabetologist can advise the patient accordingly. We are doing this in primary health centers. Our team is going, screening the diabetic patients who come to collect their medicines, and they are being advised only, given medicines only if their eye is examined. Again, in a country where it is very much needed, like in India, we had only 10% of the ophthalmologists are using telemedicine to screen. Today, we are also using artificial intelligence to do DR screening, where just simply dropping an image into this algorithm can give within a few seconds the grade of the image by using these artificial intelligence. And today we are using it in real time in our screening programs, where the 1 hour or 2 hours is shortened to less than a minute, where the patient can get the report within a minute. And this is as good as a retina specialist, as you can see from the slide, after a lot of multiple validation studies where we have been doing. So this recently, myself and Dr. Raji Raman, my friend from Shankar Netralaya, have been got together and presented these screening guidelines published in IJO for diabetic retinopathy. We also need to look at what are the skills available. We need to close. It's not enough just diagnosing diabetic retinopathy, but it is important to make sure that the care for diabetic retinopathy is also available, because today that's another short supply with the number of ophthalmologists versus the number of diabetic patients that are out there that needs to be screened, and those who develop retinopathy to be treated. Will it be possible? So we need to improve that cadre. Also, those who can do not only screening, who can treat these patients with laser intravitreal injections or with surgery. So these are things that have to be in place to close the loop for the management of diabetic retinopathy patients. So these are the different challenges as I've been addressing. Most important is to improve care, and one that can be easily done is the diabetic retinopathy screening. So with the physician doing initial diagnosis and appropriate referral, and with the ophthalmologist creating a proper follow-up with these patients, we could deliver a very good care or prevent these patients from losing this needless blindness due to diabetic retinopathy. So once again, I want to thank you for giving me this opportunity to share our thoughts on management of diabetic retinopathy. Thank you.
Excellent talk. Hello.
Yes, sir.
Yeah, excellent talk. Now moving on to the other next topic. Expectations of Neurologist by Dr. Sudhir Shah, MD/DM Neurology, Consultant Neurologist, Professor and HOD Neurology, VS General Hospital, Ahmedabad, Director of Neurosciences, Sterling Hospital, Ahmedabad. Over to you, Sudhir sir.
Thank you very much. May I try and share the screen actually? Yeah, let me see if I can share the screen. Is it there? Slide seen now?
Yes, sir. Yes, sir. It is visible.
Great.
Yeah.
Great. Now let me do this. At the outset, let me first thank and congratulate my friend Dr. Mayur Patel, my nephew Dr. Yash Patel, and the team who has organized this wonderful event. A great concept, a very innovative measure, and very much in place for today's context. So I hope the echo of the different talks reaches to the different parts of the world and it benefits in patient care. So with that prayer and hope, I would like to emphasize some of the points what a neurologist would really wish that the NGOs and the common public really help in propagating those facts which are very important in today's context. As you know, diabetes mellitus is a chronic metabolic non-communicable disorder and it is an epidemic proportion worldwide. And has been repeatedly told, India is one of the epicenters of the global epidemic. And the high level of visceral fat and insulin resistance in spite of a low BMI generally predisposes them to type 2 diabetes mellitus and many more other things. So just to summarize, I don't want to go into details of all this, but you know very well that the possibility of pathogenesis are environmental factors like economic prosperity, urbanization, westernization, decreased physical activity, high intake of refined cereals and low intake of dietary fiber fruits, and genetic predisposition, particularly in Asian Indian population, is despite a low BMI, high waist circumference, high waist hip ratio, high visceral fat, increased insulin resistance, high prevalence of dyslipidemia and beta cell defect. And then you know the profile of this type of people. But what is important that the issues in management, there is a very low awareness level, high prevalence of undiagnosed disease, a lack of nihilism in accepting the disease, and unaffordability of care to some extent at the other end, and unavailability of trained medical and paramedical personnel. These are the issues that we need to tackle. So as you know, the risk factors are overweight, obesity, physical inactivity, dietary issues, age, family history, ethnicity, urbanization, and the outcome is stress, the low birth weight, and it is almost like a COVID epidemic, like diabetic epidemic is having the highest rate of incidence and prevalence these days. I'm sure you know this. These are simple facts that the environmental factors in terms of nutritional aspects, obesity and physical inactivity coupled with the insulin resistance leads to ongoing hyperglycemia, which has a two-way effect: atherosclerosis, hyperglycemia, hypertension on one end, and the triopathy, retinopathy, nephropathy, and neuropathy, and then ongoing issues with blindness, renal failure, heart disease, amputation, stroke, and disabilities and death. So, friends, you know, this slide summarizes that there are two types of complications: macrovascular and microvascular. Microvascular retinopathy, as Dr. Kim very efficiently discuss the retinopathies and the other complications, the kidney. One of the colleagues is going to talk on the nephropathy. Neuropathy and brain cerebrovascular disease, cognition and CNS infection. These are my territory areas, and I will elaborate the problems and neurologist faces, and of course, cardiac and extremities. So out of the whole chunk diabetes, at least 1/3 to one half of the complications are related to nervous system, and that is what we should realize, and all NGOs are requested to listen to what I say now, because these are all underdiagnosed things. It is like a tip of iceberg that we are diagnosing. Rest of the things, there are asymptomatic patient, undiagnosed patient, complications arise, and that time we come to know the patient is already in diabetic ketoacidosis or has severe malignant vascular disease, right from heart to carotid to renal to peripheral vascular disease. So what is a diabetic neuropathy? Why NGOs should take part into discussing all these and have a community survey asking patients, do they have symptoms of paresthesia, pins and needles in the legs or both the hands? Do they have less sensation while walking on floor? They get a kind of some floor sensation, something below their feet, feeling kind of cotton wool walking, something like that. Or while bathing, they don't feel heat and cold sensation. Because diabetic neuropathy, friends, is the commonest complication of diabetes and is most common neuropathy in the Western world. In India, diabetic is yes, but apart from that, we have Hansen diseases, leprosy, vitamin deficiency like B12, B1 deficiency, alcohol deficiency, alcohol use toxicity related neuropathy, and so many other toxic neuropathies like lead, arsenic, etc. But in Western world, diabetic neuropathy is the commonest one. And there is substantial morbidity, including recurrent lower extremity infections, ulcers, amputations. And based on several large studies, approximately 50%, my friends, of patients with diabetes will have eventually neuropathy. So if you take 1,000 diabetic, 500 will develop within 5 to 20 years some kind of neuropathy, 50% time. Now, what are the different types of diabetic neuropathy? Generalized somatic neuropathies like distal sensory motor or sensory neuropathy, wherein the patient will complain of tingling, numbness, hot and cold sensation, pins and needles, or while walking, they might feel something odd, like a kind of sand kind of feeling below their feet. And some people would have the small fiber neuropathy, others have autonomic neuropathy. What does that mean? The symptoms would be shininess of the skin, there would be less hair on the sheen of the legs, and so there are vasomotor changes, trophic changes, etc., constipation, urinary incontinence, urgency, and impotence, sexual lack of libido, etc. These are the symptoms of autonomic neuropathy, and less sweating. And large fiber sensory neuropathies typically, as I mentioned, while walking, they feel that as if there is some kind of cotton or some pad below their foot, and they don't feel the ground properly, and they are ataxic. So while walking, they feel they have imbalance, and if you close eyes, if you ask them to close their eyes, they might kind of have imbalance and may fall down actually. Sometimes you have postural hypotension. So when they get up suddenly, they feel dizzy and they have sudden blackouts. So these are the symptoms, and which are not uncommon, friends. If you really screen out all these diabetic people with the list of symptoms that I mentioned, many of them would volunteer, and then you take them for the test. Right from now conduction test to simple fog test, you will realize that they are really having clinical or subclinical neuropathy. Similarly, there is facial neuropathy, there is eighth nerve neuropathy, there is third nerve neuropathy, ptosis, or facial asymmetry. There are some less sensation on the trunk. There will be limb mononeuropathy, carpal tunnel syndrome kind of feeling, or proximal motor neuropathy kind of amyotrophy. While walking, they have waddling gait and severe pain in the hips and buttocks. So, and then there are myriads of combinations out of all this. So friends, this is very, very common biotic reason. I want all of you, particularly NGO friends, to spread this news and pick them up early, get them diagnosed. Sometimes this is the presenting symptom of diabetes. People, they don't know that they have diabetes, but with these symptoms they come up and we diagnose that they have already advanced diabetes, or their HbA1c is in the range of 10, 11, etc. And when you go back in the history, we realize that they had polyuria or polydipsia or so many other symptoms. So this is a schematic representation of what I said, and these are the neurological findings, which I don't think are very important for you to recognize. But the treatment of this diabetic neuropathy is not very difficult. If we diagnose even early or even in the mid stage of the disease, we can actually halt the progression, and to some extent we can revert also symptomatology. Strict glycemic control, the nerve conduction usually improves. Maybe symptoms may not improve that much, but there is objective evidence if you have strict glycemic control, nerves improve. You treat the hypertension, treat the dyslipidemia, and that also helps in cure of many other problems which are bound to come up, like stroke or heart disease or renal disease. Then avoid alcohol, smoking, and other vices. Ask them to have supplemental vitamin deficiencies like vitamin B12, B1, B6, etc. can be supplemented. Specifically, we have to ask them to take care of foot care, which I will address in a minute. And for painful neuropathies, we have gamut of drugs, which I think is out of the purview of my talk, but duloxetine, amitriptyline are the important drugs. Friends, diabetic neuropathy is one of the dreadful complications, and many people whom you see with their amputated limb, we tend to, feel sympathy and maybe kind of, pain that this could have been averted. So neuropathy coupled with peripheral vascular disease, these produce ischemia, produce ulceration and gangrene, and ultimately leads to amputation. So neuropathy, as we discussed, can be diagnosed with loss of protective sensation, and there is a gradually occurring foot deformity and dry skin. And with the peripheral arterial disease, there is ischemia. So the undiagnosed, notice repetitive trauma, and then gradually cracks and fissures in the skin, and ultimately this leads to the ulcers and gangrene. Some of them, they develop Charcot foot, that is called osteoarthropathy, that is related to neuropathy coupled with trauma and inflammation. There are secondary infection in the foot. So these are dreadful things, and it is not that uncommon. Of course, with the current management aspects, particularly in urban areas, we see less and less of this complications, thanks to the friends like Dr. Mayur Bhai and different, various top diabetologists and physicians we have. We are able to, educate people in time and treat them well. So this is becoming less and less, but still, even in urban area, in some parts as well as in many rural aspects, we see this complication. The most important message for today I want to give is for cerebrovascular disease. I'm sure there is a lot to be done in these areas. Like neuropathy, this is also an uncharted area. I would say that 40% of the cerebrovascular disease are just because of hypertension, which is a common accompaniment of diabetes. And per se, 15 to 20% strokes are purely due to diabetes because of uncontrolled diabetes, hyperglycemia, and the gamut of metabolic issues. coupled both, 60% of the strokes are just because of diabetes and hypertension. And if you also ask them to stop smoking and alcohol, etc., and take care of their physical health, reduce BMI, do exercise, and reduce obesity, and stop sedentary lifestyle, at the same time ask them to reduce stress, I think 80 to 85% of strokes can be controlled, prevented, and cured. So this is the importance of cerebrovascular disease. And you know, in a study in Sweden, the highest rise, that is six-fold rise in stroke, was in diabetic males and 13-fold rise in diabetic females. So as compared to normal population, this much is the incidence of cerebrovascular disease in diabetic people. And the greatest rise in 5th and 6th decade. What are the symptoms of stroke? We call it FAST. F is facial asymmetry. When a patient is confronted by you and you find that there is a facial asymmetry, there is some abnormality in arms, in like when you ask them to raise their arms, so one of the arms falls down, or it just fluctuates up and down, or it pronates like this. So that is sorry, that is the earliest symptom of stroke. Similarly, in leg also, one of the leg, while raising leg, when ask you to raise a leg, one of the leg just tries to fall down. So that is the FAS is speech. Ask the patient to speak few words or repeat, or you ask some question, ask to answer them. Speech is involved, your face is drooping, or smile is involved. If there is arm drip or leg drip, or B fast, B is balance, and I is visual complaint. So B fast, this is the mnemonics for stroke symptom recognition. Balance, eye symptom, visual symptom. F is facial asymmetry. A is arm or leg dripped, and S is speech. If that is so, the T is for time. Time is brain. Friends, you realize that while there is a ischemia, either there is a block of the artery because of thrombosis, or there is an embolism where something, a clot has come from the heart or great arteries and lodged into that vessel. So that is called thrombus or embolism, blocking the artery. Now, the important thing, the most important message for today, if I have to give, is that at every second when there is a blockage of artery, every second 32,000 neurons die. So within 1 hour, you can understand that 1.9 million neurons die. And that means in a stroke, 1.2 billion neurons are dead in one stroke. Imagine a brain has 100 billion neurons, and 1.2 billion neurons in untreated stroke, they die. So as soon as we get the above symptoms, that's be fast, we have to ask the patient to go directly to a good hospital where thrombolysis can be done. If we do intravenous thrombolysis with RTPA or intraarterial thrombolysis coupled with that, 70 to 60% of the strokes can be prevented, further damage can be prevented, the patient goes back to the previous situation, or there is a minimal damage of the cell. So most of these ischemic strokes are the result of lacunar infarcts or embolism or thrombosis, which I discussed. Hypertension is the main risk factor for stroke in the diabetic patient, and there is something called TIA, where there is a transient ischemic attack. Similar symptom comes and goes away, and that can be taken care of. This is a warning sign. If you investigate the patient, you find out several risk factors, right from diabetes, hypertension, smoking, alcohol, atrial fibrillation, to genetic factors, to some clot embolism from the heart. There's some abnormality in the heart valves, or etc., or previous heart attack or previous stroke. These are the common risk factors, apart from many others. The third important thing with the neurologists would always wish to train the common public, and particularly enlightened people like you, is CNS infection. Friends, You have seen that in COVID, those patients who had diabetes, many of them develop mucormycosis. All diabetic patients are more prone to infections, let alone other infections, CNS infection, meningitis, encephalitis, abscess, fungus, malignant otitis, external otitis, and mastocytitis. Fourth important thing is diabetes and memory, diabetes and cognition. Cognitive deficient, poor performance in abstract reasoning, complex psychomotor functioning, complex cognitive tasks are affected because diabetes slows down the processing of the brain. So friends, diabetes is a real enemy, right from the memory, intelligence, speech to stroke to neuropathy and importance to other so many complications where the life becomes miserable. And if you don't take care, amputation and permanent hemiplegia and loss of permanent speech and memory, these are the issues. So I can't really overemphasize the need of education of these patients, and therefore your role would be crucial. And if the patient comes with diabetic ketoacidosis, ischemic stroke, venous thrombosis, other CNS infections, cerebral edema, etc. occur. Retinopathy has been discussed. Nephropathy is not my territory, but we can plan primary, secondary, and tertiary prevention, including activities aimed at preventing diabetes from occurring in and susceptible population screening, early diagnosis and effective control of diabetes, and preventive complication of and disabilities due to diabetes. I have a feeling that every 6 months, if the government screens people for hemoglobin, blood pressure, fasting sugar, HbA1c, lipids, and creatinine, I think many of the diseases can be prevented right from the early childhood to late adult people. If we do have a screening program, this as well with ECG and echo screening in ages beyond 50, I think would be the most important screening program for Indian continent and even Asia. So primary prevention is behavioral intervention and pharmacological intervention, population strategy, as I mentioned, and we have to actually identify high-risk people. And then secondary prevention comes to identify asymptomatic people with diabetes, and that is how you need population screening, selective screening, operative screening. Opportunity screening is like people entering into airport, all people should be screened. Like that, in some people entering into a mall, they should all be screened. Why mall? When a person comes to a doctor for any ailment, for headache, malaria, whatever, he should be screened for diabetes, hypertension, anemia, HIV, cholesterol, and ECG. If that kind of aggressive approach is taken by doctors and other people, we can literally make difference to the lives of people. So screening of retina, food care, how to check your food daily, etc. These are the things which would mean a lot. Wash them daily, dry well, especially between toes, feel the bumps and temperature changes, look between the toes carefully, file toenails, check for dry cracked skin, examine bottom of feet and track what is. So I'll just be finishing within a minute, so please give me 1 or 2 minutes. The same basic improvements in diet and physical activity that prevent type 2 diabetes are likely to prevent cerebrovascular disease and its complication. So the truth remains the same. As Sadhguru was telling, health is not absence of disease. Health is something rubbing from within. We are all full of energy. Samadosha, samagnischa, samadhatu, malakriya, prasanna, atma, indriya, mana, swastha iti vidyate. Atma, Indriya or Man, soul, mind and body, when becomes perfectly in a positive state of health and bliss and happiness, that is health. And that is what we can achieve with all this. And these are the classical levers in public health in response to diabetes. These are the clinical services, glycemic available, glycemic control, BP control, lipid management, annual eye examination, food care, etc., etc., immunization, preconception care, diabetes education, case management, targeted screening. Behavior that we have to promote through help of people like you is education, awareness for physical activity, stopping all vices and doing healthy diet and like regular visits of doctors and health monitoring, etc. And populated target policies are healthcare access legislation. Government has to do things through legislation, drug and supply reimbursement policies, and population strategies. So in the cornerstone of diabetes management itself covers is self-care, changing behavior, encourage interaction, and people should understand that this is not a joke. You have a right to live a healthy, long life, and these are the self-care points that you have to look into: blood glucose, body weight monitoring, food care, personal hygiene, healthy lifestyle. There should be group training. The diabetic group should be made. I'm sure Mayur and many other friends are doing the same kind of things, and that helps. And they've shown that there is a reversal of diabetes. People are gone off the drug, and some of have reduced drug, as he's mentioning in his speech. So that is what is needed, friends. These are the barriers, and we have to remove the barriers with dietary counseling, patient education, physical activity, medication, compliance, aggressive follow-up, sudden death assessment, and to add to it, yoga, pranayam, meditation, and relaxation strategies. Thank you very much, friends. Thank you for kind listening. I'm sorry I overshot it by a few minutes. Thank you. You are muted.
Hello.
Yeah.
Sir, excellent talk on neuropathy, diabetic neuropathy, covering all the aspects from basic to the advanced, and also adding divine touch in your lecture as always. Sudhir sir, you are really a gem of a person and a very good neurophysician. Very good information, sir. Thank you.
Thank you very much.
Our next topic is expectations of nephrologist. Can you please share this slide, please?
Arun sir, it is there on the screen.
Yeah, but something is coming in between.
Jatin sir, you can start.
Should I?
Yeah, it is there. Right?
Nephrologist, regular dialysis and blood bank, kidney transplant education, and organ donation awareness by Dr. Jatin Kothari, MD DM nephrologist, trustee of Apex Kidney Foundation, consultant nephrologist and transplant physician, Hinduja Hospital, Mumbai, section coordinator, nephrology, Hinduja Healthcare. Over to you, Jatin sir.
Thank you, Dr. Arun. Thank you for your kind words. In the interest of time, I'll straight away go for the lecture. Can you allow me to share my slides?
Yes, sure. Sir, you have to share your slide.
That's what I'm trying to share.
Yes, yes. It is visible now.
Are my slides visible?
Yes, sir. Yes, sir.
Thank you. Thank you, Dr. Arun. In the interest of time, I'll straight away go for the topic. And this is my first interaction at a NGO meeting ever. So pardon me if I get a little too medical, but I will try and cover a little bit basics about diabetes and kidney disease and how it is affecting our country and the world. And as an NGO organization, and I'm a part of an NGO organization which looks after kidney disease patients and their families, etc. I will have a few minutes of few things that we have been able to do over the last 14 years, and probably some things that we can collectively do as a group. So straight away going into the problem statement, we all know that this is not new information. I'm sure this has already been discussed in this meeting. The whole burden of diabetes and how it is affecting lives across the world. You look at the numbers, almost fourfold growth in the last 30 years. And we are close to 500 million people now already who are suffering from diabetes all across the world. If you look at the distribution in various countries, depending on the income status, you can very well see that the low income and the low to middle income population countries are the ones which are having a rapid and steep rise in the overall incidence of diabetes. So it is a problem which is much, much more common to our part of the world compared to the developed world, where you actually see some sort of leveling of the overall incidence of the disease. And as we see thinner and thinner TV screens nowadays, and we are going for slim screens, the population is having a massive obesity surge and overweight surge, and that's one of the most important reasons as to why diabetes is taking so many lives. And we are currently in a pandemic of COVID, but if you look at the overall data in terms of the deaths for diabetic patients, that itself is a huge burden of pandemic proportions across the world. So we are dealing with this disease, for years and years, and unfortunately, we have not been able to come up with strategies which reverse this disease to a large extent. Yes, there are some philosophies about how you can reverse this disease, but we are facing an ongoing disease burden and more complicated patients in our day-to-day practice. How overall diabetes is managed, I don't think we need to discuss this too much in detail, but just important to say that patient education, self-care, and creating awareness itself is also able to help in terms of reducing the disease burden. When it comes to my domain of being a nephrologist and managing patients, yes, from the preventive side, if I was able to screen everybody who is potentially a high-risk patient for diabetes for just a simple urine test, like a urine albumin detection, that itself will help me to detect this disease early and hopefully prevent further deterioration of the kidney status. But unfortunately, reversal of this disease, once the nephropathy sets in, is becoming more and more difficult and challenging. Yes, we have new drugs which help to retard and slow down the progression, but not many options when it comes to reversal of this life-threatening disease. I took this slide from the WHO slide deck of diabetes and how they address on a global platform, how they look at various things to try and control this pandemic. So there are various aspects, including prevention, looking at factors of management and guidelines, which is provided to all the healthcare professionals across the world from the WHO as a response, trying to promote essential medications, and in our country, generic medicines, which essentially are a huge savior for so many patients, because treatment for diabetes and treatment of complications of diabetes is becoming more and more expensive. So for our country specifically, providing generic medications and easy access to medications itself is a big chapter by itself. And surveillance. So if you are able to identify the high-risk population who is at risk of developing diabetes and further complications, maybe even including them in some sort of a preventive program is what essentially all of us collectively have to do. A little bit about overall what we have been able to achieve as a group and Apex Kidney Foundation, of which I'm one of the founding trustees. We set up this organization back in 2008 with the sole aim of providing support as much as we can to all patients who suffer or who are at risk of developing kidney disease. And of course, diabetic kidney disease is the #1 cause of chronic kidney disease across the world. The key objectives of my foundation was to provide education to general public and even education to physicians and nephrologists across the country and wherever we could reach them, to try and educate them about what are the new advances and how we can actually prevent and help retard the slow down the progression of kidney disease. Obviously, look at prevention, which is still at a primitive level across the world. And I wouldn't be wrong in saying that, unfortunately, we don't have too many preventive strategies to prevent this lethal disease. Focus a little bit about generating research from our own cohort groups and try and understand this disease, how specific it is for our country in terms of the genetic variation, in terms of the overall dynamics of this disease, is also something that we have tried to do. Motivating people for organ donation, and that was one of the things given to me in the talk as to how we can promote legal organ donation and organ transplantation, is also something that my foundation has tried to do over the last few years. And of course, there are financial stresses for patients who are facing these complicated situations of diabetes and end-stage complications. So help them in whatever way possible to give them medical as well as financial support. there have been some programs, and I would just highlight a few things which is applicable to the diabetic population across the city and across the country, and whatever little we have been able to do. So we are in the process of trying to conduct as many camps as possible for early detection. And wherever we get an opportunity, whether it's a religious forum, whether it's a social forum, whether it's a corporate forum, our whole focus has always been on promoting education and awareness about the various aspects of diabetes and how it causes kidney disease, how the role of organ transplantation is very important when people reach end-stage disease, end-stage renal failure, and of course, dietary and primary prevention in whatever aspects what we can cover. So from 2013 onwards, we have looked at colleges, schools, community welfare trusts, social organizations, various underprivileged sections of community, where we conduct these free health checkup camps, do a simple thing like a urine analysis and maybe creatinine if feasible, and try and identify this kidney disease because of diabetes as early as possible. At the same time, we try and educate them by giving them a didactic lecture or have a seminar educating them about the life-threatening complications of diabetes. Almost always we include a dietitian in the talk, because diet has a very important role, as all of us know, in terms of modifying and reducing this disease burden. On the transplant front, we were the first ones to set up the swap transplant registry in India. This is essentially to encourage legal organ transplantation. And with the help of the foundation, we were able to perform the first 2 domino exchange transplants in India and probably in Asia for the first time in 2013 and 2014. Subsequently, a lot of organizations, and I know Ahmedabad Civil Hospital, Dr. Vivek Kutte and his program have also taken a legal big leap in terms of helping more and more people with swap donations. But this was something which was an effort which was pioneered by our foundation. In terms of the academic things, as I mentioned, the whole forum of starting from nephrologists down to dialysis technologists to family doctors to physicians, etc., need to be educated on a continuous basis, because so many things are happening. And if you look at even the drug treatments used for diabetic kidney disease patients, there have been a tremendous advance in terms of our drug armamentarium to tackle this disease. So continuous medical education on various forums, including nephrologists, physicians, etc., has always been an endeavor. And for the last 10 to 11 years, we have this annual conference for nephrologists from the region, where we invite 15 to 20 speakers from international and national forums and have a very, very dedicated sessions of online training for the nephrology community. The same thing goes for the dialysis technicians, who are the backbone for our dialysis efforts. And the Apex School of Dialysis Technology has so far trained more than 600 professionals. There was no formal course for dialysis technologists in India. And with our foundation support, we were able to help a lot of needy people who needed grants, etc., for pursuing their further education. And this is a vocational and technical education course in partnership with the Tata Institute of Social Sciences. And we are proud to say that we've been able to help 600 people become qualified dialysis technicians. Along with that, our Rotary support has been amazing. One of the clubs in Mumbai with whom we have partnered for a lot of Rotary grants to try and promote and help more and more kidney patients with financial support, emotional support, technical support for the technology course, etc., has been very, very reassuring. But if I was to tell you that we've been able to achieve a lot, unfortunately, this is just the tip of the iceberg. If all of us get together, we would have more and more avenues to try and help this patient population in terms of reducing their disease burden, reducing their financial stress, and somehow they give them a good quality of life. These are some of the medical camps that we have done through the foundation. And we use the Ganesh festival in Mumbai as a very big example of being a natural transplant that was done, ages ago by the Ganesh, Murti itself, clearly telling you that Ganesh itself has undergone a kidney transplant or an organ transplant by transplant putting it onto the head. So that's something that we use as a platform to promote organ donation and encourage legal organ transplantation in our country. Of course, it is governed by the Human Organs Transplantation Act, but from our efforts with the NGO foundation activities, we want to help more and more people with the option of transplant in a legal fashion across the country. So I would want to end here and not take extra time, and would be happy to answer or take any questions. Thank you very much for this wonderful opportunity.
It was really nice talk, sir, regarding the transplantation and legal way of doing it. Thank you very much. Our next topic is, are we meeting expectations? What are the ways of augmenting these efforts? By Dr. Sushil Patel, Consultant Diabetologist, Aksar Diabetes Center, Baroda. Over to you, sir.
Thank you, Dr. Arun Saxena, sir. So we are opening the session for this question answer and for the panel discussion among these panelists also. So first question, which was there for my lecture, that what is the role of tobacco in the diabetes management? So there is no direct connection like the tobacco chewing will increase the sugar level or decrease the sugar level. But there is always a connection that if the patient is diabetic, there will be increasing the risk of diabetes complication where if the patient is chewing the tobacco, because tobacco itself is adding on for the risk of macro and microvascular complication. Now I'm moving to the other question which has come from the audience to our esteemed speakers for this session. First question is for the Dr. Meenakshi. The most common nutrition practice in the India, which is harmful for the diabetic patients, particularly in the pregnancy in rural India, which NGOs should focus on?
Sir, I could not hear you. Can you please repeat?
Which are the most common nutrition practice prevalent in rural part of India, particularly in diabetic pregnancy, which should the NGOs should focus on?
Sir, unfortunately, I wouldn't say that nutrition practices are under a qualified professional in the rural parts of India. And so what I would suggest is the NGOs need to take up the onus of train the trainers. You know, at least the nursing professionals or the allied healthcare professionals who are in and around the rural areas, who are in access to the rural population, at least those who come for screening, you know, they come for screening for gestational diabetes or diabetes per se. At that point, they should catch them. You know, that's the ideal place where we can talk on nutrition, or we should have camps, or we should have mass media communication through radio or through television or through YouTube channels wherein we can reach the rural population. I don't think we are reaching the rural population. Yes, as I mentioned to you previously, the Tamil Nadu Health Systems Project has created a forum wherein we train a lot of healthcare professionals, entire team, you know, a nursing team, a medical professional, whether it is the medical colleges or the primary health centers, we train them not only in nutrition, in screening, assessment, as well as prevention and management, so that they take it further down. That's the only way an NGO can liaise between this and help strengthen the entire network.
Thank you, and thank you, ma'am. We have another question for the Dr. Arun Pal, sir.
Yeah.
Sir, should NGOs use the biothiometry or the handheld Doppler? Biothiometry and the handheld Doppler in the community to identify the high-risk food.
See, out of total 74 million patients in India, only 15% have a vascular problem. Okay. We see more vascular in a corporate or third level hospital, but community doesn't have that. I think you have to check neuropathy. The way to check neuropathy is a filament test, that is Semmes-Weinstein filament, which can be tested by paramedic, biostasyometer, or now there is a vibrometer which is easy to carry. There are now equipments which has all neuropathy testing in one set, which is like a, you know, old time MTNL or BSNL telephone hand receiver. So these are newer modifications are coming, but what is more important than testing, the paramedic or a community diabetic foot worker has to examine the feet. And, you know, as per the American Diabetic Association and even the Diabetic Foot Society of India, We have made, what is known as a 2-minute examination of the foot to risk stratify. What you need to do is just feel the dorsalis pedis, posterior tibial, try to separate the toes, see the dorsum of the foot, whether there are hairs on that, see the plantar surface for the scars, calluses, or existing ulcers, see what footwear patient is wearing. That tells you about vasculopathy, neuropathy, motor neuropathy, patient education about footwear and self-care. Then you can risk stratify. So physical examination, filament test, biosthesiometer or a vibrometer. These are, and now if you have this handheld, thermometer, infrared, which is very common with this COVID infection, these are the only equipment required.
Very well answered, sir. And another question for the Dr. Kim is that how much it costs to an NGO to use the artificial intelligence for the screening of retinopathy, and what is the turnaround time of diabetic retinopathy reports? Dr. Kim, are you there?
Hello?
Yes, sir.
Can you hear me?
Yes, sir.
Yeah, sorry.
Yes, sir.
Yeah, see, regarding the artificial intelligence, it's still not come into on a regular use for commercially available. There are various costs that are involved in it. People are just now coming with it because of the legal implications. It has to be approved by certain clinical bodies. Right now, they are CE certified, but there's no Indian body to certify it. But once it comes in, the cost is going to be very, very minimal. The cost will be more on getting the fundus cameras, the retinal cameras. That is what would be the cost. But the cost of grading or using the artificial intelligence is going to be really negligible.
Okay, sir. Thank you. So how soon we can expect this in the near future?
Anytime. There are a lot of people offering right now, but it's going to be another 6 months to 1 year. It's not very far off, at least for this, for diabetic retinopathy.
Thank you, sir, for this wonderful opportunity what we will get in the near future. Dr. Sudhir Sasar, we have one question for you. That is, what are the common myths for the symptoms and the management of diabetic neuropathy in the community? Dr. Sudhir, sir.
I think Sudhir sir is not there.
He is there. He is there, but it's muted. Dr. Sudhir, sir, are you there? Okay. So one last question among is that for Dr. Jatin Kothari, sir. Sir, what is the role of over-the-counter medicine for the diabetes management in the kidney failure?
So if you are pointing towards specific medications, yes, drug-induced renal disease is a big problem in a country where things are not regulated as far as medications are given by prescriptions. The commonest drugs used and abused by the population are painkillers like non-steroidal anti-inflammatory drugs. We all know that so-called nice is not nice. That's what I tell all my students about use of analgesics. Even the old terminologies of analgesic nephropathy used to refer to taking painkillers for a prolonged period of time. But we've seen in our practice, day-to-day practice, that even 1 or 2 tablets in the wrong setting can actually set in the entire issue of end-stage renal disease. So we need to be very careful about direct toxins like non-steroidal anti-inflammatory drugs. Just a comment on alternative medications, because that seems to be the flavor during COVID and even pre-COVID. Almost every patient who comes to my OPD has always tried homeopathy or allopathy or Ayurvedic, and I'm not averse to seeing these patients. I have nothing against these sciences, but I only say that, tell my patients that you try and do something which has some scientific basis, and hopefully, that will minimize the damage, especially to the kidneys. Other drugs like antibiotics, etc., which we also prescribe and very commonly use, we need to be careful even from our side, not blaming the patient alone, because partly, the problem is huge because of the physician involvement, and the physician himself is not, careful enough to use the right dose, use the right antibiotic, and use it only when it is required. So over-the-counter medications is something that we deal with on a day-to-day basis, and is one of the commonest reasons as to why kidney failure is such a big disease burden in our country and even abroad. I wouldn't shy away from saying that this is a global problem. It is not a problem only specific to India. If you look at Chinese herbal nephropathy and look at the number of papers that are published in scientific journals, the data is quite astounding. But yeah, it's a very, very common problem and something that we have to deal with on a day-to-day basis. Thank you.
Thank you, sir, for this wonderful answer. I think Dr. Sir is back.
Yes.
Sir, there is one question for you, that what are the common myths for the symptoms and management of diabetic neuropathy in the community?
Before I take that, I will add to what Dr. Kothari said, that I do have lots of patients coming up with Ayurvedic medicines, and I also don't usually mind, but I always like to check the content, and I always like to do FSL analysis whenever there is a doubt. To tell you the truth, I had at least 3 doctor patients who suffered from encephalopathy and seizures, and they were taking something related to lead as a treatment of diabetic thing. And so Rasayan medicines, particularly those who have metals inbuilt in their formula, they must be strongly discarded. We have to educate our patients for that. Anyway, coming back to the myths about neuropathy, many people, they feel that having some paresthesia and burning and tingling and pins and needles is a normal thing related to aging, and we should not bother. That is the biggest myth. Even with the first symptom of paresthesia, particularly if they are symmetrical, one should be very careful. Sometimes people feel that, dropping things from the hand is also because of the age or some other thing. Maybe I have not slept well, etc. But that is also wrong. Diabetic neuropathy, one of them is carpal tunnel syndrome or distal sensory motor neuropathy. They have n number of symptoms which I had mentioned. So we have to screen those symptoms very carefully. Whenever in doubt, we have to get the nerve conduction studies, etc. Many people feel that because of the weakness, we have to take some rejuvenant drugs and some vascular drugs that will produce complete relief from the neuropathy. Neuropathy is due to blood circulation disease, which is also a wrong thing. And number of other things like people use aphrodisiacs for importance, and this actually autonomic neuropathies don't respond to all these things. They have to undergo perfect diabetes screening program, proper treatment, and time to time checkup. So with all different neuropathies, like there are entrapment neuropathies, there are 33 entrapment syndromes, and all are most common with diabetes, right from carpal tunnel syndrome to fibular head syndrome, peroneal palsy, tarsal tunnel syndrome to scapular syndrome. There are several syndromes, pronatatory syndrome. These are all diabetic syndromes in turn. If they are not entrapped in between the muscle heads or some other fibers, they are usually diabetic in origin. So we have to educate people, remove their different myths. Even the doctors, medical doctors don't have proper education about diabetic neuropathy. So we have to train them. Very politely, we have to write back to them. These are the issues we have to address. Thank you very much.
Thank you, sir, for that wonderful answer. And I thank you all the speakers for their wonderful talk and answering the questions. So can I have the slides for the panelist? So we can start the panel. Nero, are you there? Can you share the slide of the panelist? We have 4 panelists with us. That is Dr. Purnima Sharma. She is a diabetologist from the Jaipur. Sorry, no, Dr. Purnima Sharma. She is a gynecologist and director at Rajdhani Hospital, Jaipur. Mr. Rohan Arora. He's the Delhi and Pune chapter lead, Blue Circle Diabetes Foundation. And we have Ms. Pradula Kapila Bhargav. She is a founder, Diabetes Power Fighter Trust, Public Health and Evaluation Professional. And Dr. Vishal Shah from the Ahmedabad, consultant diabetologist. He is inclined in the research and clinical work, Swasthya Diabetes Care Ahmedabad. So I would like to ask first to Dr. Purnima Sharma. We are missing a gynecologist over here. So can you tell us something that what are roles NGO can play in the awareness to common public, precisely the pregnant ladies, so that we can avoid the possible complications of it?
Hello, everyone. Can you hear me?
Yes, ma'am. Yes, ma'am.
Okay. First of all, we should know what is the gestational diabetes. Gestational diabetes is it's a glucose intolerance in the pregnant ladies in the second half of the pregnancy, and which have never been diagnosed for diabetes. And in this patient, there is maternal and fetal complications. So it is very necessary to diagnose this situation. In maternal complications, there is increased rate of cesarean section, and if the normal delivery is conducted, there may be injury to the birth canal, and there may be development of diabetes in the later half of the pregnancy in these ladies. And the fetus in these ladies may develop hypoglycemia, breathing problem, jaundice, and they may develop diabetes in the later half of the pregnancy. And in India, 5 million of women affected every year by gestational diabetes. So it is very important to diagnose this situation. And NGOs have many crucial role for this, because in India, the tests are available, but the peoples are not aware for this. So NGOs people can arrange an awareness campaign, educational programs. They can distribute the pamphlets, and they can arrange a meeting with the doctor, expert gynecologist, and with a diabetologist, so that they can make aware this woman about the gestational diabetes, so that we can reduce this type of complications, and we can explain the ladies about the diet and high risk factors of diabetes, and how can we decrease this risk of the maternal and fetal complications.
Thank you, ma'am. Thank you for that answer.
Okay,
I am going to Rohan Arora. So what is your take as an NGO leader? That I think that you had heard all the lectures. So what is your take as an NGO leader that how we can fulfill this expectation?
Thanks for inviting me to talk, and thank you to all the panelists for the wonderful talks. So I have been living with type 1 diabetes for over 11 years, and initially I was misdiagnosed as a type 2, and the information that I received from the doctors and the information that I got from joining an NGO and from the patients, so there was a gap. The doctor always told me to adjust my doses, but I could not get much information about diet, exercise, and all the other things that are required to manage my diabetes well. So there was always this gap. And when I talk to people who have lived through this disease for 15 to 20 years, I could get much more information and knowledge. And as people mentioned, there is a gap in education. So this gap, what we do in our NGO Blue Circle Diabetes Foundation is we try and fulfill these gaps. So as a person living with diabetes, I could bridge this gap because I knew English, I had an internet connection, and I could reach out to people to attain that knowledge. And what we found is people who lived in the rural sectors, people who don't speak English, who speak different languages, it's even more difficult for them to get this knowledge. And for that, we started a helpline for Blue Circle Diabetes Foundation called the Buddy Project. where we got trained in mental health and diabetes education, and we speak over 8 to 10 different languages, and we could reach out to people who are in the rural areas and provide them with this knowledge. And so there is a need to also have the print material as well as helplines in different languages in India. Prevention is better than cure. Also, reach out to schools, do more corporate awareness that we try and do at our foundation to detect the diabetes early and make sure that it does not progress to the advanced stages. Also, motivation is important, where the education, even if the education and all those things is there, patient needs to be the onus is on the patient to make sure that they fight this and do a proper care. So adequate motivation should be provided, and also mental health should not be discarded. So that's it, and thank you.
Thank you, Rohan. I am going to Ms. Mrudula Kapil Bhargav. What are the ways for augmenting the efforts? Or you are already doing your activities beautifully in your NGO, but what are the further ways for augmenting efforts to meet the expectation of the doctors? You had heard all the doctors right now in the different field. So what is your take on this?
Thank you, Dr. Sushil. So to answer this, I will actually add to all the panelists, as they said, and doctors, as they mentioned about the needs and unmet needs. To that, I would also like to add the experience as a type 1 person living with type 1 diabetes from past 28 years. As a public health professional working with People-to-People Health Foundation for access to insulin and diabetes supplies, and the founder of Diabetes Fighters Trust. What we actually found and actually we experienced as a from an NGO side, that just educating them is not enough. A person living with diabetes, or those who do not even understand what is diabetes, for them education is not just the only thing that they need. They actually need that word of mouth, that okay, yes, this is the person, this is the right person, this is the right treatment, that yes, this can actually treat us well, or it can give us the best opportunity to get the best treatment. Now, this is a point where we really need those people who are actually going to tell about the treatments, about the doctors, or anything about diabetes. We need here NGOs, and especially the patient-led NGOs, who can actually reach out to different other people across their communities, or in their neighborhoods, or people who are willing to support the cause and have knowledge about it. Another point that I would like to mention over here is, because doctors and NGOs, we all have the same goal. We just need to align our goals together so that we can reach the mass. Now, the problem here is when we say that doctors need to collaborate with NGOs. Unfortunately, we have those gaps, communication gaps, that okay, this is our patient-led innovation and or patient-led initiative, and we need your support. Sometimes doctors are willing to support, but they are not able to give their time. If we have a time slot maybe for these patient-led innovations or initiatives, and can talk to these patient-led groups about, let's say, like Dr. Arun sir said, that diabetic foot community worker is needed in the fields. So why not let's talk to these patient-led groups and train them about this particular cause, that okay, diabetic foot is definitely an issue. And when we go to rural areas, we have very minimal supplies, and there's very less access to all the diabetes management facilities. So these person-led groups can reach out over there, can actually train the community leaders, to the ashas, ANMs, who can further actually communicate the real information. Another point that I would like to talk about is the capacity building. Capacity building of not just the patients or the paramedical staffs or patient-led groups, but also the doctors. We might have doctors who are well trained in the private sector, but what about the government sector? They might not even know how to take care of an insulin pump. They might not even know how to take care of a sensor. How do we train them? And this was the point. All these points were actually discussed in the year 2019, when we brought in different panelists from different states, from different patient-led innovations and industries also. And we came together, and even Ayush, Department of Ayush was there, and hundreds of doctors were sitting there. And what we tried was to bring one or two panelists from that department itself, saying that what is the difference between type 1 diabetes, what is the difference between type 2 diabetes, so that their peers can actually understand that, yes, if my person, if someone from my own community is saying that we don't have a cure for type 1 diabetes, or we don't have a treatment for type 1 diabetes in Ayush, then that will impact a lot, because that is what I was trying to say in the starting. Word of mouth, bringing people from their communities themselves, making these communities realize that you have to take ownership of your own challenges is what is needed. And
Udula, we have to cut it short.
Yeah, just one point I wanted to say, that I think this platform has brought in so many NGOs together. I think utilizing this opportunity is the need of the hour, because now we all are connected, we are listening to each other, bringing in all the opportunities, and also like kind of demand and supply to serve the target population, that is people with diabetes, is the need of the hour. Thank you so much for this opportunity and platform. I'm looking forward, and my organization is also looking forward to collaborate and work together, be that rural areas, be that the urban areas, urban rural areas, anywhere. Thank you so much.
There were so many questions coming up from the audience, but because of the lack of time, we are not able to incorporate all these questions over here. But we will definitely show that our team and the panelists will answer you in your particular email or the WhatsApp ID, whatever you had provided to us in the conference email during the registration. You will get your answers. So just now I would like to invite Dr. Arun Saxena, sir, the chairman of this whole session. Are you there, sir? So I think we can conclude the session. There is a wonderful session on the expectation of all the stakeholders, all the diabetologists, and the neurophysician, then the nephrologist, the retina specialist, gynecologist, all are there. And we hope that we had get the clear message that what are the needs and what are the unmet needs about this diabetes management in the community. So we are concluding this session now, and I'm handing over to Dr. Neera Gupta for further proceeding. Thank you very much. Thank you to all the panelists.
Thank you so much, Dr. Sushil. Thank you, Dr. Saxena. Thank you all esteemed speakers and the panelists. It was actually the objective of this meeting to set the expectations right. We heard the diabetologist perspective, nephrologist perspective, neurologist perspective, and the foot care perspective. So that was the aim, and how NGOs can liaise with government to make a bigger impact on society. Thank you so much, all of you, for this wonderful, enlightening session. Let's move on to the next session, which is Art and Science of Diabetes Management. Science and art tend to coalesce in aesthetics, plasticity, and form. The greatest scientists are artists as well. This is said by Albert Einstein. So with this, I would want to invite the chairperson, Dr. Dhiren Patel, of this session, who is Director and Consultant Physician, Sanjeevani Hospital and ICCU Center, Surat. Over to you, Dr. Patel.
Yeah. Good evening, everyone. First of all, I would like to congratulate Dr. Mayur Patel and Dr. Yash Patel, Dr. Rajesh Sharma, Dr. Sushil Patel, and a whole team for this wonderful conference. I think it's a unique conference, and the first time it's happening in India, because 31 countries and 687 NGOs are taking part on this conference about diabetes. Today, we have a very interesting topic, how to consult a doctor. Should I Google, go with notes, or be specific? For this, we have very stalwart person, very eminent personality, Dr. Unni Krishnan AG from Pune. He is a chief endocrinologist and CEO of Chelaram Diabetes Institute. It's a well-known institute, diabetic institute in Pune, and he is very prominent academician. Over to Dr. Unni Krishnan, sir, please.
Thank you, Dr. Dhiren Patel. It's a pleasure to be here. Good to see all of you, Dr. Neera Gupta, and everybody else out there. Thank you, Dr. Mayur Patel and Yash Patel, for this opportunity. I'm going to share my screen, just a moment. I hope my screen is visible now and that I'm audible.
Yes, sir.
So once again, thank you for that. And my talk is, it's a pleasure to give this talk, which is a very new and interesting topic. And I know I'm not talking to doctors alone. I'm talking to people with diabetes. I'm talking to NGOs. I'm talking to a lot of multidisciplinary people. So I'm going to make it as general as possible. So let me talk about the little things that matter from the healthcare provider's perspective, as well as the patient's perspective. And this presentation is going to be from a chronic disease perspective, like say diabetes or thyroid disease management. So I'm going to divide my presentation into 3 parts: before entering the doctor's chamber, and during the consultation, and of course, leaving the doctor's chamber. So these are the 3 areas. And I've used these pictures just generally. So these pictures don't really mean anything, but I just thought I should use some light and colorful pictures to imply that a consultation can be a bright and enjoyable thing. It need not be a difficult task to visit a doctor, and that's very important. And that's what we have to do. So the title of my talk says, should you go with Google? Should you go with not with Google? So I think before visiting a doctor, if you're seeing your good old doctor, you are sticking to the good old doctor, no problem. But if you're actually searching for a good doctor and you are researching a good doctor, I think you must spend some time, not just on the internet or the mobile phone, but at particular different avenues. A famous doctor is not always the best doctor. The best doctor is a doctor who is there for the patient, who has the patient's confidence, whom the patient can call and consult when needed, when in emergency. So that's a good doctor. And of course, if you go with Google, you will be able to find some information about the doctor. Yes. But I encourage my patients to do a little bit more than that. I'd encourage people to just check on the internet, not just about the doctor's reputation and reviews which other people have given. I'd encourage them to find out a little bit more about the doctor in terms of the various opinions of the doctor. Whether the doctor is science-based, whether the doctor believes in observation analysis, whether the doctor is published papers or is involved in research. And fourth, whether the doctor is actually engaging with his or her peers, that means with colleague doctors, in discussing, understanding, and taking science forward. Or whether the doctor is using his or her website or social media or Facebook merely to promote themselves. There are a lot of doctors who promote social media platforms aggressively, and many of them are very good communicators. But I encourage people, if you're searching for a doctor, that not necessarily all people who are very media savvy and who are very good on social media or on websites are good doctors. And so therefore, look at the doctor's research, look at the doctor's publication profile, look at the doctor's general views and whether the doctor is engaging with the peers. But in my opinion, the most important reason is the reason I've shown on top. The most important reason is when the doctor is recommended by a friend or a relative or a neighbor or somebody you know. In my view, most people, most doctors practice building up I've seen is by word of mouth. So yes, Google will reinforce your faith in the doctor. A website or the publications or the discussion will also reinforce that faith. But the real faith, especially if you're going through a new doctor, has been recommended by a colleague or friend. Because many doctors can write prescriptions, many doctors can do tests, but only a good doctor will make the patient feel comfortable. And it's very important that a doctor makes the patient feel comfortable, confident, and motivated. This is especially true for a disease like diabetes, which is chronic, and the patient has to take care of the little challenges. More of that as you go ahead. So when you walk in to see a doctor, if possible, always try to take an appointment. That's very important, because without an appointment, the doctor may have somebody waiting for them. The doctor may be busy. The doctor may have some personal problem. Yes, we are doctors, but we also have our own little personal problems. Many doctors' children are going for 10th standard. Some doctors have family members who are sick. So try to take an appointment and go to the doctor, because then you have the doctor's full attention and time. But at the same time, if you're feeling ill, if you're feeling sick, always try to contact the doctor and see the doctor early if possible. Otherwise, you can go to the same institution where you are able to talk to the doctor in the casualty or a colleague doctor who will immediately get in touch with the doctor. So we've come to the end of my first point, which is before entering the doctor's chamber, what are the little things that we should be doing? Now let me talk about the consultation. So when you go and see the doctor, it's important to bring all your documents. I like it when patients come and show me little notes they have written. So notes about what are their symptoms, how long they have been having the symptoms, what is their view about the symptoms. They have not been exercising, so that's why the blood glucose levels would be high. Recently, they've had a function to attend and therefore the blood glucose levels are high, so on and so forth. All the reports, it's important that patients bring all the reports to see the doctor, even if it's an old report. For example, if the patient has had a thyroid problem, and if there's a thyroid swelling, if an ultrasound was done 5 years ago, even that report may be important, because if the patient comes today and you have an ultrasound done 5 years ago, you can compare the size of the swelling. So having an old report is very, very important. Images, very important to have old x-rays and new x-rays. For example, if a patient on a routine chest X-ray is showing a little bit of a scar in one area of the lung, and you have a X-ray done 5 years back showing a very similar scar, then you know that it is not anything ominous. Sometimes a patient thinks it is not relevant, and if it's not relevant, there's no need to bring it. For example, if there's a 65-year-old lady and the lady had an appendectomy, or a gentleman had an appendectomy at the age of 12, it may not be that important to carry it. But if you are in doubt, please bring all your reports. So nowadays, many people come with paper. Many people come to see the doctor with mobile phone reports. Well, doctors are comfortable to go through papers and files because that's what we have been used to. I'm also comfortable to go through mobile phone reports. But remember, when the mobile phone is so tiny and you have an elderly doctor like me, and I'm nearly elderly because I'm 50 plus. In fact, in our hospital, above the age of 55 years, we have something called Senior Citizens Health Package. And when I'm doing an annual checkup, I'm thinking, okay, after 2, 3, 4 years, I myself will have to go for Senior Citizens Health Package. So yes, we have, if the mobile phone is small, if the font is small, there are hundreds of pages. It's very difficult for doctors to read it, but we will still happily go through your reports. But remember, when its font is small, when the mobile phone is small, the chances of errors is very high. So try to bring paper if possible, or if you have a computer or a tablet, you can always show the reports on that. A small mobile phone makes it very difficult to read. So I've just put in this saying, do not be afraid of the ocean, because the ocean is made of little drops. So I think it's important to talk freely to the doctor, and you should go to a doctor who encourages people to talk. There is something called motivational interviewing. You motivate the patient to do better. One of the key principles of motivational interviewing is that you motivate the patient to do better for themselves. For example, if somebody is sitting in front of me and is talking, I tell them, you please talk. No, doctor, you may not be interested, but I went for this particular function and I ate this chocolate. I said, no, you tell me. Sometimes when the patient is distracted and talking about something else, I try to bring them back into the right direction of the disease in question. But sometimes it's good to let them talk, because then the patient will say, oh, I went to that party and I ate some pastry. The next day I was feeling stressed, so I ate another pastry, and it was a festival day, so I had some gulab jamun, and along with that I had the liquid of the gulab jamun, which contained sugar. So I let the patient talk some more, and then the patient will say, yes, my sugar is high. That's because of all these things, doctor. So what we have done in that setting is that the patient has expressed a problem, gone through the reasons for the problem, and the patient has also solved the problem in his or her mind. So getting the patient to talk about it and solve the problem on their own is going to have better results than the doctor saying, oh, did you go for a party? Yes. Did you eat gulab jamun? Yes. Don't eat gulab jamun. That's something which is very didactic, and the doctor ordering the patient what to do and what not to do. But I think if the doctor can be a good motivational interviewer, let the patient talk freely. But if the patient talks about something completely unrelated, like for example, some political issue or some floods in some part of the world, then you can gently nudge the patient into talking about what they should be talking about. So do not be afraid of the ocean. The ocean is made of little drops and also has some little gems, because when the patient talks freely, you might find out a little bit of the history. Oh, did that happen? Okay, that could explain this. So I think patients should be talking freely to their doctors. Now, keeping a mobile phone on during a talk, neither the doctor nor the mobile phone patient should have a mobile phone going on. If you are a doctor, give the mobile phone to a colleague or to somebody else, or keep it on silent. And if you're a patient, also do that, because it's quite distracting. Having PDF documents, again, it's very difficult to read PDF documents on mobile phones. Looking at the mobile phone, if a doctor looks at the mobile phone, the patient may think doctor is not interested. If the patient looking at the mobile phone, the doctor is saying, my God, पेशेंट हमें देखने के लिए आ गया और मोबाइल फोन के साथ बैठा है. So it's difficult. Finally, I want to say that nowadays a lot of labs do lots and lots of tests. Sometimes I just ask for a blood glucose test and an HbA1c test, which is really a simple test to know the sugars and sugar control of the last 3 months. Or I may ask for thyroid function test, but the patient will do a whole health package, and sometimes you'll find tests of copper, arsenic, lead, vitamin D, vitamin B12. I haven't asked for these tests. So then, you are finding out something abnormal in these tests, and then you don't know what to do. The patient doesn't know what to do, and the doctor doesn't know whether to leave it alone. So try not to do the tests which the doctor has not asked for. For example, copper, arsenic, and lead poisoning and all is extremely rare, and we do suspect it very rarely. Copper and arsenic. Arsenic poisoning is something which is very good in a Sherlock Holmes mystery story or an Agatha Christie's story or something like that, but really not good for a doctor's chamber to have arsenic reports or copper reports. So do not do tests which are unnecessary, because you will get diagnoses which are unnecessary and you may get investigations which sidetrack from the main issue. So do not do tests, and tell your lab only to do the tests which doctor has asked. If the lab says no, please do the whole package, and please show the doctor the test which he or she has asked, because then you'll get the right reports. So this is a study which I was looking at, is that while the 8 points are from the study, the rating given to them is mine, which is a rating which is equal rating. So one of the most important ratings, so how should a patient rate a doctor? I think one of the ways patient can rate a doctor is, did the patient address the concern? So if a patient comes to a doctor for diabetes, we should treat the diabetes. But sometimes patient comes and for diabetes, but the patient's main problem is a shoulder pain. Yes, it may be related to diabetes, but it can be treated by physiotherapy. So did the doctor address the patient's concerns? Second is the doctor explaining the patient's condition? That's very important for a patient to rate a doctor. So if the doctor has explained the condition, for example, what is diabetes? I think one question I always ask my patients when they come with diabetes is, why should we treat diabetes? And I'm very fascinated, because many patients tell me, हाँ sir, diabetes तो treat करते हैं क्योंकि इसमें organ dysfunction होता है. That why treat diabetes? Because it causes organ dysfunction. So I say, what organ? Sometimes the patient says it may be the the liver and the bone and some other organ. So I tell them, no, it affects the kidneys, the eyes, the feet, and the heart. A lot of problems, and increases the risk of infection. So it's important for the doctor to explain the condition in very simple terms and ways in which people can understand. The third is, so many doctors tell me patients are checking Google, patients are checking WhatsApp University, but I think I should encourage them to look at Google and ask questions, because when they ask a question which is genuine, and when you answer it, it stays in the patient's mind. So is the doctor giving an opportunity to the patient to question? Is the doctor encouraging the patient to participate? For example, if the patient says, Doctor, mujhe to ye karna hi nahi, I don't even want to take this medicine. So I think patient care is a mix of best science, best evidence, scientific evidence and guidelines, best experience by the doctor, and best choice of the patient. Sometimes patient's choices may be different, and we have to respect that choice, and we'll have to guide them to reach that choice. The next thing I think is to avoid jargon-free language. If I tell my patient with diabetes causes neuropathy, nephropathy, and retinopathy, patient will think, what is this neuropathy, nephropathy, retinopathy? So we can say it affects the feet, the eyes, the kidneys, and the heart. Then, as I said, it's important for the patient to feel comfortable. How patients will never forget how you made them feel, whether you were hurried, whether you examined them. In the early stages of my career, I realized that patients really appreciate if you auscultate their heart sounds and lung sounds, and that you spend some time examining them. And also, patients feel comfortable if you give an appearance of not being busy. Every doctor is busy. And for that matter, every patient is also busy. Busy executives have to travel all over the country or the world. Housewives have to juggle their housework with children's examinations and looking after elders and the kitchen. And house husbands also today participate in care, which is a good thing. They also help out with household chores. They help out with looking after the children's education and so many other things. So whether they are housewives or house husbands, I think both, or if they are working people, I think we need to understand that they are also busy, but we must try to give them appearance as doctors that we are not rushed. Did the patient give you all the information? Did the doctor give all the information that the patient wanted? And finally, did you ask the patient, have you checked if you have understood everything? Before going, I sometimes ask the patient, please check the medication list and be sure. There are two good things. Number one, patient has already completed everything and gone, and then the patient is not going to come back while you're seeing another patient. And if you're a patient, you're always thinking, Doctor Saab se to I forgot to ask this to doctor. Now, how can I go back and disturb him? So these things are also sorted out. So I've come to the end of the second part. I've looked at before entering the doctor's chamber, what you should do, during the consultation, what you should do, leaving. Now, before leaving the doctor's chamber, the most important thing is to ask whom to contact for emergency. A very busy doctor may not be able to pick up the phone always, but he or she will certainly have a colleague who can be contacted for emergency. And if the doctor can give you a number they can contact, fantastic. Second is to discuss the date of the next visit and any tests to be done for the next visit. And third is to check if the medication lists are proper. The doctor in diabetes or care, or in thyroid care, or in any care, especially in diabetes and obesity, is like a coach. The patient has to deal with the little temptations of life. For example, should they eat that snack in the evening? Should they not eat that snack? Should they exercise now? So our role is like a coach, and the patient has to deal with the little challenges in their day-to-day lives. And as a doctor, we have to make sure that if you take the cricket analogy, we have to make sure that the patient has an HbA1c of say 6 or 6.5 if possible through all the challenges. So our duty as doctors is to really motivate the patient. So I've come to the end of my presentation. I've talked about before entering the doctor's chamber, you must make sure that you have, if possible, you have an appointment, you have all the notes, the lab tests, the reports, the images. During the consultation, make sure that you go to a doctor who gives you time, makes you feel comfortable, rechecks, explains in simple language, and also takes care of your health. It's also important to go to a doctor who's recommended by other people, your friends and relatives, and also check out that doctor's profile on Google and social media and other aspects. You get an idea. And before leaving, make sure you have time for your next appointment, the date of your next appointment, the test to be done, and also you've got the medication list right. If you do all these things, the doctor-patient consultation can be very happy. And as I said, a doctor-patient relationship is a very divine relationship. Most people, though we hear of a lot of problems between doctors and patients, the truth is most patients trust their doctor and most doctors trust their patient. Done properly, if the patient and doctor make an effort, the doctor's consultation can be a very happy and positive and bright interaction. Let's hope that if you are a doctor, your patients trust you. If you are a patient, you have your doctor's full trust. And if you are an NGO or anybody else, you are able to facilitate that wonderful relationship between the doctor and patient. Thank you so much for listening to me. It has been a pleasure discussing and talking to you.
I think excellent lecture. Dr. Nikrishnan, you have given superb ideas and practical tips about the patient management, because it's very important nowadays. Before entering, during consultation and leaving, these are, I think you have given wonderful ideas and the practical approach, how to deal the patient about diabetes on every patient, I think. Really superb.
Thank you.
With this, now we are going to the next lecture. With this, I invite Dr. Madhav Desai sir. I think no introduction is required for Dr. Madhav Desai sir, because he is well-known teacher, our guru, and very well-known academician, and senior consultant physician from HCG Multi-Specialty Hospital from Ahmedabad, and he was past teacher of BM Medical College. Thank you, Dr. Madhav Desai sir, for accepting our invitation. And the topic is very interesting also. What to expect from second opinion? What to ask? I think this is going. Lecture is also going to be very interesting because Dr. Madhav is very practical ideas and knowledge about the every time. So with this, over to Dr. Madhav Desai sir, please.
Good evening, everyone. First of all, let me thank Dr. Mayur Patel, Dr. Yash Patel, Dr. Kush Patel, and the whole Swasthya team for bringing out innovation after innovation continuously for last couple of years and making me a part of the same conference. Thank you very much, all of you, and you've been doing a great job. And I wish the conference a great success like your earlier editions. The topic given to me is what to expect from second opinion and what to ask. So it's a very interesting topic, and let's see how I justify. Outline my talk. First of all, we have to understand what is second opinion. Who wants second opinion? Whether you want or your patients want or the relatives want or somebody else wants it. And when to seek second opinions? Dr. Digan, getting a second opinion, what should we be asking to the referring consultants? So let's go ahead. Suppose the patient has come for the first consultation these days, right? We feel that this is the first consultation, but in fact, that itself is a second opinion because our patients have already diagnosed his condition on the internet and he already has his own opinion about what he's suffering from, and we ourselves are giving the second opinion. That's the lighter side of it. In fact, the second opinion is something which should be taken very seriously and carefully. So, what is second opinion? The general meaning of second opinion is that opinion of a doctor other than the patient's current doctor. So if I am treating the doctor and if I have to show it to Dr. Mayur Patel, that becomes a second opinion, right? If you go by the dictionary definition of second opinion, the Merriam-Webster dictionary, which is one of the reputed ones, gives the definition of second opinion as advice from a second expert, such as a doctor, to make sure that the advice from the first such doctor is correct. So Merriam-Webster dictionary presumes that we already given the correct opinion and the other doctor has just to say that that opinion is correct, which is not necessarily each and every case. I beg to differ from that. There is another dictionary meaning of the second opinion from Collins Dictionary, another well-reputed dictionary, which is probably, to me, it fits more with our understanding of second opinion. That is, you ask another qualified person for their opinion about something such as your health. So regarding your health, when you ask some other doctor, that becomes a second opinion. So all in all, to me, the summary of second opinion is a second opinion is an alternative viewpoint or a corroboration. I am treating Mr. X with so-and-so drugs and so-and-so diagnosis and so-and-so treatment. And if he wants second opinion, the second opinion also either corroborates with what I am doing, what I have given, what I have suggested, or he may have an alternative viewpoint. Whenever somebody has an alternative viewpoint, you are right to get it justified. So that's about the second opinion. Now, question comes, who needs it? Either your patients need it, your relatives, patients' relatives need it, or you want second opinion because you are held up somewhere in the diagnosis or a management at some point of time. So it's very, very important that second opinion, who needs it has to be clarified first, and who is unhappy. The fact that the second opinion is required means either of the side is unhappy. I may be unhappy with my own line of treatment or expected line of results, or maybe the patients and relatives are not happy about it. So let's first see who is wanting the second opinion. But second opinion should not be taken as something negative outlook or a negative feeling. Patient has every right to get the second opinion, and if somebody suggests for second opinion, I shouldn't feel offended. Why should I feel offended when I am sure what I am doing is correct? So it's patient's right. It's your right also when you are not sure about the possible consequences of something that you are going to suggest for the first time. You can always ask the patient that it's better that we take the second opinion. So second opinion should not be taken as something in a negative connotation or something adverse. It's very much patient's right and is that of your right too. So one should not feel offended just because he has asked for second opinion. Never in my life somebody has asked for second opinion. Who are you to ask second opinion? That's not something we should be doing it. And I would suggest one step ahead. I would say when in doubt about the line of treatment that you are presently undergoing for your patient, better you yourself seek second opinion and you suggest your patient that I think Mr. Y is a better person at least to get a second opinion, or let the patient suggest that no, I know these persons and I am happy with that person. So fine. So let there be second opinion. Whenever in doubt, you must go for it. Or suppose patient have developed some new problems or new complications which is outside your domain. We are supposed to practice for which we are trained, we are confident about treating. So if something that happened outside your domain of expertise, it is better that you don't wait, don't hesitate and go for the second opinion. And another important situation when you are trying to give some new treatment, suppose something that has come last week only and I want to try in this patient because I feel that he is the right candidate for that, then or the treatment that is very expensive, right? So it is better that we tell the patient that this is a treatment which is still in the experimental mode, or maybe it's not an real indications but an offline indications, but in all my honesty and opinion that probably it is going to work for you, but you have every right to take the second opinion. This is more problem in the situations like surgical line of treatment, right? Physicians, it doesn't happen much except for the new molecules which have come now and where the indications are present but in an offline mode. So in that case, maybe you need to ask for the second opinion before starting a treatment. If I want to start a treatment for say collagen disease, something like the newer biologicals drug, it's better I would take the rheumatologist's opinion and then start the treatment. So that's what I mean by innovative or expensive modality treatment, better ask the second opinion. Now, if you ask me when will I second opinion, right, I'll always ask for the second opinion when I am myself not happy with my patient's outcome, right? So suppose we take the example of a diabetes. If the patient's diabetes is not under control, despite of all my efforts and despite of I know that the patient is also giving his best as far as the other part of the treatment like exercise or dieting is also is observing, still the diabetes is not under control, it's better that we go for the second opinion. Then if the patient develops some complications, right, during the course of the treatment, like may patient develop some other organs involvement like nephropathy, retinopathy, neuropathy, or during the course of the conversation you feel that the patient has got some depression symptoms, it's better that we ask for a second opinion. Here, in true sense, it is not a second opinion, but it's an expert opinion because this is clearly outside your domain of expertise. So, but still it becomes a second opinion. You can tell the patient that I feel that you need a second opinion and it's better that you go for it. Then sometimes the patients are really behaving very oddly or out of expectations, and they take away so much of our time and still they are never happy. Some patients are born unhappy. They are never happy. If you go by their reports, their sugar levels are controlled, their blood pressure is controlled, their weight is ideal. But when we say not well. So they are never happy type of persons. And these are the persons better we take somebody's opinion to corroborate what we are doing. Then hostile patients. In the course of your practice, you will come across few patients who are really agitated, hostile. They start from the day you prescribe a prescription of a drug or investigations. They start doubting, why did you send this investigation to this particular lab, or why did you write this statement of this particular company and something like this. So they are never happy with your line of actions. Maybe they don't know you, or maybe their very nature is suspicious, or the relatives keep on coming every time the relatives change and they keep on asking the questions that why do you want this investigation? Last month only we got for these investigations, and my another colleague is taking treatment of Mr. So and so. He's not getting any investigations. I go him only once in a year, something like this. Or he start doubting, sir, are we on the right track? Sir, do you think that the diagnosis is correct? And he keeps on quoting Google or his relative in the USA. These are the people I would consider them red flags. These are the ones where you should not take any chance, and it's better that you ask them to have another opinion of the doctor of their choice. In this situation, I would not suggest any doctor. I would say straight away, better you go to another doctor. And if you want, I'll definitely give a detailed note of what I thought, what I did, and why did I do this. And later bit, you go to another person's. Then unsatisfied persons. If the person is unsatisfied and is a very, very socially, very highly influential persons, all that we call it VIP patients, right? VIP patients, at least I am not fond of treating VIP patients or keep on telling that so and so is my patients. They are the patients who can make you or who can break your reputations just for their own good. So I would say if the patient is highly influential and unsatisfied with treatment, you better offer volunteer second opinion, and you tell them that I am ready to help you to the referring doctors, but please take second opinion. It's very, very important. Then what to ask in the second opinion? That is the second part of my talk. But before that, let me tell you that second opinion is something not going to be very common nowadays. I remember one of my patients, I went in the morning for giving a second opinion in my another colleague's friend's patients who is pyrexia of unknown origin. And it may so happen that I saw a patient whom I have been following for last almost 3 to 4 weeks and was not coming to a conclusion. So in the evening, I referred somebody else for the second opinion. Morning, I was the second expert. Evening, I asked for second opinion. So it's very common. And in these days of the information exchange, information explosion, and the presence of all these search engines like Google and all, I think the patients are well informed, and we should not be at all get offended when somebody asks for the second opinion. We should ask for the second opinion. And whenever we ask second opinion, we must keep a detailed note of what we have done so far, what investigation we did, what line of treatment we suggested, what is in our thinking as far as the next line of statement. And we ask the referring doctor specific questions that this is my diagnosis A, B, C, or these are my differential diagnoses. Is there an alternative diagnosis or an additional diagnosis, something that really I have missed it? It's possible, we are human, we can make mistakes, no doubt about it. So let us remain open, transparent, and seek the right answers for our patients. We suggest investigation and ask them what investigation need to be done, and let there be some explanation from him or her why the patient's therapy is not coming under control. So that's very, very important. We need to know this. Then we ask ourselves, could I have done better? Could I have changed from A to B drug, or could I have started this drug first, this group of drugs first, then the second ones? Why did the referring doctor suggest this and he got a better result? So it's for learning. Second opinion is always for your own learning too. And what changes in the treatment are suggested by the referring doctor, that we need to know. And see, here we have a right to just get justifications. If I am prescribing the SGLT2 of a particular brand and then group, and the referring doctor suggests another ones, we need to know that, sir, can I tell me why you prefer these drugs? Is there any specific rationale? Or if I am prescribing one sulfonylurea and he's prescribing another sulfonylurea, is there a justification? So that is well within our right, but we need to know and get convinced ourselves. Suppose there is a difference of opinion. We have referred Mr. X to Mr. Y, and his opinion is something different than what I suggest, right? This is the time when I think the ball lies in the patient's court. You tell the patients that maybe we have taken the second opinion, I respect his opinion, but I stick to my opinion because I feel that I'm on the right track. Now, I cannot start somebody else's treatment. It's you who have to decide whose treatment you want to follow. So that is very, very clear. It should be made very clear that I'll seek as many opinions as you want. But if the opinion corroborates or make me wiser, I'll definitely continue with the treatment. Rest, you have to decide. So you need not continue treatment of somebody else's wishes. So to summarize my talk, second opinion is the right of the patient as well as the treating doctor, and neither party should feel offended or hurt when that question is asked. If second opinion is suggested by either side, handle it very tactfully. That means there is some element of dissatisfaction, unhappiness, and that has to be resolved so that we don't lose our peace of mind, we don't lose our patients or the entire family. And as I said, it's very much right in the patient's domain. Discuss frankly and honestly with the other doctor. As I said, all these things could I have done better, what could have been done, why this investigation done, why this investigation are required now, and why this treatment is changed. So it's very much important to get the justification from the reference. And when it comes to difference opinion, let the patient decide whom he want to follow. So this is all about what we need to do when we refer the patient to some other doctor. Thank you all again. And if there are any questions, I'll be happy to take. Thank you.
Thank you, Dr. Madhu Desai, sir, for giving clear-cut idea about second opinion. And I think it's really needed when we are doing practice, for safety of our all patients and as well as doctor also. With this, really, I going to the next session, and it's really very interesting topic and very useful for our day-to-day life also. With this, the topic is holistic health as a wisdom. And with this very eminent personality, celebrity, Gurudev Sri Sri Ravi Shankar Maharaj, the art of living. I invite Dr. Neera Gupta to give introduction and invite Gurudev ji. Please.
Thank you so much, Dr. Dhiren Patel, sir. Gurudev Sri Sri Ravi Shankar ji is a humanitarian, spiritual, divine leader and an ambassador of peace. What all words are limited in praise of him. Let's hear and watch one documentary before we move on.
In an era when ancient wisdom was buried under years of ritualistic practices, when games became wars and wars were played like games, a young boy was found in deep meditation in a quaint village in South India known as Ravi Shankar. He would say, "I have family everywhere. People are waiting for me." He astonished his teachers by reciting the Bhagavad Gita at a tender age of 4. With his education in Vedic literature and physics and his deep and profound knowledge of the spiritual world, he became one of the most prominent sages of the modern world. All through his life, he has been reviving ancient knowledge and creating tools and techniques that have benefited millions across the globe in living a deeper and a more joyous life. In 1981, the art of living was established by Gurudev Sri Sri Ravi Shankar. Nurtured by his care and contribution, the art of living has rapidly grown across 156 countries, reaching over 450 million people.
More people are searching harder for inner peace these days. Would you agree?
Correct. One of Gurudev's most unique offerings to the world is the Sudarshan Kriya, a powerful breathing technique that facilitates physical, mental, emotional, and social well-being. He has designed 57 exclusive courses that empower individuals and cater to the needs of a wide spectrum of institutions in the society. Back then, Gurudev started the Art of Living service projects by taking responsibility of reviving a sinking school which had no funds. Today, his intention has manifested in over 702 free schools, which provides education and food to more than 80,000 children in rural and tribal parts of India. During the COVID-19 pandemic, the Art of Living Foundation pioneered the I Stand With Humanity initiative, providing more than 80 million meals to the daily wage earners in over 170 cities across India. The service initiative during the pandemic included the distribution of 6,000 tons of food to 5 million families. It helped set up 7 COVID care hospitals and provided with over 200,000 PPE kits. Trauma relief programs were also conducted for more than 1 million migrant laborers and COVID warriors to bring mental relief. To combat the fear, stress and anxiety during such times, Gurudev launched the World Meditates campaign and also personally conducted online guided meditations twice daily, touching the lives of millions by bringing solace and keeping the hope alive. From childhood, Gurudev had immense faith in the principle of non-violence. With escalating violence and conflict in the world, Gurudev has brought peace in situations where war seemed like the only solution. Thousands of militants and Naxalites laid down their weapons and chose meditation in the northeast and other parts of India. His efforts include bringing an end to a 52-year-old fierce conflict between the FARC and the Colombian government.
Ojalá podamos los colombianos
Recording in progress.
avanzar pronto el principio gandiano de la no violencia. Coincidimos con el maestro Shankar.
Gurudev has visited Iraq several times and addressed peace conferences to bring respite to the nation and its citizens. He has hosted a series of trust-enhancing interventions in Jammu and Kashmir, providing all the stakeholders to voice their opinions in an effort to restore peace in the valley.
I was named Muhammad, but after becoming a militant, I was called Khalid. We had been taught to operate guns, arms and train other youths. But now, after doing the Art of Living course and meeting Sri Sri, we realized we had chosen the wrong path. We now want to spread love and non-violence in Kashmir.
Gurudev's programs have impacted people involved in armed conflicts across the world, making him a global ambassador of peace.
We gather today in this wonderful occasion of tolerance, blessed by our Master of Love.
Gurudev strongly believes that behind every culprit, there is a victim crying for help. The Art of Living prison program is helping to rehabilitate the prisoners. It has reached out to over 800,000 prisoners globally and has brought immense transformation in their lives.
I used to actually look forward to fights. But now since doing this course, I'm a total different person. I can now walk away from a fight.
I don't think any human being is totally bad. If he's bad, it's only his understanding, his behavior, his actions. But there is a good side to him. I only see that.
The Art of Living's Welcome Home Troops project has transformed lives and brought veterans out of aggression and depression. 94% of these veterans who were suffering from the unseen wounds of war reported peace of mind and reduced stress and anxiety levels. The Art of Living has also been working towards the betterment of the environment. 48 rivers and thousands of water bodies in India have been revived. Conducted more than 100,000 cleanliness drives. Planted over 81 million trees in 36 countries. More than 2.2 million farmers have been trained to adopt natural farming till date. Gurudev found the Sri Sri Rural Development Program Trust to empower rural India. Volunteers have developed thousands of model villages across India, providing solar energy to over 90,000 individuals under Light a Home project. Gurudev's vast global network of volunteers is well known for mobilizing trauma and disaster relief for the affected populations around the world. In a world torn apart by religious, social, national and cultural divides, Gurudev's vision is to see the whole world as one family. The World Culture Festival. The festival brought together over 3.75 million people from 155 countries with spectacular performances on a breathtaking 7-acre stage equivalent to 6 football fields by 36,602 dancers and musicians from around the globe, celebrating the diversity of all faiths and cultures. The Art of Living has hosted historic events leading to multiple Guinness World Records.
If you can have a mind of a scientist and a spiritual force of His Holiness Sri Sri Ravi Shankar Ji gives, then we have a beautiful world and happy world and prosperous world.
And organizing competition on earth could ever dream of.
The Art of Living Foundation. For 25 years, it worked on programs promoting peace, combating violence and drug addiction, empowering our youth. It has an incredible following that cuts through all religions, cultures, and backgrounds. A very, very difficult thing to do in today's world.
Gurudev has been conferred with numerous awards around the globe, including the highest civilian award of Colombia, Mongolia, and Paraguay. The Padma Vibhushan, one of India's highest civilian award, and 23 honorary doctorates globally. His vision for the world is to see a smile on every face and create a stress-free and violence-free society.
The voice of peace, the voice of truth should be heard loud and clear.
Finally, the moment we all have been longing for. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Par Brahma, Tasmai Shri Guruve Namah. Guru, my teacher, you are the creator, you are the protector, you are Supreme Lord. We all salute you. Aapka hardik abhinandan, Gurudev.
Namaskar, namaskar, namaskar.
नमस्कार गुरुदेव.
नमस्कार. कहते हैं वैद्यो नारायणो हरि, हर एक वैद्य नारायण से कम नहीं है, क्योंकि नारायण दुनिया को संभालते हैं, वैद्य व्यक्ति के जीवन को, उनके शरीर को, उनके मन को संभालते हैं. तो आप सब वैद्य रूप नारायण हैं. आप सबको बहुत बहुत अभिनंदन. आप समाज के सेवा में जुटे हुए हो. It's so nice to hear the first international conference on innovation by NGOs in diabetic care. We need to tell people what they should do, not just take medicine, but how their lifestyle should be. Wellness के लिए काफी उनको बताना पड़ेगा, समझाना पड़ेगा, क्या खाएं, क्या नहीं खाएं. भोजन से और व्यवहार से, आचार से, विचार से सेहत बनती है. Your health is dependent on what you eat, what you do, what you behave, what you think, and how you behave also. So in the West, the science is divided into so much compartments. Finally, a person is lost where to go, what to do. वहाँ behavioral science अलग होता है. Then there is psychology, which is completely different. A psychologist has nothing to do with, the neurologist. Neurologist doesn't know anything about heart disease, and both of them don't know anything about diabetes. इस तरह से बहुत compartmental होके हम एक system को, जीवन को जी रहे हैं. अब समय आ गया है, we have to see a very holistic view. जीवन को एक समग्र दृष्टिकोण से देखना बहुत आवश्यक पड़ गया है. इस दिशा में NGOs काफी काम करने लगे हैं. ये बहुत हर्ष की बात है. अपने यहाँ पर भी जो आयुर्वेद का डिवीजन है, इन लोगों ने भी निकाला डायबिटीज के लिए. आयुर्वेद में क्या कहा है, सिद्धा मेडिसिन में क्या कहा है, इस पर शोध की आवश्यकता थी. उस शोध करके काम कर रहे हैं. मेघांत तक करके एक ये मधुमेह पुरातन
हमारे स्क्रिप्चर्स में लिखा हुआ है। मधुमेह मीन्स डायबिटीज हैज बीन देयर फ्रॉम लॉन्ग टाइम। उसको दूर करने के लिए क्या करना चाहिए? तो योग, आयुर्वेद, ध्यान, इस सब में इसके बारे में लिखा है। हमें इस पर और गहराई से रिसर्च की आज आवश्यकता पड़ गई है। हमारी परंपरा के एक बड़े आचार्य गोविंद पादाचार्य, उन्होंने कहा रसे सिद्धे करिष्यामि निर्दारिद्रमिदं जगत। माने ये जगत में वो अल्केमी तक गए थे, अल्केमी में गए थे, फिर आयुर्वेद में गए थे, जड़ी बूटी में गए। तो निरोग होना ही निर्दारिद्र रहना है। सब कुछ रहने पर भी यदि रोग से हम मुक्त नहीं हैं, फिर उस संपत्ति का कोई मतलब नहीं है। वो वैसा ही है कि दरिद्रता ही है। इसलिए आरोग्य लक्ष्मी, आरोग्य सबसे बड़ा धन है। आरोग्य अपना माने अपने स्वास्थ्य को अपने को ध्यान में देखना है, रखना है, तो हमें अपना आचार विचार व्यवहार को भी ध्यान में रखना पड़ेगा। अब देखिए हमारे देश में भोजन में हम क्या करते हैं? चावल, रोटी, दाल थोड़ा सा लेते हैं, मगर अधिक तरफ से क्या भोजन करते हैं? आलू, बैंगन, टमाटर जी। ये कितने तरह की स्टार्च हो गया। इतना स्टार्च, इतना कार्बोहाइड्रेट लेते हैं, very little protein we take, and this has affected the health of our whole nation. स्पोर्ट्स के लिए कितने बच्चे फिट है, यदि ये अंदाज लगाते हैं स्कूल्स कॉलेजों में बहुत कम 7-8%, 10% कम बच्चे स्पोर्ट्स के लिए फिट नजर आते हैं। क्यों? हमने भोजन नहीं कराना सीखा। यदि हमने अपना ट्रेडिशनल वे में जैसे भोजन होता है उस दृष्टि, वहां पर दृष्टि लगाए, वहां पर बड़ा बैलेंस्ड फूड थी, इतना मात्रा में प्रोटीन। हमको याद है जब हम बचपन में हमारे नानी जी जब चिड़िया के लिए चावल रखती थी, उसके ऊपर थोड़ा दाल और 1 चम्मच घी डाल के फिर उसको वैश्वानर सेवा में लगती थी, वैश्वदेव, बलि वैश्वदेव करती थी। उसके बगैर भोजन नहीं होता था। घर में जब चावल परोसते थे उसके ऊपर अवश्य घी डालते, अन्न शुद्धि कहते, थोड़ा घी डाल के उसके ऊपर थोड़ा दाल डालते। बगैर दाल के कभी चावल खाना और बगैर घी के चावल खाना मनाही था एक तरह से। फिर क्या क्या, हरी चटनी हर रोज होना ही है। ये जो हमारी जो परंपरागत भोजन की तरीका है, एक तरह से बड़ा अद्भुत लगता है। और वो इतना निरोगी रही, स्वस्थ रही, 95 साल तक जीती रही, खुद भोजन बनाती थी। और उसके अब नेक्स्ट जनरेशन में वो ताकत नहीं रह गया है। और हमारे जनरेशन आते आते तो और भी हम लोग कमजोर पड़ते गए। इसका कारण भी मैं ये कहूँगा कि बैलेंस्ड डाइट या न्यूट्रिशनल फूड का बहुत ये अहम स्थान है हमको निरोग रखने के लिए। उस पर हमने ध्यान नहीं दिया, लोगों को इसके बारे में समझाया नहीं। हमने इन सबको टुकरा दिया। अरे ये क्या द्वादशी के दिन तुमको ये अगसे सुप्पू बोलते हैं, यहाँ पता नहीं क्या बोलते, वो साग खाना ही है क्या? People used to make, our previous generation used to make fun of them when they said they must have drumsticks at least 2-3 days a week. Drumstick is something which was very commonly used in South India. If you go to Kerala, Tamil Nadu, Karnataka, hardly anybody will cook without some of these traditional vegetables. ड्रमस्टिक्स का, और ड्रमस्टिक में आज कहते हैं मोरिंगा लीफ। विदेशों में छोटे से पैकेट को $35 देके लेते हैं, इतनी सी। यहाँ यदि देश में कुपोषण है, there is malnutrition in this country, we can eradicate that by planting drumstick trees in every home. Every home is supposed to have one kela, one banana tree, tulsi, neem. These are all our traditional things that our people had said, but we have today forgone almost all of them. So we need to again bring these values to villages. Kannada में कहते हैं ऊटा बल्लवनिगे रोगविला. If you know how to eat properly, you will not get any disease. ये इतना सच है, जैसा अन्न वैसा मन, हिंदी में भी अपना कहते हैं. तो यदि मन खराब है तो अन्न में कई दोष है. तुमने कुछ ठीक से भोजन नहीं किया, भोजन में कुछ कमी रही. इसलिए मैं पहली बात ये कहूंगा भोजन. इसके बाद व्यवहार. व्यवहार में क्या? सांस लेना भी हमको सिखाना पड़ गया. देखिए महामारी आई तो सांस पर ही इसका लांछन रहा. सब लोगों को पता चला कि हमें सांस लेना इतना एक माने जीवन का ऐसा एक अविभाज्य अंग है. ये समझने में हमको एक महामारी से झेलना पड़ गया. ऑक्सीजन जगह जगह ऑक्सीजन की कमी हो गई. प्राणायाम करें, अपना ऑक्सीजन लेवल अच्छा बनाएं. ये बहुत आवश्यक. 10 मिनट हर व्यक्ति कुछ प्राणायाम करे तो काफी हद तक उनका सेहत ठीक रहता है. और इसके बाद मन, मनोमय कोश, अन्नमय, प्राणमय, फिर मनोमय कोश. मनोमय कोश में जहां उत्साह है, प्रसन्नता है, वहां व्यक्ति हर चीज को झेलने में समर्थ हो जाता है. आई यूजुअली से a strong mind can carry along a weak body, but a weak mind cannot carry along a strong body. शरीर में बल के लिए बहुत आवश्यक है, मन में उत्साह होना आवश्यक. तो मन का उत्साह और बुद्धि की शार्पनेस के लिए हमें अवश्य ध्यान करना चाहिए. एक्सरसाइज, प्राणायाम, आसन, थोड़ा ध्यान, ये सब हम करते रहेंगे तो लाइफस्टाइल चेंज होता है. लाइफस्टाइल चेंज होते ही फिर हम रिवर्स भी कर सकते हैं इन सब जो डिजीज जिससे लोग जूझ रहे हैं आज. तो मैं बहुत खुश हूं कि आप सब लोग इस बारे में चर्चा कर रहे हैं, कॉन्फ्रेंस कर रहे हैं, और इस पर और नई नई बातें उमड़ आएगी. आप इन सब बातों को संकलन करिए और गांव-गांव तक इसको पहुंचाने की चेष्टा करें. ये बहुत आवश्यक है. हम बुद्धिजीवी, हम सब लोग अच्छी ज्ञान तो इकट्ठे करते, मगर वो गांव तक पहुंचने के लिए जो परिश्रम चाहिए उससे कहीं पर वो कमी रह जाती है. उसमें भी आप ये सहायता कर सकते हैं. एक छोटा सा 10-15 पॉइंट का क्या क्या एक डायबिटिक पेशेंट को करना चाहिए, क्या नहीं करना चाहिए, एक पर्ची बना दें और उसको गांव-गांव तो पहुंचाने के लिए हम भी आपके साथ हैं. हम उसमें पूरी तरह से सहायता कर सकते हैं. मैं इतना ही कह के आप सबको फिर से बधाई देता हूं. आप सब नारायण स्वरूप हो तो आप अपना इस तरह के उत्तम से उत्तम काम करते जाइए. यहाँ पर देखिए, हमारा लक्ष्य है स्वास्थ्य. कैसे लोगों का स्वास्थ्य, समाज का स्वास्थ्य ठीक रहे, ये अपना लक्ष्य है. इसमें ये नहीं देखना है कौन सी पति है, एलोपैथी है, होम्योपैथी है, आयुर्वेदा है, कौन सा सिस्टम है. इस सिस्टम के झगड़े में नहीं पड़ना चाहिए. आज अमेरिका ने भी अपनी ये बैरियर जो लोहे का दीवार लगा के बैठे हुए थे उसको तोड़ के होलिस्टिक सिस्टम पर वो भी उतराए हैं. ये यहाँ तक आते हैं कि मंत्रा चैंटिंग वगैरह भी उन्होंने हॉस्पिटल्स में अलाउ किया है. हीलिंग एंड मंत्रा चैंटिंग इज आल्सो पार्ट ऑफ होलिस्टिक हेल्थ करके. तो मैं आप सबसे ये अनुरोध करूंगा कि आप भी एक विशाल दृष्टिकोण से देखिए. सब पति के ऊपर परम पति है. वो एलोपैथी, नेचुरोपैथी, सबके प्रति उमापति है. शंभु है, ईश्वर है, शिव है, तो उनकी कृपा से सब चलेगा। पशुपति के चरणों में रखते हैं अपना ये सारे जो तरह तरह की हम लोगों के विचारधाराएं हैं, इनको एक समग्र रूप से, एक समूची रूप से करके जनता के सामने रख के हम भारत को और भारत के द्वारा दुनिया में लोगों को रोग मुक्त रहने के लिए हम सब लोग प्रयत्न करते हैं। इतना ही कह के मैं आप सबको फिर से बहुत बहुत बधाई देता हूँ और आशीर्वाद अभिनंदन के साथ हमारा वाणी को विश्राम देते हैं। ओम शांति।
राजेश में
बहुत बहुत धन्यवाद, हम आपके आभारी हैं। और आपने जो सुझाव दिया है 15-20 पॉइंट्स का बनाने का, वो हम जरूर इम्प्लीमेंट करेंगे। और आप, थैंक यू।
Thank you, Rajesh, and over to Dr. Dhiren Patel, sir, for the further proceedings. Thank you.
Recording stopped.
या गुरुजी को सुन के सच में ऐसा लगा कि आई थिंक वी हैव टू चेंज आवर अप्रोच एंड वी एवरीवन शुड फॉलो द होलिस्टिक अप्रोच। उन्होंने बहुत अच्छा बताया कि एलोपैथी, होम्योपैथी, आई थिंक द ऑल पैथीज, आई थिंक वो सब छोड़ के अल्टीमेटली द एम शुड बी फॉर ऑल लिविंग द हेल्दी लाइफ। एंड उसके लिए अपना अप्रोच एकदम गुरुजी ने जो बताया वो वी शुड फॉलो ऑल द पॉइंट्स। और उन्होंने जो बताया कि जो प्रिवेंशन के लिए डायबिटीज प्रिवेंशन for all over the country, we should make that points and follow the guidelines to the everyone and वो properly implicate करके वो prevention के लिए हम लोग सब साथ में जुड़ जाए, वो मेरी सबको request है। With this, now we are coming to the next session and that very interesting topic, how to handle disease progression and its complications, monitoring recurrent symptoms, frequency and other issues. With this, I invite Dr. Disang Patel. He is a consultant diabetologist, Glucoville Diabetes Center from Baroda. He is a moderator. And I invite also all the panelists, Dr. Jimit Vadgama, from Surat, Dr. Rima Rao from Rajkot, Dr. Kush Patel from Ahmedabad, Dr. Vibhakar Vachchajani from Rajkot, Dr. Heli Shah from Ahmedabad, and Dr. Rupen Panchal from Ahmedabad. I request every panelist to join with this session and make more interactive session. Over to Dr. Disang Patel.
Thank you very much, Dhiren sir. And first of all, congratulations to Dr. Mayur sir, Dr. Yash Patel, Dr. Susil, and entire organizing team for organizing such a wonderful conference, with a very innovative concept. So, secondly, I also welcome all the panelists for this interesting session on diabetes complications. So we are going to cover the various diabetes complications like diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, diabetic foot disease, and how a patient should approach, or how this discussion can be helpful to the NGOs who are participating and who are involved with the patient care. So with that concept, let me begin the discussion round. So my first question is to Dr. Jimit Vadgama. That what is diabetic neuropathy, and what are the symptoms and signs of diabetic neuropathy that the patients can identify and can immediately approach to the doctor?
Good evening, Dr. Disang Bhai, and thank you, Dr. Mayur Patel sir, Dr. Yash sir, and Dr. Sushil Bhai for inviting me here. And we are having a great conference. After the great talk by Guruji, we'll be seeing how to reduce the complications. Guruji has mentioned that we can reduce the occurrence of diabetes and all lifestyle disorders by simple measures in day-to-day life. But once diabetes has occurred, we will be facing too many complications of diabetes. And one of them, a very common complication, is diabetes neuropathy. What is neuropathy in simple words? Is your nerves are getting damaged due to high sugar level. So that is called diabetic neuropathy. Nerves, they conduct the sensation from the brain to the organs, or even from the organ to the brain. That's why if they are getting damaged, there are sensation defects. Features, usually the features are pain in the legs, or the tingling, or the numbness, or there is burning kind of sensation, or patient seems that the chappals are getting out of them, their leg while walking, or sometimes what happens, even if they get some injury in the foot, they are not aware of it. So these are the common symptoms of diabetic neuropathy, and it is very, very common, and it is one of the commonest complication of diabetes because of high blood sugar level. It is one of the first complications also if you have long-standing diabetes, and very unfortunate that we don't have any I would say 100% curative treatment for this complication. Even though diabetes is so long, so much research is going on. So unfortunately, there is no 100% cure available for them. Only there is majority of part, there is symptom relief, and good blood sugar control will help you relieve the symptoms. And there are medications available, right, which can suppress the symptoms. But unfortunately, we don't have any 100% cure in this complication. Very important thing is diabetic neuropathy is the commonest reason leading to amputation. Foot amputation, we commonly see very dreaded complication of diabetes. It is mostly due to this neuropathy, and patient is not feeling anything, even with the ulcers or even with the thorn going into your feet. They are not able to pick that, then it gets ulcerated, infected, and then it needs to be amputated, or the legs needs to be cut. It's a very dreaded complication, but very important thing, it can be prevented.
So yeah, definitely diabetic neuropathy is one of the very common complication of diabetes. And as you rightly said, ultimately some patients can ultimately go to the diabetic foot disease. So we have Dr. Vibhakar Vachrajani sir, who has ample experience of treating the diabetic foot disease since years. So my question is to Dr. Vibhakar Vachrajani. What is the diabetic foot disease and how it can affect the quality of life of these diabetic patients?
So, am I audible?
Yes, sir.
Yes, sir.
Okay. So, good evening to all, and thanks to the organizers for inviting me. Let me tell you, diabetic foot disease is a combination of infection, neuropathy, and peripheral vascular disease. As it is said, that diabetes affects all parts of the body, like neuropathy, already said by Dr. Jimmy. It is a combination of all these three triads, and that's why there is a problem. So, quality of life, because of neuropathy, there is unknown injury, maybe shoe bite, maybe thorn injury, or any injury which occurs because of the neuropathy. Then there is secondary infection and problem. Very important thing, diabetic patients are many times having addiction, tobacco, alcohol, smoking, etc. So that adds to the vascular problem and skin. So that causes a crisis. After infection, little of infection or smallest of injury causes the gangrene, or it may be worsening of infection. So by and large, because of diabetes, because of uncontrolled diabetes, a sequence of events happen, and adds to it is the addiction, etc. Okay, Dishanji?
Okay, Dishan.
Wonderful.
We have also Dr. Madhu Desai sir, Dr. Rumandru, Dr. Mayur Patel. I think we can have an expert opinion from them also for this discussion.
Yeah, definitely. I will go one by one to all of them. But now, after the foot, let me come to the eye, a very important organ of our body. And we know that diabetes can also affect the eye. So we have Dr. Kush Patel, who is the retina specialist. So my question is to Dr. Kush, that how the diabetes can affect our eye, what are the symptoms of it, and how frequently a diabetes patient should go for a regular eye checkup.
First of all, thank you for such a nice conference and inviting me for the panelist discussion. So we all know diabetic retinopathy is most common complications affecting the eye due to diabetes. But apart from that, there are many factors that involve in the eye, starting from conjunctivitis to keratitis and multiple organ involvement in the eye, along with uveitis. Earlier, the glaucoma development, along with the highest chances of early development of cataract are noted in the diabetic patients. But the most dreadful complications we know is diabetic retinopathy, and most commonly patients come with symptoms of diminution of vision, which may be gradual loss of vision, and along with floaters and flashes in the eye, and it is most probably most likely to be non-painful. So yes, diabetes affects each and every structure of the eye, and each problem has unique treatment and unique approach of management requires. And as far as the concern of eye checkup for diabetics, we generally recommend that each and every diabetic should consider a visit to ophthalmologist or retina specialist, uh, especially when there are some known factors affecting the eye are noted, and especially when the patient is diagnosed with any retinopathy changes. But at least once a year, if not indicated by your ophthalmologist earlier, once a year checkup is mandatory for the diabetic patient.
In the same continuation, we would also like to know from you that we know that once the patient has retinopathy and has been treated with the laser surgery or maybe a intravitreal injections, then we know that the sugar control is one of the most important factor which can prevent the further recurrences. But apart from that, as a retinologist, what are the precautions the patient should observe once he or she has undergone such treatment to prevent the future occurrences, because we know that it can recur also?
Yes, you are absolutely right, and the answer lies within your question also. So the most important factor is your strict diabetic control, which leads to further development. If not controlled well, it leads to further development of progression of diabetic retinopathy. And the other factors which are you should control, you should monitor is that as per advice by your retina specialist, you should follow his or her guidelines. If you are treated with vitrectomy surgeries for vitreous hemorrhage or proliferative diabetic retinopathy, as by advised by your retina specialist, you should instill your topical drops and systemic drugs as per he advised you. And apart from that, systemic control of not only diabetes, if it is associated with hypertension, pregnancy, dyslipidemia, other habits like smoking and all alcoholism should be omitted. And just follow the approach of retina specialist and your endocrinologist to prevent the further progression of diabetic retinopathy.
Thank you very much, Dr. Kush, for enlightening us on this aspect. So now I go to Dr. Rupen Panchal, who is the nephrologist in the panel here. So my question to Dr. Rupen is that how diabetes can affect our kidneys and how we can retard the progression of diabetic nephropathy.
Yeah, that's a good question. Can you hear me properly?
Yeah.
Yes.
So there are two things we want to know about what is incipient diabetic nephropathy and what is overt diabetic nephropathy. So as we know, the diabetes is a slowly progressive disease and it affects the kidneys. So majority of the patient do not aware whether they are affected in form of kidney dysfunction or not. We do have good physicians that they check at least urine microalbumin or urine routine micro for the proteinuria. So whenever any patient of diabetes with long history and having some amount of proteinuria, what we call as microalbuminuria, and patient is completely symptom free, we can tell it as incipient diabetic nephropathy. While the overt diabetic nephropathy, that means the patient has macroalbuminuria and with symptoms. Even though sometimes the patient may be not aware of any symptoms, patient may be not having any symptoms even after long run of diabetes, but depending of the amount of the protein he is leaking in his urine, we can say whether it is incipient nephropathy or overt nephropathy. So what is the main difference between the incipient nephropathy and overt nephropathy? In incipient nephropathy, we know that there are some medicines which can retard the progress of the diabetic nephropathy in this patient. We can offer those medicines to the patient. We can monitor the response by judging the amount of the proteinuria in the urine, and we can also modify the ongoing treatment. So if the patient is found to have incipient nephropathy, we can control it at early age and we can retard the progress early. While in overt diabetic nephropathy, the kidneys are almost already affected by the bad diabetes control, and sometimes it is difficult to retard the progress or reverse the progress in diabetic nephropathy when patient has overt proteinuria or what we can say is macroproteinuria or macroalbuminuria. So in this case, when patient present with the overt nephropathy, we have limited options to treat, and sometimes the patient may have altered kidney function as well. So we need to define whether it is incipient nephropathy or overt nephropathy. What I suggest that each and every patient of diabetes should have at least gone for the urine microalbuminuria checkup at least 6 months in the course of the diabetes. And if the diabetes is very well controlled, he can go for every yearly checkup. Now coming to the next question, how we can retard the progress of the diabetic nephropathy or any kind of nephropathy associated with the diabetes. So as we know, the diabetes and the hypertension, that is the raise in the BP, almost go together to affect the kidneys. So whenever any patient of the diabetic nephropathy, we should always check the blood pressure and we should control the blood pressure. That is the first thing we should do. Second thing, of course, the tight diabetes control or as recommended, control of HB or glycated hemoglobin by less than 7 or less than 6.5, depending the stage of the kidney function. Number 3, lifestyle changes are much more important to prevent the kidney dysfunction or retard the progress. That means avoid smoking, avoid alcohol, reduce your weight, treat sleep apnea if it is present. Fourth thing, sometimes whenever diabetes is associated with the blood pressure or hypertension, we must offer the patient the current treatment which suggests aspirin and statins. So these are the core 4 things which we can give or advise to the patient to retard the progress of diabetic nephropathy.
Thank you very much, Dr. Rupen. We have Dr. Madhav Desai, sir, also. Sir, would you like to add regarding this, which NGOs would find helpful regarding the who are taking care of the patients with diabetic nephropathy or who are screening the patients for diabetic kidney disease from the community perspective?
So I think basically it is what we need is an education to the patients and their relatives. That's very, very important, that as all the specialists have already said that they need a regular checkup. But if we say alone, probably they get a different meaning. So it's better that that comes through the NGOs, that in all the languages that the patient understand it across the India, that these are very, very important. And as earlier also somebody has rightly said, the treatment of diabetes in the treatment of complications, not in the regular diabetes. Diabetes per se is not expensive nowadays. We have got so many inexpensive medicines available. Only thing, if we follow the regular charts of the regular screening of our retinopathy for foot or for the nephropathy or neuropathy, I think we can prevent most of the complications by keeping. Now it is universally proved that if we control hyperglycemia and the blood pressure and the cholesterol, probably we can at least retard, if not prevent, the complications. So most important thing is then education through NGOs, that these are the things required. They can come out with the pamphlets, and so that without any name, so that at least it goes well with the patients and the relatives. Thank you for giving me an opportunity.
Rightly said, sir. The education is the most important thing for all the complications of diabetes, because most of these complications are hidden initially. So we need to detect it early, and the education is the only thing which can sensitize the patient to further go for the checkup. So now I go to Dr. Haley Shah, who is the young neurologist among us. So my question to Dr. Haley is, if we talk about the brain stroke. It is also very common in the diabetes patient. So can you enlighten us what are the early signs and symptoms of brain stroke that a family members or the community level that can identify in the patients, and when they can seek the urgent consultation with the physician or hospital when they see such symptoms of brain stroke? So what can be the insights into that?
Good evening, everyone. At the outset, I would like to congratulate and thank you, Dr. Mayur Patel and Dr. Yash Patel for organizing and conceptualizing such a fantastic conference. And thank you so much for these opportunities. So, as you rightly mentioned, diabetes mellitus is one of the, stroke is one of the most commonest macrovascular complication of diabetes mellitus. Now, stroke is a serious medical emergency situation that occurs when the blood supply to the brain is disturbed or interrupted by blocked or a burst of blood vessel. So one should be knowing that an untreated patient loses approximately 1.9 million neurons every minute in ischemic area. So timely reperfusion therapy offers the potential to reduce the extent of ischemic injury, which can reduce the disability and neurological deficits. Now, stroke could be either ischemic stroke or hemorrhagic stroke. And ischemic stroke is when there is obstruction with the blood vessel supplying blood to the brain. It could be either thrombotic or embolic. And thrombotic stroke could be either large vessel occlusion or small vessel thrombosis. Now, most of the patients with diabetes mellitus, they are at high risk of developing small vessel thrombosis. Almost 15 to 30% of patients with diabetes mellitus are prone to have small vessel disease. And it is very prudent to identify these patients at the early most. And the risk is much higher in women as compared to that of male. And diabetes mellitus increases stroke morbidity and mortality, and it predisposes.
I just want to interrupt you for a second, because basically what I want is in a simple language, what can be the signs and symptoms a patient can understand, because we are dealing with the participants who are more or less laymen, they are not doctors. So just in a simple language, if you can highlight what are the signs and symptoms they can observe, and they can seek the immediate medical care.
Yeah, so according to various studies, diabetes mellitus have approximately twice to 4 times the risk of ischemic stroke as compared to those without diabetes mellitus. Now, the important thing is time is brain, and every minute counts. So first, most important thing is reduce the stroke risk, recognize what are the stroke symptoms, and third most important thing is respond immediately. Do not waste a single minute, because stroke is a brain attack. Now, in the simple language, I would like you to remember by the simple mnemonic name as be fast. So whenever a patient is having sudden onset of loss of balance, that is B is for balance, that is, if the person has sudden onset of loss of balance or dizziness, E is for eye vision symptoms in one or both eyes. If the patient is having visual disturbances or blurring or dimness of vision. F is for facial asymmetry, that the patient is having facial weakness. A is for arm or leg weakness of one or both the sides. S is for speech, that is slurring of speech, or whether the patient has the person is having understanding or speaking, or patient is confused. S is also for sudden loss of sensations over one or both sides of the body. And T is the time to act fast. So again, the symptoms would depend upon specific part of the brain area, whichever is involved. And accordingly, we must be careful. And the important part is to make this patient reach to the immediate emergency service without wasting a single minute. That was the most important part that I was trying to highlight, that if we give this patient early thrombolytic therapy, if it's an ischemic stroke, then this patient, we can reduce significant disability and burden to the society. That is the most important part.
Yeah, so the time is the most important thing, I think. The patient and the caregivers should recognize the signs and symptoms earliest, and they should seek the immediate medical care, because time is crucial here. So now I come to Ms. Rima Rao, who is the dietitian and a nutritional expert on the diabetes aspect. So ma'am, just wanted to know that if you can explain the diabetic diet, because most of the patients are always confused about the diet. So can you explain in the simplistic language what the diabetic patient should do in a routine day-to-day life, and what is the importance of cultural diversity in the diet, because we cannot do every diet for every patient, every region.
Yeah, good evening, everyone.
It's a pleasure to be here, and thank you for inviting me and giving me this opportunity, Dr. Mayur Patel and Yash Patel. So a diabetic diet needs to be highly individualized, and we cannot say that we cannot give separate diet for everybody, because what happens that when you talk about the cultural aspect of the diet, we all know that what is culture. Culture is our life experiences in our family, in our community, our values, our beliefs, our customs, our language, our thoughts. So all these things, all these actions make up the culture of a person. So in India, with so much variety, north, south, east, west, everywhere the culture is different, but all the diabetologists here will be knowing about the START study, which says that wherever you go in India, whether it is north, south, east, west, basically they all consume a very high carbohydrate diet. So whether it is a rice eating south or wheat eating north, all are eating a very high carbohydrate rich diet, and this has to be controlled. So we can individualize the diet. At the same time, the general scenario is the same. So to make balance, what we can do is that we can reduce the carbohydrate to less than 50% and increase the protein content. And it was very nice to hear Guruji today. And if you remember his talk, it was all about lifestyle change and food. And a diabetic diet, we need to take care of the macro and the micronutrients both, and we have to see to it that the individuals stick to their regular meal times. So erratic meal times, a sleep pattern, and the normal activity of the patient, that is whether the patient is even obese or not obese. All those factors have to be considered by planning a diabetic diet. But I will only say that simplest way to plan a diet is that less of grains, more of millets, more of pulses, dals, more of vegetables, especially the green leafy vegetables, and fruits. So if you take care of this, so low carbohydrate, moderate fat, and high protein diet would take care of the diabetic diet.
Very well said, ma'am. So yes, the simplest regime is to cut the carbohydrate. So now I again come to Dr. Vachrajani sir. Sir, we would like to know from you that what is the role of specialized diabetes footwear, because many patients and many community members do not know about the importance of footwear for a diabetes patients, for the prevention of diabetes foot disease, as well as for the treatment. Once the patient has got amputation or once the patient has got ulcers in the foot, then what is the importance of such footwear for such patient? And where can they get such footwears in the cost-effective way?
Yeah, very good question. The only thing is, I always tell my physician friends and patients that from the day one of diagnosis of diabetes, they should start thinking of preventive footwear. Preventing footwear doesn't mean that tailor-made footwear. Preventing means there should be no chappals and no slippers, because neuropathy over a period of time leads to slippage of slippers and deformities of the foot. So to prevent that deformity to occur over a period of 5 years' time, one should have a footwear which doesn't require to be holed. It means sandals, shoes, or we can say mojudis type of footwear. So this is one basic thing for all diabetic patients. Number two, because of neuropathy, because there is no sensation. Patients walking barefoot in temples and roads and all that, they invite trouble. So the role of footwear is, wherever they go, they should wear footwear, including indoor as well as outdoor, to prevent unknowingly getting injuries. So this is another role of a footwear in a normal individual with diabetes. Once the patient is operated, there are ulcerations and deformities to be prevented. See, now what is required is there are tailor-made footwears available, but it is always costly. So cost effectiveness is really a problem. But as far as possible, after the ulcer heals, if the patient's foot is normal, the shape is normal, then a good quality sports shoes type of a footwear with a medial arch would suffice. Sometimes with callosities and recurring ulcerations patients, we advise them specialized insoles like silicone insole or microcellular rubber, microcellular porone type of material. Now, if you go further, there are better qualities of molded insoles available with deformed foot and callosities and one or two toes or multiple toes amputations. They require molded as per the shape of the foot. The mold is prepared and that can be incorporated in the footwear. So molded insole is another very good option to take precautions and to prevent the reoccurrences of foot problems after the foot is affected, injured or diseased and operated. So this is basic regarding our footwear. Now, very important thing is always wear socks, cotton socks. So that will prevent the friction injury and minor trauma can very well be prevented. And very, very important instruction to be given to patients is never wear a newly purchased footwear for a longer time. Otherwise, whatever quality of the footwear is, there will be a shoe bite and there will be a problem. So this is basically which one diabetic patient should take. Okay.
Thank you very much, sir. That was very helpful actually. Now we have many questions actually to ask to all the panelists, but because we need to conclude in 4 minutes, just 2 to 3 minutes. So I will take only 2 questions and I tell Dr. Rupen Panchal and Dr. Helisa just 2 questions and just answer in 2 sentences only. Very useful to the community. To Dr. Rupen Panchal, once the patient have got the diabetic kidney disease and undergone the renal transplantation or maybe undergoing dialysis, then what are the important messages you want to send to such patients and family? And to Dr. Helisa, what are the important message you want to give to the patients who have undergone the stroke, a major stroke? Just in 2 sentences.
It contains two questions. So first of all, patient of kidney transplant with diabetes, the only one message is to control your diabetes, be with your physicians on regular checkup, and do not forget to take your medicines. Many times the patient becomes non-compliant to the medicines. So this may create a big trouble for the patient and for the transplanted kidneys. So be regular in whatever treatment you are taking and be healthy. Number 2 question is patient of diabetes with dialysis. So I can say the dialysis is a very cumbersome treatment for the kidney patient. And many of the dialysis patients do get low sugars during dialysis or after dialysis. So what we do, the dialysis patient, I would advise to take some calorie food during dialysis or before the start of the dialysis. And they can modify the ongoing diabetes treatment with your physicians depending on the low sugar levels. So patients who are having dialysis and who are also having diabetes should control your sugars, but also should take calorie food during and before the dialysis to avoid the low sugars. That's it.
Dr. Haley.
And for the stroke part, I would just like to tell that stroke rehabilitation is equally important, that physical, occupational, speech therapy, recreational physiotherapy, and vocational and rehabilitation therapy for patients who have already undergone stroke is important. And as a part of the treatment, they should take treatment accordingly, whatever is been suggested by the neurologist, antiplatelet or antithrombotic therapy. And for the secondary prevention, they should eat properly, eat normal, eat DASH diet, mind diet, what we call. That should be low fat with the individualized glycemic control goal, and they should try and maintain normal body weight and attain individualized goal. And proper physiotherapy is important, and avoidance of risk factors like dyslipidemia, high blood sugar, and stopping smoking and alcohol is equally important.
Now I have only 1 minute, and I will ask only final question to Dr. Ms. Reema Rao. Ma'am, there are a lot of confusion regarding the cooking oil. So just wanted to know from you which cooking oil patients should use and whether quantity is important or quality is important. Just we have to answer in 1 minute, ma'am.
I think both are very important because of cooking oils are available in the market, and you are right, there is a lot of confusion, but we should lower the saturated fats. Saturated fats are ghee, butter, and all those things, but it's not that we don't have to take, we have to take, but in less quantity. The oils containing monounsaturated and polyunsaturated fatty acids should be increased, especially because they have a lot of antioxidants and they have an anti-inflammatory effect, so very good for diabetes. Also, they reduce actually insulin resistance, and also insulin sensitivity. So MUFA and PUFA have to be taken, which is there in the rice bran oil, the sesame oil, rapeseed oil, olive oil, groundnut oil. All these oils are very good, and a combination of them have to be used. So I, as a to a layman, I always suggest that you include all these oils in your diet, especially in Gujarat. Peanut oil, that groundnut oil, sunflower or safflower oil, and ghee. So if they use all these three things for different things, like for
I think Madam is disconnected.
For you in, so all these oils, but 5 to 6 teaspoons a day, not more than that, because it is a total fat also, which is very important, and we get fat also from other foods, not only from oils. So there are visible fats and there are invisible fats, so we have to consider both.
Thank you very much, ma'am, and thank you very much to all the panelists for joining for such a wonderful discussion. And now we have the paucity of time, so I will hand over the session to the organizer. Thank you very much, all. Thank you.
Bye. Thank you.
Thank you.
Thank you so much. What an energizing session. Listening to Gurudev was an achievement. And the learning was that everyone has to join hands to make the care holistic care. Great. Thank you, all the panelists. Thanks, Dr. Dhiren Patel, and thank Dr. Dishank Patel. Thanks a lot. Let's move on to the next session. That is session 4, Innovations and Diabetes Care by Stakeholders. We often use the word innovation, but what exactly is innovation? Innovation is anything that is novel and that is useful. So that's where we are going to discuss in the next session, that is innovations in diabetes care. And we have the experts for this session, Dr. Urman Dhruv, consultant physician, director, Department of Internal Medicine and Diabetes Care, SCG Hospital, Mithakali, Ahmedabad, India. We have Professor Tejas Bhatt, Associate Professor, Department of Biomedical Engineering, Ganpat University, Mehsana. We have Dr. Arun Saxena, Senior Consultant Physician, Diabetologist, Vedika Hospital, Ahmedabad. We have Dr. Vinay Mukhekar, Leading Medical Professional, Medical Affairs, Indian Subcontinent, Medtronic Diabetes, Mumbai. We also have with us Professor Vijay Dave, Assistant Professor, Biomedical Engineering, Department of Government Engineering College, DEC, and Mr. Sunny Shah, Chartered Accountant, Swasth Diabetes Care, Ahmedabad. So over to experts for the next session. Dr.
Thank you very much. Yeah, thank you very much for organizing such a nice session. And we are going to invite each speaker one by one. I think we are going to give them each 7 minutes. We'll start with Ms. Jaz Sethi. What we are going to do is, after they present, one of us, one after another, would ask questions rather than all asking or firing simultaneously. So the first speaker, Ms. Jaz Sethi, will talk about Project Kiran. Over to Ms. Jaz.
Thank you. Namaste, everyone. And thank you so much for that introduction. I am just going to quickly share my screen, and I hope you all can see it. So basically, I'm someone living with type 1 diabetes for the last 12 years, and I run an organization called the Diabetes Foundation. So Project Kiran, what is it all about? So, you know, as a team comprising of people living with type 1 diabetes, and I think the previous panel has so beautifully explained that education is such a fundamental part of living a life of quality when you have type 1 diabetes. But often in India, what we have seen is that because of an overburdened health system, doctors are not able to give that much time to their patients when it comes to diabetes education. So the objectives were very clear for this particular project. It's to cater to every different child's learning needs about diabetes education. It's to understand that not all children learn alike, and that there should be resources available for different kinds of requirements. We also believe that type 1 diabetes education needs to be engaging, so not boring. We don't want them to study for a 10th grade exam. We want it to be engaging, colorful, and innovative. Also understanding the requirement of rural and urban India, and also figuring out what requirement works for those two audiences. And lastly, it's about making learning about type 1 diabetes fun with user in the driver's seat mindset. It's about giving them agency and using that ownership to make them take care of their treatment better. So what our foundation did was the methods of research. We were really inspired by Dr. Howard Gardner. He is a world-renowned educationist, and he came up with the multiple intelligences theory, which basically talks about every child has multiple learning needs. Some may be a visual learner, some might be a kinesthetic learner, and each child learns differently. So each education module should be catered to that learning requirement. We partnered with the best minds. So we went across the borders. We partnered with the NHS, with JDRF, with ABCD, with Cedric by CEDAR. We partnered with some of India's greatest type 1 diabetes organizations because we never wanted to compromise on the quality of education. We also were a big part of this was reaching the unreached. So we did a lot of work on research of what does rural India understand better. For example, rural India does not like illustrations. They would rather have pictures. This we did not know when we started designing. So we did a lot of modification based on our target audiences. And then finally, it was about catering to each competency, whether you have just been diagnosed or whether you've been diagnosed for 10 years. We wanted to create something for everyone because we always believe that we are still learners in this life of type 1 diabetes. And something for everyone, languages of learning. I maybe don't like reading a book. I may like looking at a presentation deck. So like I said, again, languages of learning and catering to each learning style. So that was our research. How did we put this into action? So presenting to you Project Kiran. Project Kiran is an education initiative by Diabesties. So for the visual learner, for the spatial learner, we had our poster series where we created these kind of very fun, innovative posters that were very simple to understand. We also created a comic book called Blue Light, which got a huge positive response from the community for kids to learn about their type 1 diabetes with fun characters and fun animations. The impact was that people loved reading the comic book and it felt they could relate to those characters at a personal level. For the verbal, the linguistic learner, we created a pocket book called Beating the Blues. Here's a picture of the pocket book over here. A very detailed yet very fun basics pocket book. If you get this pocket book, you know all about your type 1 diabetes. We partnered with all the international bodies for this project over here. And this is targeted for those who have the basic skill level. The impact over here is that they loved how fresh it looked and also how informative it was. For the oral, the auditory learner, the auditory learner loves sounds and visuals. So we have our YouTube channel where we create videos every week to basically talk about different topics in a very, very fun and engaging way. And the impact is through all the comments that you can see on the channel, saying how needed this was to make people understand about their condition. For the logical and mathematical learner, we created the logbook. It's called My Type 1 Wonderful Logbook. We partnered with Udan for this particular one. And again, making logging blood sugar levels fun and easy and also inviting, because we all run away from that logbook. So we said, how do we create a logbook that actually invites people in? For the physical and kinesthetic learner, kinesthetic learners love to learn by doing. So we created this card deck. And as you can see over here, the king, the queen, the jack, they all, so the king over here is injecting insulin, the jack is wearing a pump. And on each of the numbered cards, there's a tip and a trick about type 1 diabetes. So we researched this. We found how much time does a person actually hold their cards in their hand when playing any game. And when they're holding the cards in their hand, they're actually learning about their condition. Even for people who don't have diabetes, when they're having this card deck in their hand, they're learning about it. So the card deck was fun and a cool way to learn about type 1 diabetes. It's a great family game. For the social, the interpersonal learner, people who like to learn in a group, we have a project called Madhu Meets, which is once a week educational meetings. And it's all about sort of using very visual decks to talk about different topics and then have discussions on the same, because the interpersonal learner loves by listening to other people. And finally, for the solitary learner is the one who has intrapersonal skills. They like one-on-one attention. So our project called Back to Basics is such a hit. We do about 200 sessions a month, and it's all about giving one-on-one attention to make them feel heard, to make them feel supported, and to make them feel like, yes, somebody cares about them and they're teaching them one-on-one. And the impact of this is, as you can see, a testimonial over here saying that words wouldn't do justice to express my thankfulness for the B2B sessions. So the conclusion of this is that we want to create a safe, engaging, and celebratory environment for people with type 1 diabetes to learn the best way they feel fit. And what we would like is, we've done all these resources, we have all these products, we want to create starter kits. So sample starter kit would look like this, and give these starter kits to all the type 1 clinics in India. And very basically, just to tell the HCP that when you have a newly diagnosed person who comes in, just give them this starter kit, let them go home, let them explore, let them understand what works best for them. And never let's not compromise on the quality of education just because we don't have the time. So that is Project Kiran, and I hope that has been helpful. Thank you so much for the opportunity.
Thank you, ma'am. Really, first of all, wonderfully finished within exactly 7 minutes. So that's an additional credit that can be given to you. Question to you is, what's your infrastructure as far as human power is concerned?
So our team of diabesties currently has 30 people. We have 30 people in our core team, and they're all living with type 1 diabetes, and we are spread out all over India. So we have people in Punjab, MP, UP, Rajasthan, Madhya Pradesh, Maharashtra, Kerala, and Gujarat as of now.
And how do you get the database?
The 30 people are my team, but then basically what we have is, we have a lot of WhatsApp groups, we have our YouTube audience. So we have about 3,000 people living with type 1 diabetes in our direct contact. And it's been word of mouth, it's been through the YouTube channel. So it's coming in through different outlets, but that's what we currently have.
Right. Because being a member of RSSDI, I know that the institutions like RSSDI have got a huge type 1 diabetic database. And if you can approach each of them, that would be fine. What you can also add is, we have seen the card deck. Same way you can create different games. Just like we had created a snake and ladder where each number carried some message. Same way you can create Ludo and other games which would be helpful for the people. Absolutely. I think the project remains open for questions from other experts, and then Dr. Tejas would take over. Anyone else? Other experts can ask the questions?
Yes, sir. I just would like to ask, in the particularly rural areas, how you will identify the kids having type 1 diabetes? Because right now it is a challenge to even identify the different disease.
Yeah. So as of now, what we have done, and also just to mention, I forgot to mention in my deck, all of this material is translated into regional languages. So all our poster series are also into Hindi, Gujarati, and other languages. We've partnered with local organizations like UDAN, like JDF. So if I talk about Gujarat specifically, we work with JDF Rajkot, JDF Jamnagar, JDF Bhavnagar, who already have a database of kids. So we're using these resources in their regional language to not only prototype, but to also figure out what require works. We're always open to refinement. So we're working with them for this particular project as well.
Okay, that's good, madam.
Thank you.
So this is really good creative work. Congratulations. I would suggest each expert to give marks out of 10 so that we can hand it over at the end of the session to the organizers. And now I'll invite Professor Tejas Bhatt to conduct the second speaker, managed for the second speaker. Professor Tejas, is he there?
Sir, yes, sir, I am here.
Yeah. So you can manage, or you can request Dr. Darshana to go ahead.
Okay. Madam, kindly start your presentation, please.
Good morning, everyone. It is a great honor to be here amongst you, and it is a indeed pleasure to represent and speak on behalf of the Swasthya Diabetes Care. And let me introduce myself first. I am Dr. Darshana Patel, and I am working with the Swasthya Diabetes Care. I am here to present our most innovative and unique project, Make My Life, which we are running since 1998. As we can see in this slide, our aim of this project is, instead of the hiding the disease, they should feel confident about the disease. And our mission is excellence in clinical care, education, research, community service, and helping needy people. We also believe that with proper management of the diabetes and its complication, children with type 1 diabetes can live long, healthy, and happy, cheerful life. Children and their parents' cooperation is essential for proper management of the diabetes and its complication. It is only possible by empowering them with proper knowledge and helping them in assessing the best possible resources. First, I would like to give you an overview of this project. First, as we can see in this screen, let's first start with highlights. Education, spreading awareness, counseling, Make My Life Meet, value-added services, clinical care, Center of Excellence for Type 1 Diabetes, capacity building, and research. As we can see in this picture, this is a picture from our education program. In education program, we do many more things, like we educate them for general education about the disease, nutrition care and guidance, lifestyle modifications, self-monitoring glucose system, SMBG, insulin technique, insulin delivery device, management of the low blood sugar, hypoglycemia card, management during pregnancy, management during emergency, sick day rules, etc. And we also spreading awareness is by distributing of educative materials like pamphlets, poster, booklets, etc. We are also users of many more social media platforms like Facebook, Twitter, Instagram, LinkedIn. All we are using for information about upcoming events, and we are giving information about upcoming events, upcoming videos, interviews via these social medias. We are also doing counseling like psychological counseling, career counseling, marriage counseling in this program. As we can see in this picture, this is a Make My Life Meet project. It is a fun-filled atmosphere. It is held in the fun-filled atmosphere, include educative games, dramas, kids, competition, prize distribution, yogas, and many more such things. In these slides, we can see Make My Life Type 1 Diabetes Get Together virtual program. We are also doing some virtual program also in this COVID scenario. And this is an insulin pump. Swasthya Diabetes Care is a center of excellence for insulin pump and also a center of excellence for CGMS, stem cell therapy, and many more things. We are also holding some capacity building programs like doctors training, paramedical training, and we are doing many researches about this type 1 diabetes also. This is, as we can see in this slide, it is a slide of marriage bureau program. We are also running a marriage bureau for diabetic. It is the first marriage bureau for type 1 people in whole world. As you can see in this slide, our article for marriage bureau published in Times of India, and we had arranges 36 successfully marriages. And as we can see also, we can see in this picture, Dr. Yash Patel is giving counseling and communicating with people. This is a Make My Life project extension program, which means we are not only empowering them for marriages, but we are also empowering for early pregnancy after marriages. We are also empowering them for early pregnancy, and we take care of their postnatal, prenatal care also. And we can see in this picture is there is a lady who kept her baby's name on her consultant's name, Dr. Yash Patel. It is an indeed privilege for us. And let me summarize some things. In Swasthya Diabetes Care, we have a separate type 1 OPD. We are doing type 1 get-together program virtually as well as physically. We have marriage bureau. We are doing counseling for type 1 patient, health, education, career counseling, marriage counseling, pregnancy and child barrier counseling, child caring counseling. And now we are talking about this slide. What are you thinking about this slide? It is a birthday celebration? No. It is a festival celebration? No. It is our Make My Life project, Make My Life program. And these all are our little star of the Swasthya Diabetes Care. These all are type 1 diabetic children. If there is any question, please put your question into the chat box.
Okay, Darshana Madam, very good initiative by Swasthya Foundation, which is Make My Life. But I have one question about once we are talking about kids.
Okay.
Who are suffering from type 1 diabetes. This is maybe a general question for all. See, kids in general, we say that kids do not have any control on food. If they found any sweet, if they found chocolates, at that particular time, they are ready to eat it. So in this particular case, is there any methodology or any thing which is kids may be trained for this one, they can control over this such food?
Yes, in such a type of a Make My Life program, we educate kids, and we don't restrict them, but we can say you can eat butter in little quantity, and in sweet you can also sugar-free sweets. You can also eat sugar-free sweets also.
Another thing, once we are talking about Center of Excellence related to insulin pump, which is being running over there. So is there anything has been developed over there for particularly kids or adults related to type 1 diabetes?
In the case of insulin pump, we are doing proper counseling, and we are giving, if they are ready for insulin pump, we are giving them demo for insulin pump, and after they try, after 10 days or 12 days, and after trying, if they are comfortable, then we can provide them insulin pump.
That's good, madam. Thank you very much.
Welcome.
So from my end, it's over, sir.
Thanking you for hearing me. It is a great pleasure to be here. Thank you.
Can we have our next speaker, Mr. Kapil Dave, to start his presentation?
Dr. Arun can take over the next session, next project.
Sure. So our next speaker is Mr. Kapil Dave, reversal of the diabetes. Over to you, Mr. Kapil.
Mr. Kapil, kindly share your screen.
I think his audio is not audible.
We cannot hear you, Mr. Kapil.
Mr. Kapil.
You can invite the next speaker.
Yeah, moving on to the next topic, reduction in blood sugar in diabetics with laughter and yoga by Dr. V.V. Ramakumar. He is a founder of Dr. Ramakumar Diabetes Academy. He is a certified trainer for diabetes educators conducting free diabetes camp, education camps, gold medal orations, cartoon, short story, parody songs, competitions, and diabetic walks. Over to you, Doctor.
Hey, 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 stop. Welcome. I will start sharing my screen. Today I'm going to discuss about laughter yoga as an adjuvant in diabetes control. You know, gelitology refers to the study of laughter, which examines the laughter, relieves the body stress. This is a concept of laughter and medicine. As you know, smiling makes us attractive.
Sorry to interrupt you, sir. Your audio is not very audible. I mean, increase the volume, please.
Can you hear me now?
Yeah, but still it is bit low as compared to normal one.
Sorry. Okay. Can you hear me now?
Yes, sir.
Okay. Smiling makes us attractive. Smiling relieves stress. Smiling elevates our mood. Smiling is contagious. And
sir, please increase the volume. I mean, from the system.
Dr. Ramakumar, the wind sound from your end. So
something is wrong with this. I'm extremely sorry for that. I am not able to. I'm trying. Sound bench like
Please continue.
Sorry for that. I don't know. Anyway, can you hear me?
Now it is audible, sir. Yes.
Okay, fine. So smiling is contagious, and
Still there is some noise. I think those who are not speaking, kindly keep your phones, microphones on mute, please.
can you hear me now? Yeah. So what is laughter therapy? Laughter therapy is known as a psychotherapeutic technique or strategy intended to produce mental emotional benefit through laughter. It is important to learn laugh at yourself. Laughter therapy helps to dramatize the life situations, developing the competitive spirit, and we will become more optimistic. Okay, how do you classify this laughter therapy? We can classify laughter therapy as an intervention was classified using humor, that is spontaneous laughter, means we will tell the jokes and other things, or some jokes or comedy, or without Okay, interventions are classified not using humor. So there are two types. One is using humor and another one is not using humor. If it was specifically mentioned that only laughter yoga, which is non-humorous per definition, or non-humorous laughter was used. So we have two types of laughter therapy. One is using humor, another one is non-humorous, that is laughter therapy. Okay, as you see the literature, first there was a study in Japan. Laughter lowered the increase in postprandial blood glucose. It was published in Diabetes Care. And what they concluded is, in this study on non-insulin users of type 2 diabetes, exposure to a comedy show along with many other participants in the audience, postprandial glucose was shown to be lowered by 46 milligrams per deciliter due to laughter. What they did was they showed a serious show and measured the blood sugar. And the next day they showed a comedy and they measured the blood sugar. And they found out that the comedy show reduced the blood sugar by 46, means laughter reduced. So in conclusion, they write, the present study elucidates the inhibitory effect of laughter on the increase in postprandial blood glucose and suggests the importance of daily opportunities for laughter in patients with diabetes. So we have to encourage our patients to laugh because they're going to get some benefit by laughter. Okay, then coming to laughter yoga, the inhibitory effect of laughter yoga on the increase in postprandial blood glucose in type 2 diabetic patients. It was done in Slovenia. And the aim of the present study was to determine the impact of laughter therapy on blood glucose level in type 2 diabetic patient. For this purpose, they used laughter yoga, which includes respiratory laughing and fun exercises. The study involved 211 participants, of which 110 were involved and 101 are not involved, means they are controls. In both groups, the level of blood glucose was measured at arrival after they had standard brunch, a total of 250 calories. A 90-minute lecture was followed by a 30 minutes intense workout for those participants who had laughter yoga included in the program. So they gave laughter yoga for some group, and other group, they didn't get laughter yoga. In both groups, the level of blood glucose was measured after 120 minutes. They found out that inhibitory effect of laughter on increase in postprandial blood glucose. So the study indicated the importance of daily opportunities for laughter in patients with diabetes. Okay, so what are the principles of laughter yoga? Laughter yoga is a unique concept where anyone can laugh for no reason without relying on humor, jokes, or comedy. Laughter is initiated as an exercise in groups, but it will turn into real laughter with eye contact and childlike playfulness. So it was named laughter yoga because it uses laughter exercises and yogic breathing. They combine laughter and yogic breathing. And laughter yoga was started in 1995 at Bombay by a medical doctor, Dr. Madan Kataria, and his wife in Mumbai Park. Now there are thousands of laughter yoga clubs throughout the world, and it is present in 120 countries. So what they want to do is laughter should be sustained at least for 10 to 15 minutes to get all the health benefits. Natural laughter lasts only for a few seconds. What we will do in laughter yoga is we will have more laughter. As laughter yoga is done in an exercise, we can have prolonged laughter, which brings physiological, hormonal, and psychological changes in the body, which are beneficial. Laughter should be deep, that is belly laughter using diaphragm to bring all the physiological benefits, which is possible in laughter yoga clubs. So laughter should be unconditional. So what are the steps in laughter yoga? I will just show you. Just clap with me. Ho, ho, ha, ha, ho, ho, ha, ha. So we will bring that together by clapping, and then we will do breathing exercise. What we will do is, while exhaling, we will laugh it off. Okay. And this is called breathing exercise. And next one is childlike playfulness. We will make people to be like children, because children laugh more than adults. Once we become adults, we are laughing less. So we will make adults to become children, and we will say, very good, hey, very good, hey. Then we will do laughter yoga exercises, which way mingle. Suppose we will make people to laugh through normal things. Our friend won a gold medal in Olympics. So what we will do is, we will ask our patients to throw a javelin and laugh it off. Hey! Or you can tell the vaccine. See, we can take a vaccine, show the vaccine, take the vaccine. Hey! Hey! Like that, we will laugh, and we will make the patients to laugh more, because laughter yoga needs sustained laughter. So we started this Ram Kumar's Laughter Yoga Club. It is free. And we also did the innovations in diabetes education. We conducted cartoon camps. Then we conducted stories, humor stories, and parody songs. And we wrote a laughter therapy in diabetes primary care. These are all my collaborators. And this was a small study with the limitations we did in COVID time. This is the study where we measured the blood sugar, and we did a 30 minutes laughter yoga and measured. And out of these nine participants, 6 of them had lowered blood sugar. So laughter is free, easily available. It should be considered as an adjuvant to diabetes treatment. Laughter yoga should be promoted as a daily exercise, as it has shown multiple benefits. Further research is needed using CGMS and other newer technologies. And at the same time, we advise the patients to continue their blood sugar medicines, and we don't ask them to stop. But laughter yoga is an adjuvant, and because you see many adjuvants are becoming very costly, so we consider laughter yoga. So what you should do in your practice: begin smiling and laughing at yourself. The patient and his family will automatically follow the suit. Find humor and positivity in adversity. You will automatically find an opportunity to achieve health and happiness. So if you see the laughter yoga or laughter, outcome measures varied broadly from mental health and well-being, like agitation, anxiety, cognitive function, coping responses, depression, laughter, life satisfaction, mood, pain, quality of life, resilience, self-efficacy, self-esteem. These are all the benefits which you get. To physical health, like blood glucose level, blood pressure, body weight, fatigue, heart rate, immune function, insomnia, pulmonary function, everything improves with laughter. They have these studies, and we conducted first national meet on gelitology in diabetes, and laughter in diabetes therapy study group we have. Please join us and enjoy. And I request all of you to laugh for a few seconds with me. Thank you. Thank you very much.
Dr. Arun, you can have questions, and then rest of the experts.
So I think it is a great idea, because you reminded me of Patch Adams movie where. But what I feel is that even the type 1 diabetes, the challenges and a lot of anxiety as well as the stress of managing diabetes is very high. So I think for type 2 we have a lot of things, but I think in type 1 where we I think this can be really helpful. But so is there any idea of you, like you're planning to do this for type 1, particularly the children as well as their parents?
Yes, doctor, you are right, because type 1 diabetics, they have to take so many decisions every day regarding insulin, regarding diet, regarding carbohydrate count, everything. So for them, laughter yoga is very useful. The problem is we are having COVID restrictions. After these COVID restrictions, I will go ahead and do that. Because of COVID, we are a bit behind. But my plan is to include laughter yoga in my diabetes education and educate everyone. Thank you very much.
I think it is said that laughter is the best medicine, but it is very difficult to quantify the amount of laughter you put. And simultaneously, you don't have any control group while the trials that you have shown. So it's difficult to prove the effect of laughter therapy on diabetes, howsoever nice the idea may be. But yeah, I agree, it's a good idea. We can go to the next.
Sir, I want to answer your question, sir. In that Slovenia study, they had a control group where the other group didn't do laughter yoga, and the control group didn't do yoga, and the other group they did, and they compared with that, sir. There is a control group, definitely.
Yeah, that's true. I'd seen that trial, but it was a very small number of patients.
Yes, sir. That's what I'm saying is laughter is freely available. We can use this. We need more studies. We want to do that. Thank you very much, sir.
Sure. Okay. Thank you very much. Can I request Dr. Vinay to take over the next project? Mr. Kapil Dave.
Yes. Good evening, dear friends. Today I'm going to talk about victio diabetes. What do you mean by victio diabetes? In the sense, we have been talking about the symptoms of diabetes, the treatment of diabetes. So let us talk about reversal of diabetes. So what is this concept? We go for two aspects. One is the management of blood glucose, and second is the body's response to the hormone insulin. In order to better understand this concept, let us go for the slides. Yes. Our goal is victory of diabetes, and the aim is diabetes reversal. How do we go about this? First and foremost, we need energy. Energy comes from food. Simple. Food is converted to blood glucose. What is important is how we manage this blood glucose. That is, everything about diabetes reversal is this management of blood glucose. Second thing is the body's response to the hormone insulin. Let's go to the slide further. So the comparison is a person who is normal. His body responds to insulin in a very normal way. And a person who is diabetic, his body does not respond to the hormone insulin. That is, his insulin insensitivity is there. Let's go to the further slide. This is a slide where the insulin acts like a key to the insulin receptor, which is the lock. So once the key is fitting into the lock, the glucose channel opens up and the blood glucose enters into the muscle cell. What happens when the person is suffering type 2 diabetes? Okay, they say diabetes is a genetic factor. First and foremost, let's leave the genes apart. We go for the environmental factors. What are these? Improper diet, that is high calorie diet, lack of exercise, that is sedentary lifestyle, and the stress factor. So overlapping of these, the genes and the environmental factors gives rise to type 2 diabetes. So let us segregate the genetic factor and the environmental factors. So we focus on the environmental factors. That is, it's a tripod: the diet, the exercise, and the meditation part. Let us go further. This is just a blood glucose concentration. A person who's normal, after 2 hours, his blood glucose becomes normal. But a person who's diabetic, his blood glucose starts from 140 around, and then it goes for a longer period. They say diabetes is in our genes. Sorry. Genes are not a destiny. The color of our hair, the color of our eyes, the color of our skin, these genes are like dictators. We can do nothing about it. But the genes of diabetes, they are like committee members. They give us signs and symptoms like excess urination, excess water intake, excess food intake, body tremor. So these are the symptoms. Okay, so they don't act as dictators. So is it possible to reverse diabetes? Yes. First and foremost, we do take care of the abdominal fat. This is the main cause. Taking care of the abdominal fat, the visceral fat. Taking it further, what we do in victio diabetes, we remove the excess fat within the muscle cell. Okay, so what happens? The intramyocellular lipids, the fat within the muscles, what we do is we unjam that lock by dissolving this fat. This is possible by the tripod stand, as I stated. One is diet, one is exercise, and the other is meditation and relaxation. So from oral medication, we go for minimal to zero medication by these three concepts: taking care of proper diet, proper exercise, and meditation and relaxation. What is the vegan? What is the power plate? The power plate is grains, especially millets, legumes, That is, you can say dals, pulses, fruits and vegetables. This should be a palette. Taking further, the 5 colors of phytonutrients. Phyto means plant nutrients. As many colors as possible are very good for diabetes reversal. Taking it further across, a primary diet should be almost zero oil, zero sugar, zero gluten. Wheat, as far as possible, as I said, millets, jowar, bajra, nachni, they are really good. And if possible, zero dairy. Coming to morning breakfast, it should be pulses or dal based. Urad dal hai, something like chana dal, moong dal, masoor dal. And a dish is like a 1 rupee this. So it should be 1/4 cereals, that is millets, 1/4 dals, 1/4 salad, and 1/4 vegetables. That is, it's like a 1 rupee coin. So 1/4, 1/4, 1/4. We segregate into cereals, sprouts, salads, and vegetables. The second diet plan: whole wheat, moderate, low GI, only one cereal, that is millets, focusing on one meal course, that is, which is dals and pulses. Milk, as possible, try to avoid milk, because what happens, milk contains antibiotics, it contains pus, and they say it's something to do with the, as I told you, the body is responsible to insulin level. The receptors, something happens at the insulin and the insulin receptors. That is where the problem arises for the milk part. The scientific analysis is going on, so that they say that it is at the receptor level where the milk hampers the secretion of insulin, and at the same time the absorption of glucose in the blood cells. Exercise is like an insulin because of better response of the receptors to the insulin. And so, what does exercise act like? It has an insulin effect. How? Decrease in fat, better body response to the insulin, better glucose intake, glucose control, with your diabetes. Everything has to do with the fat. Decrease the fat intake, response increases, blood glucose in the bloodstream gets absorbed, and that is glucose control. This is the risk factors for diabetes. If you increase the exercise calorie intake.
Mr. Kapil, you got 1 more minute.
Yes.
Mr. Kapil, you got 1 more minute.
Yes. So exercise is a very important part. Feel good. Thus, with your diabetes is nothing but the exercise plan along with meditation, relaxation. So it's diet, it's exercise, meditation, and relaxation. That is the entire plan. It's like a tripod. 2 important factors. One is management of blood glucose, and second thing, to summarize, the body's response to the hormone insulin. These are the 2 factors which you take care of. With your diabetes is possible. It's like a magic wand. So that is it. And I would like to conclude my session. Any questions, please?
Do we have Dr. Vinay?
Yeah. So thank you. Diabetes reversal is what we really need, because we are having a diabetes capital of the world, a kind of tag. But like, was there any studies or any outcomes that you are measuring? Because now with a lot of digital therapeutics, the measuring outcomes is very easy.
Yes, yes. We had 2 patients actually, and these are type 2 diabetes. And what happens with this tripod stand? In a period of 5 to 7 days, there was a drastic change within the glucose levels, but blood glucose levels. And we had a diabetologist who was adhering to the compliance factor. So we have a team. So I'm the nutritionist and the trainer, and we have a team, and we have a diabetologist in our team panel. So that is how we actually check the insulin levels. We go for the HbA1 levels, and insulin is taken after every 4 hours. So in a day, there are 4 levels of insulin which is taken, and within a span of 1 week, there's a drastic change in the glucose levels. And even the diabetologists, they prove it. Yes, it's effective because the diet it's a simple diet. Exercise is there, and then the meditation part. So it's a very, if we say, it's a very integrated approach. It's a total holistic integrated approach. That is, we go for it. The main concept is that we reduce the medication uptake and make it as nil as possible. That is the intention behind it. And it has shown really very good results.
I think you got a signal. So what we need is a large patient data, and that can be really, you have got positive signals. So what we need is a large patient data that can really prove this in the future. But thank you for the presentation.
Thank you, sir.
Mr. Kapil, how could you say that diabetes was reversed? You have presented a project of diabetic reversal. So how could you prove that diabetes was reversed?
Yes, sir. We had a diabetologist in the panel, and we used to take the blood sugar levels. And at the end of 3 months period, we had an HbA1c test done. So before they had a case paper done, we have to file a case paper. Everything is written,
So
the BMI.
what was the, you have to first define diabetes reversal. So what was your definition of diabetes reversal?
Yes, what is
was
my
it a normal HbA1c? Was it normal HbA1c after 3 months? Then I have to say, sorry, it is not diabetes reversal.
Pardon, sir?
What was your definition of diabetes reversal? How did you define it?
Yeah, the definition of diabetes reversal is something like where we go for the total holistic integrated approach, taking into account the diet part, the excess part, and the
When do you
part.
say,
yes,
Mr. Kapil, when will you say that this patient has a diabetes reversal? At what stage?
Sir, within a span of 1 week, we
Okay.
can actually see.
Okay, there is no sense in arguing. You cannot say within 1 week or even 3 months that diabetes has been reversed. So you should go back to the doctor and ask him the definition of diabetes reversal. I think we'll go to Dr. Vinay to take us to the next project. Dr. Vinay, is he there? Thank you, Mr. Kapil. Dr. Vinay?
Yeah. So I think our next speaker is Dr. Tausif Nabi. So can we start?
Is my slide visible?
Yes,
go ahead.
Please.
Good evening, judges. I thank the organizing committee for giving me the opportunity to present the paper. I also thank the other authors for accepting me as a presenter for this paper. The topic for this presentation is characteristics, outcome, and progression of women with recurrent gestational diabetes mellitus. As we know, GDM is the most common metabolic complication during pregnancy, and it is increasing worldwide. Various studies have reported that the women who are diagnosed with GDM have subsequent risk of around 30 to 85% of developing GDM again in the subsequent pregnancy. And this percentage varies depending on the population studies and the various diagnostic criteria employed. Although the Asian studies have shown that the progression is more in women of Asian descent. And studies have also shown that neonates of women with recurrent GDM are large for gestational age and macrosomic. So the majority of the risk factors in GDM women will persist or become worse in subsequent pregnancies. The pregnancy outcome of women with recurrent gestational diabetes mellitus has not been thoroughly studied. So we hypothesize that women with recurrent GDM might be at high risk for metabolic derangement and adverse reproductive outcomes. So identifying recurrent GDM women in pregnancy will facilitate not only better care during pregnancy to improve outcomes, but also provide an opportunity to identify women with future risk of lifetime diabetes. So the aim of the study was to assess the characteristic maternal and neonatal outcomes and postpartum diabetes in women with recurrent GDM as compared to GDM. So this was a prospective observational cohort study of multiparous women with GDM. We recruited consecutive multiparous women with GDM diagnosed after first trimester. Study duration was 2.5 years. Various parameters like demographic, clinical variables, fetal-maternal outcome were recorded between two groups, and postpartum glycemic status was determined at 1 and 6 months. GDM was defined as per as ADA criteria, that is any one of the three values should be abnormal, that is blood glucose fasting more than 92 or 1 hour more than 180 or 2 hour more than 153 on 75 gram OGTT. Over diabetes was defined as blood glucose fasting more than or equal to 126, 2 hour postprandial 200 more than or equal to 200, and HbA1c more than or equal to 6.5. This was taken as over diabetes. Eligibility criteria: while all the patients of GDM age more than 18 years diagnosed as per American Diabetes Association criteria, we excluded patients having primary gravida, GDM patients where GDM was diagnosed in the first trimester, that is less than 12 weeks, patients who were suffering from chronic systemic diseases, patients who had twin pregnancy, or patients who were on glucocorticoids. The women were divided on the basis of past history of GDM into recurrent GDM and non-recurrent GDM. Then the detailed history regarding the was taken, anthropometric variables, signs of insulin resistance, obstetric history was taken into account. Then the various biochemical investigations like CBC, KFT, self-monitoring of blood glucose and HbA1c were done. UAG was also done to check for fetal well-being, amniotic fetal index. Study outcomes, maternal outcomes assessed were gestational hypertension, preeclampsia, preterm delivery, antepartum and postpartum hemorrhage. Neonatal outcomes recorded by route of delivery, fetal birth weight, small for gestational age, large for gestational age, NICU admissions, hypoglycemia, spontaneous abortion, and stillbirth. Postpartum glycemic status was determined as well as ADA by using 75 gram OGTT at 1 and 6 months. The various definitions which were used in the study would be seen, and statistical analysis was done. Coming to the results, out of the 260 participants, the final participants who took part in the study were 178. That is, there were 36 women with recurrent GDM, 142 with GDM, and other patients were excluded. Coming to the baseline parameters between the recurrent GDM and GDM, we can see the recurrent GDM women were relatively older as compared to GDM. The pregnancy, pre-pregnancy weight and obesity was significantly higher in women with recurrent GDM. Gestational age at diagnosis was lower in case of recurrent GDM as compared to GDM. Obesity in the pregnancy, over diabetes, signs of insulin resistance, need for insulin treatment were also higher in patients of recurrent GDM as compared to GDM. In the glycemic chart, what we can see, this all the glycemic parameters at baseline were deranged more in recurrent GDM women as compared to GDM women. Coming to the maternal outcome, what we did HbA1c at the before delivery at 37 weeks, 36 weeks. The glycemic goals achieved were similar, although we can see HbA1c was slightly higher in case of recurrent GDM as compared to GDM, but it was not significant, and the goals achieved were similar. But despite achieving the glycemic goals, the gestational hypertension was more in patients of recurrent GDM, preeclampsia was more, and need for cesarean delivery was more in recurrent GDM. Coming to the neonatal outcome, the birth weight of neonates of recurrent GDM mothers was slightly higher as compared to GDM women. They were frequently large for gestational age and macrosomia. Postpartum glycemic status at 6 months could be seen that around 28% of patients developed type 2 diabetes mellitus at 6 months in recurrent GDM group, but only 7% of patients in GDM group developed type 2 diabetes at 6 months. So there were around 20% of patients with recurrent GDM as compared to 80% patients with GDM only. Women with recurrent GDM were older, had higher frequency of pre-pregnancy weight and maternal obesity and signs of insulin resistance than women with GDM. The diagnosis of GDM early in the gestation and need for insulin treatment were also significantly higher in women with recurrent GDM. Women with recurrent GDM had poor glycemia diagnosis as compared to GDM. So the key message would be women with GDM in 2 consecutive pregnancies are at increased risk of adverse maternal and perinatal outcome despite achieving the optimal glycemic goal. Women with recurrent GDM are at more significant risk of postpartum diabetes. So early identification, aggressive management, and close postpartum follow-up is essential to reduce these complications of recurrent gestational diabetes mellitus. Thank you.
Thank you for the presentation. What was the new finding that will lead to change in your guidelines of your institution there?
Actually, this study has not been previously, this sort of maternal and neonatal outcome has not been assessed in patients with recurrent GDM. Although what we can see, what GDM women, when they deliver, we don't check their postpartum glucose. that is important. They usually, when women deliver, they go to their maternal home. They don't follow their lifestyle because they are at a risk of developing type 2 diabetes later in the life. So they had to modify their lifestyle, need to maintain a healthy lifestyle modification, and need to get tested for glycemia at various intervals given by various guidelines.
So like your key message for the patients who are attending here is that we should check our glucose status even after GDM regularly and follow up with the doctors.
Yes.
Am I correct?
Yes.
So, any other question by any other panelist? So, thank you, Dr. Tosif.
Thank you.
Okay, can I request Dr. Vijay to manage the last project? Is Dr. Vijay there? Dr. Vijay Dave? Dr. Binder, you can go ahead.
Hi everyone, I'm unable to share my screen. They say cannot share while other participant is sharing the screen. Yeah, I can share my screen now. Am I visible?
Yeah, you are visible, audible.
Thank you very much. So thanks a lot. I'll be presenting my personal journey as well with the journey of my company Fitterfly. And today's topic is about personalized glycemic response-based digital therapeutics, our initial results. Now, just a quick background about digital therapeutics. They are emerging solutions for supporting patients and doctors with better outcomes. They have been tested in Western world with multiple health conditions, the most important of them being diabetes. Now, digital therapeutics programs offer anything else except medications, and they are nutrition, exercise, sleep, stress management, motivation. And I'll show you how we used all these therapies to improve the outcomes of patients with diabetes. The 4 pillars of diabetes management remain medication, nutrition, emotional, physical wellness, and monitoring. But unfortunately, in the current practice, doctors like me, we struggle with time for our patients and the support once a patient leave our clinics. So the gaps in healthcare, we all know, there are no preventive programs. There are no data-based preventive programs in India. So we set up DiabeFly Digital Therapeutics platform and program 2 years back. And the program works with continuous glucose monitoring devices. Recently, we've launched a version with SMBG monitoring also. What we did was initial first 3 years of the company, we built up India's largest food and nutrition database. We have the database for all 32 cuisines with macro and micronutrient calculations, including 16,000 food items. Currently, more than 2,000 people do consultations happen on our databases. Out of 25,000 dietitians, 10,000 use the data and software. So it's a very clinically validated nutrition and data software which is being used in this backend of digital therapeutics platform. Let me show you a couple of things in this particular thing. This is my own personal data from CGMS device. So whenever a person eats any kind of food, our software is able to chart the glycemic response of each of these food items after eating them over a period of next 2 hours. When I ate something which had 33 grams of carbs but was a healthy glycemic food, then my blood sugar rose from 104 to 131 but remained within the normal range. With something which is high starch like a Maggi, my blood sugars actually crossed 140 every time I ate. Another example, when I ate white bread toast, my blood sugar crossed 150, but within 2 hours, they fell down below 70, and I felt a lot of intense food craving and hunger after eating certain kinds of these foods. So this kind of data which we built for myself initially, it opened my eyes to what are healthy foods for me and what are unhealthy foods for me. And I really worked to bring down my HbA1c from a pre-diabetes range of 6.2 to 5.5 by making certain changes. Let me show you a video recording of how this software is actually able to do wonderful calculations at scale using machine learning. This is the glycemic values which you can see from the CGMS devices. A healthy glycemic response to 42 grams of carbs is the blood sugar rising to 115, then coming down. And then since it's a continuous glucose monitoring device, you can pick up early morning hypoglycemias also. But the most interesting part of the software is actually a component called meal mapping. So an average person eats around 120 to 140 meals in a period of 14 days. And our software is able to calculate the glycemic response to all of these meals over a period of 1 hour. You can see this, whatever I eat, what is the amount of fiber, fat, carbohydrates, energy, and what is the glycemic response. Here's a badam kaju barfi with lunch, which triggered my blood sugar rise by 59. Grapes increased within 15 minutes, my blood sugar started rising by 33. And I can also go and check the healthy meals, unhealthy meals. And like I realized that whiskey doesn't raise my blood sugar, but beer raises my blood sugar. That was also a finding which was very important to me. So all these wonderful items actually help you, create a diet plan which is very specific and for every single person. And this is the innovation. This is the largest food database, largest machine learning algorithm ever built in India and Asia Pacific. Then the second part of the program is precision nutrition report, where we are able to give micronutrient reports for calcium, iron, zinc, magnesium for every single patient. We built this database for 18 plus conditions, including hypertension, heart health, and we use it extensively for counseling patients about healthy eating. The third part of the program is self-care and education, where we follow a highly personalized approach, whether the patient has pre-diabetes, what kind of knowledge level they have, whether they have a sedentary lifestyle or into fitness, vegetarian, non-vegetarian. Now we have even Jan kind of software into it. What is their BMI? What's their gender? What are their comorbidities? In fact, for people having diabetic retinopathy, we can even calculate lutein and zeaxanthin in the Indian foods, which is the only software available in India. The content which gets sent to the patient through the app is very user-friendly. It's very engaging. It has videos, it has memes, it has articles, it has meditation audios, and there's extensive use of all these things happen during the 90 days program. The fourth component of the program is mental well-being. We have a team of psychologists who administer diabetes distress scale and motivation and match score. We are certified licensed users of Behavioral Diabetes Institute from US. So we realize that a lot of patients have emotional distress, physician distress, interpersonal distress, and sleep issues. So a team of psychologists gives them cognitive behavioral therapy remotely and a personalized program for mental wellness. And the last part of the program is physical fitness. Though all of us doctors talk about physical fitness, but we took the program in a very different way. We do a video fitness assessment for all these patients based on American College of Sports Medicine guidelines. And we found that the fitness levels of patients are really poor in India. So they get a scientific fitness plan by a clinical physiotherapist and a personalized plan for every single exercise. So this combined is a 3-month digital therapeutic program, which is based on nudge theory and has all these components administered for every single patient. Now, these are the outcomes which have been presented in American Association of Clinical Endocrinology, ENDO 2021. Here today, I'm showing the outcomes of 120 patients, 1% drop in HbA1c, 90% had a drop in HbA1c. In the patients who had a drop, 1.22%, and 90% had a significant weight loss, and 30% had a partial or a complete diabetes reversal. So we are working with patients with pre-diabetes, new onset diabetes, who are people with diabetes who are struggling with glycemic control, people who have been recently recommended insulin, and people who are struggling to lose weight. There are a lot of doctors across India who trust us, and the most reputable name because we stand for outcomes and scientific validity. So we have more than 80 doctors across India who refer us patients. And tomorrow we are celebrating, day after tomorrow, we are celebrating the Pre-Diabetes Day, where a galaxy of people are joining us. So I invite you all to join us for the first World Pre-Diabetes Day. It's hosted by Economic Times. We believe at Fitterfly that the biggest innovation in 21st century will be the intersection of biology and technology. And Fitterfly will be one of the companies which will really help people make meaningful changes. It will also help doctors administer the right kind of therapy outside their clinic for their patients' outcomes. Thank you very much.
Do we have Dr. Vijay with us? No. Okay. Can I have a couple of questions? One is, what is the cost incurred to the patient? And number two, what data the patient is supposed to enter every day?
So the cost of the CGMS program, including the device and home visits, psychology, physiotherapy, everything is 7,500 rupees for 3 months. It is available across 27 cities now. And the patient needs to enter the data for first 14 days. They can even enter a picture of the food they're eating along with the timestamp. So there are software can calculate the glycemic response to each of these meals. And after 14 days, we ask them to enter the data from their SMVG machine twice a week, or if the doctor recommends, because 90% of these patients are referred by doctors. So then the doctor says that I want 2 values per week, they want 4 values per week, then we put them into the software and the patient gets a reminder. And the update reports go to the doctor every month how their patient is doing. And then the patients visit the doctor at the end of 90 days with the end program values.
So a nice one. Questions from any other panelists?
Sir, as you mentioned about glucose monitoring device, so that is on the basis of machine learning. So as sir said that every time the patient have to feed the data, or automatically it will detect the information about the patient.
So it has a machine learning algorithm for entry. So what happens typically is once you feed in the diary for 2 or 3 days, automatic suggestions related to the cuisine, the location of the patient, what they usually eat, that starts appearing onto the time slots. Like for me, typically, I eat mango before my workout every morning. So at 6 a.m., mango automatically appears and I can just say click that I ate mango today. So that kind of machine learning algorithm really simplifies the machine entry. So after first 3 days, the entries become very quick.
Okay, thank you.
Dr. Viral want to ask something. Dr.
Yeah,
Viral,
go ahead.
please.
Thank you. So this is Dr. Viral Shah from Colorado, USA. Dr. Singhal, this is a wonderful presentation, and I love this concept. This is the area that I'm working for many years here in the US. So definitely love to have words with you later on. My couple of questions is just for my understanding here is that, so when we develop an app here in the US, we get the data from US food registry. I forget the name, right?
It's for USFDA. USDA,
yeah,
sorry, US Department of Agriculture.
Thank you. So, and they have the standardized database, and that includes even the restaurant's meal, right? And we don't have that kind of things in India. So question here for you, and probably you may not like to answer that. How did you build that? Where did you get the sources of all the data?
I love to answer that. It was a difficult journey, Dr. Viral, and thanks for answering that question. It took us 3 years to build the database. So we took the database from Indian food composition table, which had about 950 ingredients. Then we worked with National Institute of Nutrition, and we worked with a couple of these colleges like Nimra Niketan, and we had a team of 50 dietitians across India working for 3 years and standardizing the recipes. Once we had standardized the serving sizes, the compositions, the variations, then we actually cooked 2,500 of the most common recipes in our kitchens. So in our company, we have 3 kitchens where actually every single ingredient was weighed in milligrams, cooked, and finally served into the various serving sizes. And that's what is photographically documented, videographically documented, and that size is gradually increasing. So a lot of standardization happened over a period of 3 years. And then we released it for general use to companies like Nestle, Danone, Cipla, Eris, USV, a lot of companies, and Abbott. So then it went through a rigorous clinical use with 20,000 children with Indian Academy of Pediatrics. Then it went for clinical use with 3,000 diabetes patients as a research project. Then it went into use with patients with ulcerative colitis, and a lot of other clinical studies happened to make sure that everything is getting validated. So there is a 20-member data team which continuously keeps on updating the data. Last year, we integrated with the Barcode Association of India to get the packaged food data in. So we're the only licensed provider for barcode related packaged food items, and we integrated the USDA also, and also the Gulf food database, the Thai food database, Singapore food database, and Indonesian food databases. So all that standardization on a global
Dr.
level.
Singhal, sorry for interruption here, but I'm still trying to wrap up my head around this concept. Like, for example, when I come to India and I stop by to any vendor, the size of the samosa would be different, right? What's inside the samosa is also different. And there is no like a package or label or a barcode that will tell me that this is a 30-gram samosa with X, Y, and Z inside it, right? Again, I'm trying to understand that how can we make that kind of a really standardized for an Indian setting where all the states are different and all the states are a different culture, right?
Absolutely. So I think that is the biggest problem here. The meal composition, even for a roti, the kind of atta which we use or the dal which we use, there is a 10 to 20% variation there in the way it is cooked, even the same dal. And then there's a 10 to 20% variation in the way it is served, the serving size. So that 20% variation is there in the database. I completely agree with you. But for the roadside food, in India, that's not standardized, but only the packaged foods, the restaurant foods, and some of the standardized foods like upma, poha, all those things, and we show all the variations. But there will be 10 to 20% variation in the home cooked foods, which you will find. Packaged foods is very standardized.
Great. And sorry, I'm taking a little bit of a time here, but a couple of suggestions for you is that, is this based on the picture of the food, or it's patient has to enter?
The patient has to enter
just
manually.
the suggestion for you is that, this is what we have learned over time and time. If you tell the patients to do more, it's not going to happen. So if you eliminate the user interface, that's the way of automating, the digital technology. So I think if you are already doing on that work, side, I think that would be a great. And then third thing is that with the respect of time, I will try to be very concise here, is that A1Cs are nice, right? But last 5 years at all these forum, I keep talking about that the A1C is not the best metric to judge someone or provide someone about their comprehensive glycemic control. And it's a time to move beyond A1C. You are already using the CGM, Libre. So I think it would be nice to utilize the CGM based metrics to look at the progression of their management. And you showed your graph with the Libre of 67. Just take that with a pinch of salt, right?
Yeah,
because
agreed.
we all know that the pressure on the sensor can cause false low. So if the patient will have a pre-diabetes or type 2 diabetes on oral or injectable medication that generally do not cause hypoglycemia, I ignore all the hypoglycemias that are recorded by the CGM, because nothing is perfect in this world, right?
Agreed.
So that's all.
Completely agree.
Thanks. Single. Beautiful concept. Good job, and good luck with future.
Thank you. Thank you, Viral.
Thank you very much. Well presented, and we had nicely answered most of the queries. I think with that, we wrap up the session and we'll hand over back to the organizers. Thanks all my co-panelists and all the speakers for their presentation. Back to you.
Thank you so much, Dr. Mandrup sir. Thanks, Vinay, and thanks all the panelists for a wonderful session. Though the time limitation was there, but I can't stop myself asking a question to Dr. Singhal. Dr. Singhal, just one more question if you could answer. The great presentation by you, but how do you compare your digital therapeutics with Voluntis digital therapeutics and US FDA approval? Are you planning to take any regulatory approval over there?
Not right now. We are a small company based out of Navi Mumbai. Regulatory approvals for US require setting up a US entity and applying for a 501. Hopefully, next 6 months, we'll have more evidence to do that, but not right now. Right now, it's
and
not work.
You need a lot of money to get the US FDA approval. Yes. I'll be happy to help if you have that plan.
Thank you, Viral. I'll have written down your email ID. Thank you very much.
Thank you, Dr. Singhal. Thank you so much. So great discussion indeed, and really innovative projects that we have seen till now. Let's move ahead what it brings to bring the innovations. So for that, we are moving to our next session, session 5, and it's a panel discussion for which I would invite Dr. Yash Patel, Director Consultant Diabetologist, Swasth Diabetes Care, All India Institute of Diabetes and Research. So the title is, I am a patient with uncontrolled diabetes. Should I get enrolled in clinical research? So unless that happens, we can't reach to innovations. Over to you, Dr. Yash.
Thank you, Dr. Neera Gupta. And indeed pleasure. I see plenty of involvements all around. And the scientific committee, thank you for putting this wonderful topic ahead. And the organizing team, as well as the digital team and the platform provider. MICE idea, as well as the all organizations and the participants. Thank you for bringing up this panel discussion to all of us. In this panel discussion, we have esteemed panelists, Dr. Jaideep Khare, consultant endocrinologist from Bhopal, Mr. Ravi Gaware from Bengaluru. Pardon me if I pronounce yourself in some of the, and you can correct your self, along with you can put on your camera as well as the mic, you can unmute yourself. Ms. Nehal Nandagani from Blue Circle Foundations, then Dr. Viral Shah, our esteemed guest and the friend of ourselves, adult endocrinologist from USA, Ms. Gopi Maniar from Ahmedabad, from the media side, Mr. Shiv Kumar Sharma, member of Ethics Committee from Ahmedabad. So indeed pleasure to host this panel and to keep this flow flowing. We would start with the question that yes, we all are exposed to in words or in practice to clinical trials. And to clinical trials, I would start with the flow that in a flow, Dr. Jaideep Khare, Mr. Ravi, Ms. Nehal, Dr. Viral, as well as Ms. Gopi, and to Mr. Shiv, that what are the importance of clinical trials in our routine practices. Maybe from the perspective of Dr. Jaideep, you can start, then we have Dr. Viral, then the media, and then the ethics committee, and yeah, please.
Thank you, Dr. Yash, for the kind introduction and having me here. And welcome, Dr. Viral. You have given us such a wonderful insight in the previous talk, so it will be really useful here. So, as in this topic, that I am a patient with the uncontrolled diabetes, should I get involved in the study or not? So this question is slightly tricky and difficult because whenever we plan for any study, there are definitive inclusion criteria and exclusion criteria. If we are planning to have those patients, those who are eligible with the uncontrolled diabetes in our study, then definitely we can plan to have those patients. But now here, what is the importance of clinical research? This is the first question here. So I will say that there are so many individual evidences that according to me, this molecule will be good. According to me, this practice is good. According to me, whatever practice is good. But when we come to number of patients, I might be biased because my opinion might be biased. The same way, when we do some clinical trials, it is generally, it may be single-blinded, double-blinded, or maybe triple.
So, Dr. Jaideep, I would just interrupt on that our audience is somewhat in the community and the non-governmental organizations and not much much so technical as
yes.
So
so these clinical trials helps us in giving the data. Those are slightly unbiased and those are relevant to our communities. So that's why these clinical trials are important, because something what I think is good might not be good in whole community, or something which I think is bad may be good for the patient if the proper trial is done.
Wonderful. So like
stop here.
Yeah, so you likely mentioned that we have something in mind, but how it comes to the scientifically in the proper format, that is more important. Yes, to the Dr. Viral Shah, please. Why clinical trials are so important? Yeah, and you work in the tremendously in those area. Maybe think over it, sleep over it, and work over it. So we would like to get it from you.
Yeah, thank you. Again, thank you for inviting me, Dr. Mayur Patel, Dr. Yash Patel. It's always my pleasure to be in this kind of a platform. So thanks. So for me, I'm a phase 3 clinical trialist here in the US. My 80% of time is doing clinical trials. So for me, clinical trial is a life. That's the way. Now, I want to give you a slightly different perspective here. Everything we do in our life, using a mobile phone, the chair that Dr. Yash Patel is sitting on, there are plenty of research is done to make that comfortable to us, right? If we don't like the product, we're not going to use that. So it's the same concept in a clinical research is that we want to make the life of the patient as a quality of life, particularly, as better as possible, with more safety and less side effects, right? And to do that, you need to do clinical trials. Clinical trial is kind of a trial and error, right? And that's we all do in our day-to-day life. So I don't consider that a clinical trial as a separate entity. It's kind of a part of our life. Every single day, we do some kind of a clinical trials in a different way, right? You don't want to call it clinical trial by definition, but and in India, we sometimes call jugaad, right? But the jugaad is the simplest way of doing clinical trial and see what works. So life cannot exist without trial and error. That's my simplistic view on a clinical trial. And the clinical trial is the way to move forward the science and make our life better.
Wonderful, wonderful. To make it to understandable to all of us around. So I'll go to Ms. Gopi, who is one of the media person. And what is the perspective of clinical trial on the media side, if you can share on that aspect?
Yes, definitely. Thanks for this opportunity. My view is like whenever the some clinical trial done, like it's we are talking about the last pandemic, COVID pandemic. So my question is to Mr. Viral. Sir, can you please explain that after the giving a remdesivir to each the patient who required that, they got the diabetic. Like there are so many patients.
You are really a media person. So rather going for the media perspective, you just represented that media is always asking for patients and looking for the body's bias.
Absolutely, that's my job.
Really wonderful. Yes, Dr. Viral, if you want to go ahead.
Sir, I need that answer because there are so many people. We did that story that like out of 190% patients got heavy diabetes.
So we got your questions on the same, and in the same question, Dr. Jaideep is there, Dr. Viral is there, we are all around. The question is, even to add on that aspect, not only remdesivir, even the time given for the vaccine to go through the trial, is it how or what is the view of our all selves around on that? Doctor, we can start with Dr. Viral on the same.
Okay, you are asking me to open the can of worms here. Okay. This is one of the most complex questions.
And keeping in the time in the constraint, keeping the time.
I will try my best here. Okay. So, okay, my answers, take that with a grain of salt because I'm not an infectious disease specialist. I'm a diabetes specialist and I do a lot of research in the digital diabetes space. So I don't do any research related to the COVID. I participate in a research for COVID. I have been volunteer for research for the COVID antibodies and other kind of a test as a patient rather than, as an investigator. So that's a different story. So we have to think about a couple of things. And this is the question first for, from a Gopi is that remdesivir, whether it's a cause and effect relationship or whether it's an association that the remdesivir is causing diabetes. Now, I don't know this topic at all, but I'm giving you an answer in a scientific perspective. This is how I'm going to analyze this. When you look at a couple of things during the pandemic, you are biased to that, right? All the doctors are biased because, like, for example, if I'm a diabetologist, I see the patients coming to my clinic and I say, hey, I see more patients with type 1 diabetes in my clinic. And that means the type 1 diabetes prevalence is very high. No, I am wrong because I'm a type 1 diabetes specialist. That's why the people are coming to me, right? Similarly, it's quite possible that the people with prediabetes, people with undiagnosed diabetes, people who are at the high risk of developing diabetes are more susceptible to get the infection. They got the infection, are treated and develop diabetes. Now, this is, we call it an association. So like, for example, 190 case or 200 case, whatever cases that you have observed, and certain individuals develop diabetes. So there is a possible association that the remdesivir may have caused that, or the severity of infection might have resulted into the precipitation of diabetes. Cause and effect is a very different, and that's the basis of a science than the association. Association do not prove the causality. And I hope that these are technical terms, but makes sense probably. So by doing that kind of a survey, by looking at those 190, 200 patients, does not mean that remdesivir is causing it. Now, if I want to prove that, what I'm going to do is that I'm going to do a randomized control trial where I'm going to have 100 people. I'm just making this up. You have to do a statistical sample size and all these things for clinical trial. 100 people on a remdesivir, 100 people on a placebo. Doctors should not know that whether it's a remdesivir, it's called as double-blind clinical trial. Because if I know, I'm gonna probably place something here. That's my internal bias, right? This is how we do clinical trial here, and this is the standard of doing a clinical trial is double-blind randomized control trial with the adequate power in a statistical sample size, and then you look for how many people develop diabetes in a remdesivir group versus how many people develop diabetes in a placebo group. Is there any difference between two groups or not? If there is, then yes, you are proving the causal association, causality here. That means the remdesivir is causing the diabetes. If you don't, then it's not. So again, I don't know the literature very well, but in my opinion, I don't want to just put that kind of a drug on a bad situation that it causes diabetes.
So that is what, when we get shoot with a media question, we answer with the media answer. So I would add on to another, to take it to the further panelist. We have Miss Nehal around, who is working in the community, and she is one of the representative of the NGO. Miss Nehal, if you can share what is the perspective of clinical trials on the NGO side, or on the charitable foundation sides, or as well as in the communities or the community workers side, volunteer side, please.
Yes. So thank you everyone for giving this opportunity. It is glad to connect with every one of you all. And along with working with Blue Circle Diabetes Foundation, I myself am a patient. I'm living with type 1 diabetes since the last 19 years, and I'm insulin dependent. So the importance of clinical trials, I would say, is really huge, because that is the stepping stone, if I have to say that, in terms of finding any cures or any solutions to any diseases. But when we talk about involvement of patients in these critical trials, I think there's a big gap over there, because most of the times patients are not aware what sort of clinical trials are happening, if they should be involved or not, what are the benefits, or like what are the disadvantages of not being a part of it. So as a patient and as someone who works for an NGO that promotes awareness of diabetes, I think it is important for the patients to be a part of clinical trials and not just be bystanders over there. And I think as someone who's working with an NGO, I think the NGO can fulfill this gap, wherein we can connect the organizations who are conducting clinical trials and the community who may not be aware of these clinical trials. So I think as an NGO, we fit in that space, and we can fulfill that gap over there, wherein we can meet the community members, the patients, along with the doctors and the people who are conducting this statistics and clinical trials.
Wow. Thank you. So this is wonderful, taking on responsibility and taking to ahead side. And in that background, Ms. Gopi, I would come to you also. So now we have Mr. Ravi there. Raviji, if you want to share something on clinical trials, what is the perspective on your side? You can. You need to unmute yourself. Yeah. Mr. Ravi?
Yes, first of all, thank you very much. And
yes.
Yeah, can you hear me? Yeah.
Just you need to increase your volume. Yeah. You can speak loudly also. Usually in panel discussion in India, the voice are always high. Ours is the responsibility and the enthusiasm is on a higher side. Yeah.
Right. So thank you, Dr. Mayur, Dr. Yash, and Dr. Viral, and everyone actually who are part of this discussion. I just participation in clinical trials as a patient is also very important, because the prevalence rate of diabetes in India is increasing, by 10 times. It's almost around 72 million in India actually have the diabetes. And it's actually a duty of the society of the country to support the innovation, to support actually the development of the new drug. And that is something, which we have to really think, because if the patients participated, then they are going to actually get a benefit with the better care, with better medication, treatment, medical test. But at the same time, they are actually doing something very important. That is, a purpose of it is to develop the newer treatment for a country and for a society. And without which we will not have this newer treatment. And there are many examples, right, in the past. And for diabetes, as actually, in the earlier session, I think Dr. Singhal has mentioned that the use of CGM devices, right? It's a great innovation, which is coming up everywhere. But we have many new trials which are coming up and which are using the CGM devices. Unless the patients from the country don't participate in clinical trials, we will not have this data. We have long-acting insulins, which can be given only once in a week.
Mr. Ravi, your range seems to be broken out. So you can you can switch off the camera and you can go ahead with your sharing, please. Until time we have Mr. Shiv also in. Mr. Shiv. Hello. Yes, Mr. Shiv, from
Yeah.
what is the ethics committee perspective on the same? That I know that is your bread and butter for the same, and you can comment on what is the perspective of clinical trial on that behind. Yeah, from ethics committee perspective, and what is ethics committee? You can put that is also in the background for the common public we have around, the NGOs we have around, and the researchers also around.
Thank you, Vivek. Thank you, Mayur sir, your meeting. विवेक मैं भी बात करूंगा. एक्चुअली ऐसा है कि जो आपने जो एथिक कमेटी अभी जो आप गोपी ने कहा कि इंजेक्शन को लेकर बरोबर, वो इंजेक्शन से कई जो कोविड के जो पेशेंट उनमें काफी असर हुई है, बरोबर, उनकी बात एग्जैक्टली सही है. पर जो पब्लिक के अंदर जो चीज होनी चाहिए डायबिटीज के, तो उससे डायबिटीज कई पेशेंट बढ़ चुके हैं. आपको पता है कि रेमडेसिविर इंजेक्शन के डायबिटीज के पेशेंट काफी बढ़ चुके हैं. तो उसके लिए क्या पर्टिकुलर उनको श्योरिटी करनी चाहिए खासकर पब्लिक के लिए?
Sorry, Shiv bhai, just to make sure the participants are from 32 countries and probably the language of interaction they would understand is English. I would make translation of yourselves. So what Mr. Shiv has shared is ethics committee and the research is just needed for the diabetes in the great extent as the prevalence is rising in a much more extended level. And as a ethics committee, what he represents is the social side and the committee side of the ethics committee. And in that background, he had shared that it is important to go through research and volunteer for the same. Thank you, Shiv. Yeah. So, Mr. Ravi, if you want to share something, and you can put off your camera and share on that side, and then we have further questions to ask for. Yes.
Yes, bhai.
Just a minute, Arun sir. Yeah. Mr. Ravi, your voice is not reaching out.
Sorry, there was some actually problem with the connection. Is it better now? Yes. Okay. Thanks. No, so that is what, I am saying is that it's very important, for the people of the country to understand the importance of clinical trials, role of ethics committee. That also gives actually a lot of confidence in participation in the trials. Plus, when they participate, they will get extra attention and extra time of the doctor, and that is a big benefit. I understand that this concept is very well actually known, and with the vaccine trials coming up after the COVID-19 situation, everyone is aware about clinical trials.
Thank you.
So thank you. Thanks.
Got it. So Arun sir, if you have any question, you can ask, and then we can conclude this session, and any sharing from the other panelists.
Only one point I would like to add in the previous discussion of diabetes development in a patients, as Ms. Gopi raised the question in a COVID patients, new development of diabetes or high blood sugar in a COVID-19 patients who were treated with remdesivir. Right?
Arun sir, so the question is appropriate for the panelists. The question is not appropriate for the scientific contest, or content we are going through. So can we do it offline in chatting? Please. Sorry, I have to be strict for the time.
One question.
So your question is, we got it, but what we are asking for is responsibility. Any clinical trial which are happening is on the basis of ethics commitment. And what we are asking as a consultant, community workers, or the volunteers, what media responsibility are you providing to promote and bring those volunteers for those ethical trials? And that is what we are asking to you. Thank you, Arun sir. And getting on to that question. Yeah.
Thank you.
Yes, Gopi madam. So what can we expect from the media to support us for those clinical trials which are done ethically and there's ethical values around?
Doctor, yes, I would like to add one more point.
Please.
Dr. Viral is there from US. Hi, Viral. And with due respect to Mayur bhai, there are 3 points to consider. Number one, patients who are not diagnosed but having high sugar previously before being infected with COVID. Number one, patients in ICU taking steroids, which can alter the sugar level. Number two, and number three, those patients who have taken multiple drugs, which can alter the sugar level. That we have to consider first, and then do the random clinical trial, double blind, with good amount of patients. Then only we can interpret as if it is going to affect our COVID patients or not. With any drug,
We got it.
Dr. Viral is there. Dr. Viral is there.
Dr. Arun Saxena, what you have asked is really a clinician and from the patient perspective question, and we got it. So, Dr. Viral Shah, if you want to answer that question, but every clinical trial is.
No, I am not raising the question. I am just putting across my point.
So that is a right concern for any clinicians, and this is what represent that we always worry about the patients first.
Yes.
And in that background, you asked that question, and we really understood. Yeah.
Thank you. Thank you.
In just one word, I would just say that for any clinical trial, it takes a humongous amount of time to design that clinical trial. We spent about a year or two just to design the clinical trial even before we execute them. So it takes a lot of time. And we do consider all these points that you talked about that, but ultimately it's a patient safety in the mind. That's the first point.
Thank you. And Ms. Gopi, we got your commitment, and thank you for being straight on that. But we are looking for your commitment on the same as a whole team and as a whole panelist, what support you would be able to bring in. So if you want to, if any panelists want to share something, then or we can conclude this session to make it in timeline. Yeah.
So as a patient perspective on clinical trials, I think with respect to the topic, that uncontrolled diabetes, I think that would be a no as a patient from me, because the basis of diabetes management is controlled diabetes, right? Like if you want your life to be good, if you want to do all your daily activities, your sugars need to be in control. So with uncontrolled diabetes, I would not suggest, or I myself would not enroll for a clinical trial. I think the first step would be your sugars need to be in control, your HbA1c need to be in check for probably 6 months or so. I'm not aware of the stats on the duration that you check for a clinical trial.
We got it.
That would be my first step. And another thing would be data. I think for any clinical trial to go ahead, the data needs to be proper. It should not be made up data. And in terms of that, as part of Blue Circle Diabetes Foundation, we have a Blue Circle Diabetes app that I'm going to talk about tomorrow as well. Wonderful. So in that app, we have, as of now, we have around 11 million records, which are already recorded in terms of blood sugars, food, exercise, and estimated HbA1cs, everything. So I think data as well as diabetes control should be two important topics.
So I will add on to that aspect, and as a clinician only, that we got your perspective from the patient side. One thing is, yes, data, and that also ethical data, scientific, standardized, unbiased data, what you are asking for. And in that also the ethical information and total information informed to the patient, that is all basics of the trial of any clinician. Okay, Dr. Veera? And to further side, on the control side, would you be part of the clinical trial which has just observation to look for? Your observatory data, and though not control or control, would you be would it be enrolling or not?
Yes, I would love to enroll it. If it's just an observation trial, I think there would be no issues.
Yes,
that would be exclusion criteria. By designing the trial, you will have inclusion
Dr.
criteria.
Arun, so Dr. Viral already mentioned there is a right amount of time and efforts are placed it on behind, and the patient's perspective is always taken care first. Yes, thank you, Dr. Thank you, Ms. Nehal. Anyone from the panel who would like to share their views on the same, or should I sum up?
So just the one comment here is that I published an article in Diabetes Care last month, and it is about the minority community's involvement in the clinical research and in impact of that in a real life use of those technologies. Now, what I mean by that is, so let's say, I'm developing a Mercedes Class G. I'm just making this up, right? Now I want to test that Mercedes, that how it works. But if you don't participate in that, my Mercedes will be designed more towards the people who participate for it, right? It won't be for you. So then you will be complaining that this Mercedes is not working well. But because that, another analogy to that, in India, we keep telling that if you don't vote, then don't complain, because you did not participate in the formation of the government, right? So the participation in a clinical trial is a must if you want your community to kind of a benefit from that technology. Because when we do clinical trials, our intention is to refine the technology so that everybody can use that, right? So we need your input for that. So participation is very necessary. And my point in the Diabetes Care article is that the Indian Americans' involvement in a clinical trial is less than 1%. And that's why all these technologies are made more for the Caucasians and the white. Nothing wrong about that, but because that we are not taking much involvement, our input is not taken into the design of those technologies, right? So this is true for Blacks, this is true for Hispanic population in the US. So again, ultimately, the conclusion here is that clinical trial, take part in that, develop that. That's how we evolve in research.
Wonderful. So
Yes.
you rightly took on to the right community of ourselves, and this makes me to summarize the whole discussion and the panel around that. This meeting had 32 country participations, and of that almost 50% are from developing part of the world, and where the real time data we are lacking around. And to sum up this panel discussion, the innovations are built on the necessity. That's what we talked about in the previous sessions. The creativity are the roots for those innovations to come up, or the father of those innovations to be in the world. But what are the real mothers or the obstetrician for the same are the researchers, the right research, and the rightly taken responsibility for those research and taken actions by those volunteers are the one who takes the pain of labor and deliver those innovations at the product out there. Thank you all of one to be part in this panel discussion. And this is all on myself that I am taking this session on the much more large extent, and pardon the organizing committee for the same. Please. Thank you, everyone.
Thank you.
Thank you.
Thank you for having us. Thanks.
Thank you, Dr. Yash. My name is Dr. Margarita Ochoa Maya, and I am also an endocrinologist in the US, and I work with Biocon Biologics. I'm honored to be part of your meeting, and today I am introducing session number 6, Caring of the Caregiver. As we all know, right now, there's a significant amount of burnout, and I think that you will find this session super important. I'd like to introduce Dr. Anil, senior consultant practicing for the last 35 years and vice president of the APA. Dr. Anil, would you like to start your conference?
Thank you for your kind words. So let us, this very interesting session, let me thank at the outset the organizers for arranging this wonderful multidisciplinary sessions. Basically, what we clinicians usually see in diabetic conference is a very limited version of clinics and technology. But this seems to be encompassing all economical, social, the clinical, and whatnot. So let me introduce my first speaker, Dr. Neera Gupta. She will be talking on training, education, and further development opportunity for a diabetes NGO volunteer internationally. Dr. Neera Gupta, can you share your slide, please?
Good evening, good morning, and good afternoon across the geographies to all of you. I'm Dr. Neera Gupta. I'm lead medical affairs at Biocon Biologics. At the outset, I would want to thank the organizers for giving this wonderful opportunity to be part of this conference. For the first time, innovations by NGO in diabetes care. I'll be talking about training, education, and further development opportunities for a diabetes NGO volunteer and international perspective. I will be covering my talk under the following heads: education and training, current perspective, barriers to effective self-management in diabetes, NGO role and aim in NCDs, research, diabetes education, advocacy activities, patient care provider communication, patient-centered care, call for action. What is chronic care model and how NGO can contribute to it? Priorities of people living with diabetes and NGOs making difference to the outcomes. Development opportunities, NGO volunteers, and conclusions from global perspective. Education across the world the Blue Circle Voices Network by IDF. What it says is that 82 participants from 43 countries they participated, and 39% experienced difficulty in affording their medicines. 1/3 believe that government should take an action for making the drugs accessible. If you see the US perspective, still the diabetes care and insulins, they are considered expensive. If you see the statements from Costa Rica, they say that diabetes education for adults is much poorer compared to the type 1 diabetes in children. Chile, the statement is that everybody talks about the diabetes education, but nobody does anything concrete about it. What Argentina's perspective is that there are no defined educational campaigns for either treatment or prevention, and this should be taken care of. Ecuador, unfortunately, due to lack of knowledge, parents remove their children from school, and the schools either they don't want to accept the child because of diabetes. In Brazil, they say that diabetes association, they do help, but Brazil is itself a very huge place to cover. In EU, if you see, the education overall is good, but still the education provided to the carers, it's a challenging issue there too. If you see the Africa perspective from Tanzania and Cameroon, they say that the basic education for diabetes has to go a long way. And discrimination was a serious concern in Western Pacific region. So we see that education is a need of hour in this chronic condition. Let's see an example of older people with diabetes, wherein barriers to effective self-management in diabetes. How do we look at that? So if we see that these patients have constrained diabetes, dietary challenges, they have loss of functions, they have poverty, they have limited opportunities for the physical activities. Lack of status, because unfortunately, the attention goes more to the younger people rather than older people. Lack of family support. These elderly people, they have multiple comorbidities. They have depression, lack of education, and the limited time for consultation with treating physicians, and difficulty in accessing the healthcare. So there are various challenges and the barriers for effective self-management. But how NGOs can make a difference is that ongoing training and for the carers and providers on diabetes, involvement of family members and the caregivers is very, very important. Diabetes support groups have to play an active role, and in primary care clinics especially. There has to be active health promotion days, specific days in healthcare clinics for diabetes. And all the NGOs can contribute a lot to these activities. Let's see the NGO role and aim. So aim is to provide physical comfort to the patients, improving relationship with family members and people with diabetes. To promote quality of life, this will help in improving overall health outcomes for individuals with diabetes. Gradually preparing patients and family members for long-term diabetes care needed by the patients. NGOs are contributing at all stages of the research cycle, including priority setting, knowledge translation to action. NGOs play a key role in psychosocial support, counseling, and rehabilitation. Let's see the role of NGOs in prevention and control of NCDs. So when we talk about as a whole, non-communicable diseases, the diabetes automatically is the prime focus area, and where all they make a difference is global and regional network of champions they are. IDF World Diabetes Congress, IDF has the largest NGO, so collaborating with IDF, support for the WHO and the NCD action plan, providing support programs and empowering, educating, energizing the patient as part of treatment team, because NGO is a part of integrated treatment team. And IDF automatically is making a long, huge difference in patients' lives of diabetes patients through the IDF activities, making the seminars, the education, diabetes atlas, and the clinical guidelines. Being the largest NGO, the IDF, there are other NGOs also, like National Diabetes Institute in Malaysia, the Sante Diabetes in Africa. For the developing countries, they are playing an important role in education, and Diabetes Education Society of South Africa for the developing part of the world, not only in South Africa, but also internationally at other places, also helping people with diabetes. So NGOs in research processes, NGOs have contributed to all different stages of research cycle, as we talked about, namely advocacy, priority setting, capacity building, resource mobilization, sharing and utilization of research findings, and building networks to help people with diabetes. Diabetes education is an important key area of NGOs, and diabetes educators, if we look at, they work in various settings: hospitals, inpatients, outpatients, clinics, public health departments, physicians' practices, and private practices. IDF is playing a great role in training and education and helping NGOs to help for a bigger cause. The patient population groups, kids with type 1 diabetes, a sensitive population, there is a lot of work which is required, like kids' educational guide for nutrition and diabetes in school. We heard that schools, training in the schools to teachers, students, it's very, very important. And the Kids Diabetes Information Project, that helps, it's specifically designed for teachers from grade 1 to 9, school nurses, school staff, school students from age 6 to 14, and parents, policymakers, and government officials, so that we help. They are the future generation. We need to help them to manage their disease better. Managing type 1 diabetes in children, we have a lot of educational material that is available to go and help these children. This is another important area of IDF advocacy activities. Let's look each one by one. So universal health coverage. WHO defines the universal health coverage right from health promotion, prevention, treatment, rehabilitation, palliative care. So the essential care, the affordable access to essential care is the aim of universal health coverage. Everyone, every person with diabetes has right to get the essential care. Diabetes is a chronic problem that requires lifelong management, because it's just not the primary prevention. It also requires the secondary prevention to prevent the complications of diabetes. Uncontrolled diabetes can lead to either acute complications and even the chronic complications. They are associated with the long term. So prevention of diabetes complication is very important. Capacity building in terms of the education to the various strata of society, children, patients, family members, caregivers, NGOs, teachers, healthcare professionals. Everybody needs to build up the capacity to make a difference in terms of overall outcomes. Advocacy activities, when we talk about diabetes, requires the integrated care. So it's just not what we just named, but the policymakers have to play a very important role to make overall difference in the healthcare system and healthcare of people with diabetes. Let's talk a little bit about education when we are talking about an important role of NGOs that can be played by them. Improving intercultural patient-provider communication and management of diabetes. Of course, IDF has led the path, and NGOs needs to collaborate and make a difference further to it. So that can be taken care by improving the education on basic facts about the diabetes, the basic care, awareness, raising the blood, awareness-raising activities, blood glucose testing, screening activities, diabetes detection camps organizing. So that's all NGOs can play a much better role. Universal health coverage, we just talked about, living with different types of diabetes. How can we ease out their problems and the concerns, their psychological support system? How do we build in? That's an important area to focus. Oral health, diabetic ketoacidosis, managing hypoglycemia, another area, especially in the rural strata of society, wherein we need to educate a lot to them. How do they take care of themselves? Unawareness, education, and access for vulnerable groups, the refugees, the disabled people, they need to get the essential care. To school with my friend with diabetes, the peer group support system that needs to be established. Traveling with diabetes is another area to educate people. And diabetes, nice to know, capacity building seminars that can be organized, which is right now the best example which we are in today. Looking at patient-centered care. So patient-centered care, so patient has to be in the center. Rest all focusing to fulfill the gaps and the needs of these patients or people with diabetes. So this survey that talks about the initial diabetes education at the time of diagnosis is widespread, albeit not all encompassing. 72% of the patients, they still say that, yes, they have some education at the time of diagnosis, but still 28% they say that they are not well educated, even at the time of diagnosis. People with diabetes have a huge thirst for knowledge, which can be supported, more access to peer support system. Improving education of people with diabetes is as important as enhancing SCP training. So the provision of psychological support represent a major gap in diabetes care. So people say, 77% they say, yes, they need psychological support throughout their treatment. And 23% say, well, it is fine. Much remains to be done to have fully integrated multidisciplinary diabetes care. Call for action from IDF, improving the lives of people with diabetes. IDF mission is to promote diabetes care, prevention, and a cure worldwide. So NGO needs to join hands to support the bigger cause in terms of bringing patient testimonial, story of their successes, experiences, campaigning for diabetes causes, supporting to global social media campaigns, support to the development of specific documents, participation in global conferences, workshop, the way we are doing today. National policies fully endorse the role of NGOs in providing community-based health promotion and patient support system. These are humanitarian actions that are being taken care by IDF. IDF Life for a Child is the guide and education to a child with diabetes in collaboration with the SPAD, wherein how to take care of their treatment and education to support themselves is an important project by IDF and SPAD, and that helps people, small children with diabetes. Diabetech project, again by IDF, it's a school and a one-stop solution for diabetes-friendly clinics, which gives the organized diabetes care, not from diagnosis, preventing complications, lifestyle education advice, the diabetes education, and individualized treatment. Diabetes prevention and care and management of complications in humanitarian settings is another focus area that IDF is paying a lot of attention to. Let's look at the chronic care model. When we talk about NCDs, diabetes is an important area when in chronic disease, chronic care model that is applied. And this is an example from South Africa, wherein the advancement of the health, how NGOs' role is integrated to the chronic care model. They help in supply and distribution of the medicines in the South Africa region. The NGOs coordinated nurses, they are organized and employed by Department of Health. The diabetes lifestyle training and support system programs, that is another area where NGOs' role is very much integrated into the chronic care model that needs to be adapted everywhere else. Let's look at the priorities of people living with diabetes. So there are, if we name top 4 priorities, that here we are. So number 1, that is ensuring access and affordability of medicines and care. Because close to half of, as per Blue network voices that they say that close to half of the people, they have issues with access and affordability. So it's the biggest issue in terms of access and affordability. Number 2 priority is improving diabetes education for healthcare professionals and people living with diabetes. Education we have been talking about till now is an important gap that needs to be fulfilled. So self-management education for people with diabetes is not an option. It is an imperative. That's what is said in the documents. The priority number 3 is prioritizing type 2 diabetes prevention efforts. So it's not only the first prevention, but the second prevention is secondary prevention, what we call it as. It's very important to prevent the complications. In 2015, diabetes was responsible for spend of USD 673 billion in healthcare expenditure worldwide. This is because complications once set in is difficult to take care, and a lot of expenses they go on there. 4th priority is eradicating discrimination against people living with diabetes. Discrimination does not just affect quality of life, but also influences healthcare outcomes. Because in Western Pacific, as we saw the example, wherein the discrimination is a challenge because there are a certain group of people who have the insurance access and policy access while others don't. So discrimination has to go off. Let's look at international NGOs and development opportunities, what we talk of. So where all NGOs have a critical role to play to improve the overall health outcomes. One, the first most is health promotion, primary prevention, and education. Strengthening the overall healthcare system. Investments and funding mechanism. That's another important area where NGOs can pull up together, collaborate with people for the fundraising activities to support these people, because getting the essential care is right for every person with diabetes. Support public health policies. Policymakers have to take the front seat to drive this effort. Access to medicines. Industry has to play an important role to make affordable access to care. Strengthen the civil society through education, doing research, building advocacy, humanitarian support, and education to overall citizenship. That's all are the areas wherein NGOs can play very, very important role. Let's look at the conclusions, what we talked about, NGOs, education, and training, the international perspective. So the first most priority that lies with is the challenge with limited access to affordable medicine. So we need to take care of this and make affordable access to care. And diabetes education, it is the second most important challenging area for people with diabetes. We know that more than 80% of people with diabetes, they are from lower and middle social economic strata, wherein education will make a huge difference and NGOs have to play a critical role there. The relatives and carers, taking care of the carers, this is very important. So family members, the carers of people with diabetes, educating them so that they can support people with diabetes around them. The difference of the people with wherein you make the awareness via various means, the measures to prevent the diabetes and complications, inequalities to negate them, and making the access to all essential care has to be for all, and eliminating the discrimination that is prevailing in some of the regions across the world. So it's about training the trainer. It's about taking care of access to affordable medicines. So resources, NGOs have an important role to play. This is my last slide. And these are some of the links wherein if you want to contribute to the bigger cause, these are the links you can go through. There are various courses on educations, online, offline, paid, free courses. The short courses, longer duration of courses, you can learn and make a difference in life of people with diabetes. So please go through these links. Thank you so much once again. It was a pleasure indeed to be part of this wonderful conference to a bigger cause, to make a difference in lives of people with diabetes. Thank you.
Thank you, Dr. Gupta, for giving a very lucid, I mean, it's a very difficult topic to cover in 10-15 minutes. You have covered it very nicely. So now I will request Dr. Deepak Saxena from Indian Institute of Public Health, Gandhinagar, to start his deliberation on training, education, and further development opportunities for a diabetes NGO volunteer, national. Yeah. So let us see where we go from national to international to national. Yeah. Dr. Deepak Saxena, please.
Yeah. Just a minute. I'm not sure if I'm audible or not.
Yeah, you're audible.
Thank you. Thank you very much, sir. I'll just share my screen and that's it. So is my screen visible? It's visible. Yeah. So thank you very much. At the onset, I should really thank the organizers, mainly Mayur sir, Yash and Dr. Sushil Patel for this endeavor, and also thank because the prior speaker ahead of me was my MBBS batchmate, and we had not met for more than 25 years now. So it's a pleasure to hear her, and I'll quickly have an outline on what is the role and need for training or education amongst those volunteers who are engaged in diabetes, and reflect on some of the training opportunities for NGO volunteers that might be of use. And last but not the least, I'd like to take one slide on one of the models which I feel is an excellent model to really document or express that how an NGO volunteer can be very useful in taking this fight against diabetes for long. Almost all of us who are in public health policies or in NGO sector know about that an NGO volunteer exactly has two important roles. One is for existing diabetic, and second is for identifying the new cases. And when I talk about existing diabetic patient, it's either treatment compliance or measurement of blood sugar or identification of the complication and so on and so forth. Whereas for the new cases, they look more for screening of the population who are at risk and ensure their management, and largely by referral. Now, why it is important at this point of time to talk about training or retraining or education amongst those who are NGO volunteers, because there has been rapidly a rise in both incidence and prevalence of diabetes, and there are serious global concerns that globally the entire globe is offshooting against the Sustainable Development Goals. Not only Sustainable Development Goals, we are offshooting or off-tracking those goals, but also because of the current pandemic of COVID, it's more than clear that globally the communities will not be able to attain or achieve the famous what is known as Sustainable Development Goal, and more so because diabetes is multifactorial. And it's a multifactorial disease. It has got the management requires multi-pronged activities. It can have a lot amount of complication, and therefore a volunteer need to have multiple skills, whether you talk about comprehensive care or you talk about patients, or whether you talk about communication skill, which is more than important. And therefore it is important that a volunteer should actually know about what are the various opportunities that can be availed. And more so with COVID, there has now been enough and more published literature which says that diabetes was a risk factor for those who had COVID, and because of indiscriminate use of steroids, there is an increased incidence of diabetes. And more so, the thing or the fact that should be understood right now is that because of COVID, more than 50% of the countries that were surveyed by World Health Organization had actually documented that there was partial or complete disruption of services with reference to diabetes and its complication. That means, it's only the start, and we'll have to face this for long. So what are the potential activities or the potential training opportunities that a NGO volunteer can explore? One, for sure, communication, because for communication, for conventional diabetic care to diabetic patient, it is important. Equally true is it is important that they should have training and retraining with reference to ophthalmic complication, diabetic foot or neurology or nephrology, but more so with COVID on doorsteps and also other infectious disease, it's high time that an NGO volunteer should also be trained and oriented and educated regarding certain infectious diseases, because India has that double whammy of not only COVID, but also COVID and mucormycosis. And more so, they should be trained about primary and primordial prevention. They should be taught, they should be trained, they should be educated about stress, obesity, lifestyle modification, and so on and so forth. And most importantly, one more which is coming up is juvenile diabetic and also gestational diabetes. For me, what is important for any diabetic volunteer who is working in India, it is important that there should be a convergence, because when I did a landscape analysis of the national health programs that actually are talking directly or indirectly about diabetes and its management, I could find 7 or 8 programs that are already there. But many a times NGOs work in silos. They don't talk about other national health programs, priorities such as Rashtriya Kishore Swasthya Karyakram, or the program for adolescent, or program which is known as Rashtriya Bal Swasthya Karyakram, which talks about defect at birth, deficiencies, disease, and developmental delays. And diabetes is one of the important component of the same. We should also talk about National Program for Control of Blindness and Visual Impairment. We should also talk and converge our efforts towards prevention and control of cancer, diabetes. It's a national program of prime importance. And therefore, my take is we should really converge with those national programs of prime importance. So, if I want to put a framework on training opportunities for any person who is in India at national level and want to learn something, then I can really frame them in 3 parts. It can be a short-term training, which can be in form of workshops, CMEs, or conferences. It can be medium-term training. There are certificate courses which range from 1 week to 4 weeks. There are certificate courses on nutrition and diabetes. There are certificate courses on communication. But beyond this, if an NGO volunteer wants to have some long-term engagement, he can go for e-learning courses or distance learning courses, which are very specifically meant for certificate courses on diabetic care for community worker, or for food and nutrition and diabetes, or diabetic educator, which is run actually by Ministry of Health and Family Welfare. So I'll quickly glance through some of the important courses that you can look for if you are an NGO volunteer. Say for certificate course in diabetes care of community worker, it is offered in India by a national university, very low cost, eligibility is also very less, and it's of duration of 6 months to 2 years, where you can really complete. It gives you a concept and intervention pertaining to diabetes mellitus and procedures related to diabetes mellitus. There is one course which is offered by Medversity. It also talks about epidemiological aspect, clinical aspect, and management, but it's more focused for those who are healthcare professionals, say for dentists or physiotherapists and so on and so forth. This particular course, which is lacking in India, but I'd really like to mention about this course, which is Fact and Fiction Reversing Diabetes. It is offered by Leicester. It really talks about the prevention, cure, weight management, and so on and so forth. So it is one of the important courses that we should look forward. We should also look forward for certain international courses, which is largely towards reversing the diabetic epidemic. And there is a course which is offered by Public Health Foundation of India. It is certificate course on evidence-based management of diabetes mellitus, along with Mohan's Diabetes Education Academy. It has got a very primary objective to enhance knowledge, skills, and core competencies of a primary care physician. And it has got a secondary objective of standard teaching protocols. So, if you are a primary healthcare physician, you should really take up some of the courses. Beyond volunteers also, you should take this up. Last 2 slides from me. One which I really wanted to mention here, just to encourage our colleagues, those who are NGO volunteers, is Sevak project that was launched by an RI US Navy official in India, in Baroda. And this project was known as Sevak, and he started somewhere in 2010, where he identified one volunteer within a village, which can cater to a population of roughly around 1,000. And he can simply go and give primary basic education pertaining to diabetes and can measure blood sugar. And over a period of time, this Sevak means a helper, has grown far beyond diabetes. Now, he is a single point of contact for healthcare of village community members. And therefore, he's bridging the gap between community health clinics, district hospitals, and of course, private practitioners. So he has gone beyond diabetes. Now he also talks about hypertension. He also talks about chronic diseases and of course, immunization. So for me, if a NGO volunteer is there who actually is working for diabetes, it is important that his morale should be high and there should be a career pathway for him also. And therefore, I strongly recommend that let's look beyond conventional training. it is high time that the NGOs and the NGOs volunteers should be taught about research method. They should be taught about what to do about this data. They should be taught about biostatistics, simple computer softwares which are freely available, say for EP Info or even simple Excel. They should be taught about grant writing, and more so, they should be taught how to really convert their work, which they have done in field, into wonderful case studies, research articles, and of course, monitoring and evaluation. Finally, my concluding slide, I strongly believe in this famous quote of Robert Frost: woods are lovely, dark, dense, and deep. We all have promises to keep and miles to go before we sleep, before we sleep, before we sleep. Thank you very much. Thanks.
Thank you, Dr. Saxena, for elaborating the very important aspect of this challenge, this training, education, and further development opportunity for a diabetic NGO volunteer. And specifically, I like your idea that we should take care of the trainers. We should take care of the volunteer. Otherwise, they will run away. The basic problem is that volunteers, we just enroll some volunteer and then leave on their own. They need to be trained. They need to be retrained, and they should have, just like in doctor. We never stop learning actually. And diabetes, not only diabetes management, everything is a dynamic nowadays. Things changes very fast. So we have to keep the volunteer abreast of the knowledge curve. So now we are starting a panel discussion. I will invite the panelists, Dr. Bharat Desai from Ahmedabad, Dr. Shivani Trivedi from Ahmedabad, Dr. Deeksha Dev from Punjab, Dr. Apul Desai from Rajkot, and Dr. Anand Bhargav from Vadodara, and Dr. Sarup N from Bengaluru. Panel discussion will be on the challenges in running diabetes NGO, enrolling volunteer, and keeping their motivation level high for a longer period. How do we go about it? So I will request Dr. Bharat Desai to start to give his comment on this topic. Is he available?
Dr. Kulshrestha.
Yes, sir.
Thank you very much for introducing the panelists. Dr. Bharat is not there. I have been given responsibility.
Yo, okay. So you please start.
Yes, bhai, you are muted.
As Dr. Saxena has rightly mentioned,
yeah,
it is easy to get a volunteer, but keep him enrolled and keep him engaged in the care is really a very tough, realistic, difficult. So how do we go about it? Your views, please.
Yes, Dr. Kulshrestha, thank you very much. Myself, Rajesh Sharma. I'll be moderating the panel and we'll be learning from our eminent panelists. Nero, can you show the slide of introduction? Or I'll straight go to the questions. So we have...
Just show the slides, sir. Just a second.
Yeah. No problem. Kulshrestha sir has already introduced all of them. So I'll straight go to ask questions. My first question, I'll start with Deeksha Dev about, we want to learn from you, what are the top 3 challenges you have faced while working for a chronic disease like diabetes?
All right, so thank you for the question, Dr. Rajesh, and thank you for having me as a panelist today. A very good evening to everyone who is watching this. So the 3, I can name 2 right now, the 2 main challenges that we have faced at the Diabetes Foundation, especially since we work with a chronic condition like diabetes. First is fundraising. It is something that is very important, yet very difficult. It involves a lot of effort, and the main aspect that we have seen is building trust of the donors. A lot of times people do not know that their donations can make an impact. So giving the measurable impact, showing the measurable impact is something that we have also learned is the solution to this problem. And second, that we are still finding a way, and I'm sure everyone else who is on this panel must be struggling with this, is having this bigger policy development, because since it's not directly in our control, a lot of reforms need in policy development when it comes to a chronic condition like diabetes, especially the accessibility of insulin or the very basics of strips and everything. So these are a few things that I can think on the top of my head that we have struggled as a foundation. And yeah.
Thank you, Diksha ji. I request other panel members, if you want to add other challenges which you faced in addition to two which Diksha has mentioned. I will request Dr. Shivani first. Would you like to add something?
Thank you, sir. So, along with organizing various campaigns for diabetes awareness and education, we have seen that as it's a chronic disease, we need to do the follow-up campaigns also. So, taking the follow-ups, taking a detailed history is so important, and remaining connected to people, to our volunteers, is a bit difficult task for a longer period of time. Not saying it's impossible, but it's something we have to work on and have seen as a challenge.
Okay, so keeping connection with the volunteers and the patient is a challenge. Diksha says generating finances is a challenge. I would ask Apul Doshi ji, what you want to add something to this? Apul ji?
I'll be talking on behalf of Apul sir today.
Yeah.
So, like the other panelists just said, it is very true. Like reaching to people, generating finances and stuff is difficult. One of the major things that we have faced is to convince people to come forward and accept that they have type 1 diabetes. People we have seen are usually hesitant to say that, oh, my child is type 1 diabetic. Like they would try to hide it from the society for various reasons. And we think that it is one of the major challenges, like more people should come forward and they should not take it as, something awkward or something. Like just come forward and say, hey, I'm type 1 diabetes, and there is nothing to be ashamed about it.
So Rohit ji very well said, acceptance by patient and the family that I have this disease. Generally, the first reaction is, I cannot have a disease like this. I will go to Swarup ji from Mysore. Would you like to add anything else to this?
Yeah, thanks, Dr. Rajesh. So we work closely with the government of Karnataka, and we are developing a model for NCD care continuum. We're working on diabetes and hypertension. So it's a population-based model wherein we have interventions with the public health system. So I would like to mention the challenges that we faced in 2017 when we started working with the public health system. So there are 3 levels of challenges: at the facility level, at the community level, and at the health system level. So at the facility level in the urban PHCs, we saw that the healthcare providers were not up to date with the recent protocols, and there was no provision of a counselor and a dedicated lab technician at the urban PHCs, and there were no electronic medical records or any form of physical records to ensure continuum of care. At the community level, we saw that there was no dedicated outreach and micro planning by the community health workers. First of all, there's a lot of vacancy of community health workers, so we had to pitch in with a new set of new cadre of community health workers. And there was no technology platform available to capture the data at the facility level as well as the community level. And there is no opportunity for patients to come together like a patient support group meeting. There are no health and wellness centers, and we had to establish some to ensure that people come over there and practice yoga and other wellness activities. At the health system level, the PHC medical officers were not trained as a program manager. So we undertook an exercise wherein the PHC medical officers were trained as a program manager, wherein the entire 60,000 population of their PHC geography were screened, and out of that we had X number of diabetics, X number of pre-diabetes, as well as the healthy group. And then we helped them to develop interventions and implement interventions for all the specific groups. And there was continuous issue of supply of drugs and consumables at the health system level, which we have addressed to a certain extent. These are some of the broad challenges with respect to public health system.
Thank you very much, Swarupji. You have added a new dimension to the other panelists. And actually, my next question was on the government system. I'll come back to you with that important question, because that has a lot of value addition from the perspective of NGOs. I'll come back to you. Rohit want to say something. You want to add something? You have raised your hand.
Yeah, just one thing, like we are discussing about finances and stuff, and I would like to say the thing that we have personally faced as an NGO is that there are no governmental support. Like you go to government for fundings or any XYZ thing as an NGO related to diabetes. So there is little to no support. And that is one thing that if it changes, then it could be.
Okay, we will come to that. So now the next, our central theme of this is challenges in running the diabetes NGO. This is the first thing we have covered in the first question. The next thing is enrolling the volunteers. So I would come to Dr. Shivani Trivedi. How many volunteers you work with, and how do you enroll volunteers?
So what started as a group of 14 people, our seniors from our college started Prayasam NGO Trust. And today we have around 600 volunteers with us. And we have different wings, and women's wing that works for various other campaigns like breast disease awareness campaign, breast cancer awareness campaign. And other than that, we have diabetes and hypertension awareness campaigns, and some other food donation and blood donation drives.
Okay, so that's what you did from 14, starting with 14 reached to 600. But my interest, and now all pupils are wide open, they want to learn from you how to go from 14 to 600. Tell us that success story quickly.
So basically, it started from our college, and our seniors introduced us to this. Everyone has this empathy inside us, but that needs a platform where we can share our ideas, where we can share our experience for the betterment of the society. So we reached out to other medical colleges. Mainly, we have students with us. We also have students from engineering platforms. So yeah, we contacted different colleges, and they contacted their families. So we have some students whose entire family is involved in our trust. So that's how we started connecting to others.
So literally, and how much time you were able to reach from 14 to 600 workforce?
So our trust was registered in 2019.
Okay.
And before that, we had some WhatsApp groups and Instagram as a social media platform. A big thanks to our PR team, who is working very hard in social media platforms.
Okay, so a lot to learn from you. Swarupji, you are also doing a lot of work. Would you like to answer this question?
Yeah, so we also started working with volunteers way back in 2017. And we came up with a concept of having one volunteer for about 100 people with diabetes and hypertension. So we selected the volunteers from the geography where people with diabetes and hypertension were residing. And the criteria to select volunteers were they should have completed at least 10th grade in terms of education. And they should be dedicated and motivated to bring about a change in the society. They should be willing to provide at least 2 to 3 hours a day. So these were some of the criteria that we have applied, and the turnover is very minimal. We have been able to retain more than 95% of the volunteers, and they do regular outreach and micro planning and ensure home visits to the homes of people with diabetes and hypertension.
Wonderful. So that brings me, actually, you have answered that partly when you say 95% of them you are able to retain. So my next question was to Mr. Apul Doshi, was since the volunteers have a repetitive job and many times you don't succeed, you don't know how things will shape up and people will respond. How do you handle this issue, keep their motivational level high? This is to Apul Joshi ji.
Again, I'm answering on behalf of Mr.
Okay, sorry. Yeah, please.
No issues. That's perfectly fine. Yeah, so the thing about motivation is that for all our volunteers, the reason to volunteer is personal to them, as most of them or their children are type 1 diabetics. So whenever we are organizing our activities, maybe any kind of camp or anything at all, they would be volunteering as if they are volunteering for their own. They consider our organization as one of their own, like a big family member. And so we don't really need to motivate them by external sources. They're pretty self-motivated in our case.
Okay. How many volunteers you handle?
We usually have about 150 volunteers for our bigger activities.
Okay.
And for our smaller ones, we have anywhere from like 15 to 50.
Okay. Then this addresses the second thing. We go to the next situation. What challenges you face, like I think Diksha said this initially, what challenges you face in fundraising in the diabetes cause? This question is to Anand ji. Anand Bhargav ji is there?
Yes, hi everyone.
20
Am I audible?
Vadodara, yes.
Yeah. So, I won't be able to answer this question as such because our foundation is usually funded by our group of companies. So we have a portion of charity that we do from the profits that we gain, because we consider that we have a responsibility to cater the society where we are doing business. Plus, the chairman was also a diabetic patient from last 40 years, Mr. Chandresh Bhai Parekh. So he have actually, put up most of his learning and innovations that he have done and made sure that the volunteers that are with us are, carrying forward it towards in the society. So when it comes to fundraising, so we are doing it from our own group of company, but I feel that yes, there will be like challenges that other NGOs or the organizations might be facing, because
you can tell us which other challenge you face. Do you want to add another challenge which you are facing?
So yes, in terms of challenges, yes, our volunteers, our team members who are working for this cause are facing challenges. One of the biggest challenge, as Dr. Neera Gupta has also said, is education. So most of our cases that we are, attending are from the villages or the people who are living in the outskirts. So the education level is very low. So when the education level is very low, the acceptance, being a family member or being a parent of a juvenile diabetic patient, you will tend to neglect it. So the role of our volunteers is becoming difficult over there, to make them understand that your child is suffering from type 1 diabetes and it needs a proper care and medication on a regular basis, or it can be a lifetime medication that your child might be needing. So over there we are facing a hurdle. Then the second thing that comes is the proper dosage on proper interval. So even after our volunteers are meeting the families on a monthly basis, even they are telling them that this is the dosage, and this dosage you have to take on regular intervals, the family is not following it, because of which the diabetes is not getting under control. So normally the patients that we get, the juvenile patients that we get, is having a A1C report of say 15 to 17%. So we try to bring it down to somewhere around 7 to 8.5%. So, to work this hard, we have to make sure that the child is taking their insulins, their medication, their diet, the child is doing some physical exercises. So for that, we have to convince the parents, we have to convince them that don't make them eat something which is going to, spike the sugar in the child's body. So these are some challenges that we are facing.
Thank you, Anandji. Earlier, other panel member have highlighted that acknowledgement is an issue that they have the disease.
Yeah.
Now you have brought out another thing from the, pocket, that patient adherence is a issue to the therapy, and also the access, because they are not living in a city, so remote places, and the environment there is such. So I acknowledge that, I am noting this. Then the next question related to the, I'm going back to the fundraising issue, because money runs everything. So I'm going back to, you don't have the issue of money, but I'm going back to Dr. Sushil Patel. Have you come across any situations where donors do not understand the need that for diabetes they should be donating, or they may want to donate for other causes like education, nutrition, or other disease like cancer? So have you faced that, and how do you handle that?
Yes, thank you, Rajesh Bhai, for that question. I am handling as a project management posting at the All India Institute of Diabetes and Research. Dr. Mayur Patel, in his presidential address, he has narrated all the activities in the first at the beginning of this conference. So we are working with various projects, not only the type 1 diabetes, but the Save a Leg project and the Prevention of Blindness project, and the type 1 diabetes also, that is Make My Life project. So whenever we are going to the donors, or actually we want to raise the fund from the donors, or maybe for the CSR organizations. So if I ask that I want insulin for the type 1 diabetes children, and you can fund that maybe for 1 month or 1 year or like so. So majority of time what happens that the donors are not aware about the type 1 diabetes condition. So they said that, sir, we don't understand this condition. If you require some money for the nutrition of that child, or if you require something for the education of that child, then we are ready to support that part. But we don't know that there are such kind of existence of children with the type 1 diabetes. So that is a major hurdle in the type 1 diabetes. The second thing about the prevention of blindness. So India, what the donors, what I had seen in the last 8 to 9 years of my practice as a diabetologist and as a project manager in this All Institute of Diabetes and Research, that people do not believe in the prevention. And even the donors are like the same. So when we are asking money for prevention of blindness, and you know that diabetic retinopathy is a major cause of blindness in diabetic patient. So people, I had come across with some patient, some actually donors are like that. Sir, we will give that luckily to the patient, or maybe some rehabilitation cost to the patient after the blindness, but we cannot give you money for that operation of that patient for the prevention of blindness. The second thing, the same with the prevention of amputation of the limb, that we can give you wheelchair, we can give you the processes for the patient who are actually amputated, but we cannot give you the money for the operation of the patient to salvage a limb, because salvage a limb, it is a costlier affair than the amputation of the limb, what rightly mentioned by Dr. Arun Bal in his today's lecture. So these are some of the issues that people are not believing in the prevention part. Again, we are doing the one big project, that is a Stop Diabetes project, where we are doing the so many screening camp across the Gujarat state and the neighboring states, and it actually has the cost of that camps traveling cost and the screening cost and the volunteers we have to feed them and many other costs. When we come across with these donors, they said that everybody knows everything about the diabetes. So what is the need of the education about the diabetes? We know that what should be eaten and what should not be. So these are the major hurdles what we are facing as being a diabetic organization in the various aspects. Thank you for that question.
Thank you, Dr. Sushil. Very nicely summarized. Actually, you have opened the whole Pandora of challenges. And I'm sure all of you must be facing these problems. Right? Swarupji is also.
I have not covered that government aspect because you are supposed to ask.
Okay. So somebody has just said during, I think Swarupji has said that, or somebody said, you don't get proper support from the government machinery, or they are not enough tuned. Probably it was earlier, slowly government machinery is also getting up. You don't assume that I'm pro-government, but the way our healthcare system has speedily responded in COVID crisis, just forget those couple up to 3 weeks of the second wave, but otherwise, healthcare machinery has done a wonderful job. So it's I'm fair on them, the way they have responded. That means systems can work. We need to activate them and be demanding or motivating or helping them. That's what the objective of this conference is. So that brings me to the second question. While I was preparing for this conference over last 7 months, I was talking to various people, and I got to know that under the government program of Ayushman Bharat, and the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke, what they call acronym as NPCDCS. In this program, both the programs, they have insulin and other anti-diabetic drugs approved in the government formulary at the central level. And of course, if it is there at the central level, that means it is there at the state level also. Now, this is the information I got it, and people have informed me that in many states or many districts, insulin is available for type 1 diabetics free of cost. Only thing is they have to go to the respective district hospital and get it every month, which is a pain, which somebody has to bear that. And other anti-diabetics are also available. Now my question, I'll ask one by one. I'll start with Swarupji, since he has been closely working with government, that in your area, these drugs are available, easily available, or you need to do some exercise now after the information?
Yeah, drugs are available, but only thing is they're not available in adequate quantities. And there is an issue in regular supply, especially class 2 and class 3 drugs. So 1 month the drugs are available and next month the same drugs are not available. So people are not comfortable to change the medicines. They are used to take a certain combination therapy. And suddenly when they come back after 1 month or 2 months for refill of medicines, if they don't find the same drug, they will lose trust in the system. So then they try to incline more towards private health system. The Janaushadhi centers have been of a lot of help. So the medicines are really available at a subsidized cost, and Janaushadhi centers, there are many centers which are really located closer to the communities. So the accessibility is not an issue. So when we did the population level screening of the entire PHC geography, so there was tenfold increase in footfall to the PHC. So it was difficult for the district health authorities to believe that, okay, the burden is so much and suddenly the requirement is so much. But with continuous monitoring and continuous generation of data and sharing that with the district health authorities, so they are also now taking measures to ensure regular supply of drugs. So I think once the population level screening is done and the denominator is established with respect to known cases of diabetes and the pre-diabetes, so then it will be easier for government to plan for such kind of demand.
Thank you, Sarupji. You have given a very, very important key here, that you have to work with government authorities closely over a period of time so that they are also enlightened about the facts and figure, what is happening right under their nose and in their area. Unless and until they will not be able to take action.
True,
right?
true.
Yeah. So any other experience similar working with government or with this information, learning from Swarupji, any in your area, would you like to try this? Diksha?
So I have known about this, especially about Jan Aushadhi centers. If somebody is not able to afford insulin, that is one, thing that we always tell, that Jan Aushadhi still has some subsidized rates for insulin. I have also known that since in my area, I have PGIMER, Postgraduate Institute for Medical Education and Research, Chandigarh. They do provide insulin, but then again, what Swarupji said, the outflow is not adequate. You might receive it for 1 month, and for next 2-3 months you might not get it at all. So that is a huge problem. And again, I would really appreciate Swarupji adding that not having enough data of how many people are actually living with the condition is something that also disables government to help us. So having a proper registry where we have information of how many people are living with type 1 diabetes or type 2 diabetes or any chronic condition would really help the government to understand the needs of people who are living with the condition and provide the adequate treatment.
So like Swarupji, you have also emphasized the need of registry.
Yeah.
And so on the day after tomorrow, we have a session where Dr. Yash Patel will be covering the importance of registry. So we are on the right track.
We
are. Any other contribution, Dr. Shivani or Rohit, you want to contribute on this question? Dr. Shivani?
So right now we are working with PHCs and CHCs basically. So at that point, we get the medicine tablets and everything. But I also think that volunteers should be trained well, that proper reference is also necessary. That if we are diagnosing a diabetic patient and if insulin injections are required, and proper reference to a district hospital and proper care should be the next step. And guiding them for the same is something volunteers can work on.
Okay, I should not jump on. You said CHCs and PHCs, and you mentioned it's irregular availability. I should not be jumping to that question, but I'm getting tempted to ask Swarupji specifically. And do you find also that because patients are uncomfortable if the brands are changed? You mentioned combination. Do you mean the brand is changed? I'm taking X company product and then 2 months later you get Y company product. Does that also happen? And that is the reason for discomfort?
Yeah, both ways. So one is changing the combination therapy. Suppose they're taking metformin plus glibenclamide. Suddenly you give only metformin or change that combination drug. So that causes a lot of discomfort. And even the branding appearance has made a difference. So people say, some people come back and say, the medicine which I was taking previous month, that was good for me. I didn't have any side effects. With this current set of medicines, I'm developing gastritis. So it's the psychological effect really. So even though the medicines remain the same, just by changing the appearance, color, and the brand, so they feel it causes a lot of discomfort. And in the private sector, what we have noticed is some of the healthcare providers are very specific on the brands itself. So sometimes they say, if you don't take this particular or specific brand, I can't assure your metabolic levels will be under control. Your sugar will be under control or your blood pressure will be under control. So then the patients will be pressurized to go for those specific brands only. So even the health system is also contributing to this confusion in the minds of people.
So this brings to me to my final question on this.
Dr. Rajesh, Dr. Mayur Patel here. I have comment regarding this. See, regarding the brand. I don't advocate to change the brand. Whatever, maybe it is a cheaper one or it's a costlier one. It's a human insulin, it's a conventional insulin or analog insulin. You cannot change because it increases the insulin resistance. So it creates a great problem. So people with diabetes on insulin, they should not change brand here and there. Maybe once in a while, if there's a problem, then they can change. Otherwise, they should not change. That's a problem.
Thank you very much, sir. It's
again, combination. It's a particular combination. We advise to particular patient. They cannot change the combination also because onset, peak, and the total duration of the insulin differs from one product to another product, one combination to another combination. So it is very difficult, very difficult.
Thank you very much, sir. Actually, I was, the very purpose of asking this question was to understand this part. And
even tablet wise, our personal experience, generic is something different. The low cost is something different. The average cost is something different. I'm talking about the quality. The MNC companies, they have good qualities. Maybe national companies, they have poor qualities. Otherwise, quality is a great problem. It varies, maybe 20-30% efficacy problems.
Yes, sir. That is the reason why I was asking this question specifically. And I was just thinking to come to you for this question. Will it make difference? Because in government system, what happens? Today, L1 is X product, 6 months later, somebody, if L1 is not available, they will buy L2. Then what happens to patient? There, what work Swarupji or somebody else is doing licensing with government district hospital or PSC for 6 months goes in vain when patient lose faith 7 months down, 8 months down the line. So actually government also has to have some kind of system with L1. But you rightly pointed out, sir, this is a bioavailability is an important issue. So
see, we have experience in working in the field in the tribal area and the rural areas. The people, they don't have confidence. Even we provide best medications, best treatment, best doctor training, but still people, they don't have confidence in the government hospital only because these people, they are not maintaining the stock, maybe continuity of the medications and so many issues with the government. Even though they change, it is very difficult to change the mind of the people for the government services.
I agree with you, sir. I agree with you, sir. Last final question. We have talked about drug and insulin and all. Any other way, if any of the panelists can tell us what kind of support you are able to drive from government programs and how, apart from drug. Drug we have talked about just.
Yeah, so we are working with government at all levels of intervention. So be it population level screening, we are utilizing the government resources. So we are an NGO that work so closely with government. So all the frontline workers, we train them and we utilize them in conducting the population level screening along with staff recruited by our organization. And again, when it comes to confirmation of diagnosis, so we set up the diagnostics in the PHC and we mobilized a lab technician from our neighboring PHC through advocacy. So again, government provided that support. So a dedicated NCD day was started. So every Friday was the dedicated NCD wherein the PHC will remain open at 7 a.m. against the usual timings of 9 a.m. or 10 a.m. wherein fasting blood sugar and postprandial blood sugars will be conducted. We have also set up the annual test in the PHC. So ECG is available and kidney function test, lipid profile, screening for retinopathy. And we also have HbA1c, which is done every quarter. So all this is set up within the government premises and government supports in conducting and managing this test. And since the footfall increased, the government is also supporting in providing the drugs. And for the wellness activities, which is done at the community level, like yoga and also the patient support group meetings. So we utilize all the spaces available within the municipal corporation. And post-COVID, we have moved the conduction of tests from the PHC to the outreach centers closer to the community. Again, we are utilizing the space that is available within the municipal corporation. So in that way, the cost incurred for the organization is quite reduced because we work hand in hand with the government. And we have also brought the government health providers as well as the private health providers in that geography on a single platform. Whereas even the private health providers are made aware of the government programs. And so they are also referring people now who cannot afford laboratory tests in a private center. They're referring them to the PHCs, and they are seeking out to the volunteers to ensure a proper follow-up visit is done to the homes of patients, and they are mobilized back for regular consultations and refill of medicines. I think this level of multi-partner collaboration, engaging everyone, both the public and private sector, will result in cost-effective way of implementing the interventions.
Very, very valuable input, Swarupji. You have given a lot of good tips. Weekly NCD day, it's people celebrate yearly. You made it weekly, and you adjusted the timing of the OPD for the testing in the morning. So many novel things and a lot of things to learn from each other. That's what the objective of the conference is. Anyone else want to add to this? Getting support from the government?
Rajesh bhai, just sharing the experience of our project, that is a Conquer Diabetes project, what we had done with the government. That is a public-private partnership kind of project, where the fund is not given by the government. The fund we had raised from another foundation. But what we had done is that we had trained the doctors and they trained the paramedical workers, ASHA workers, Anganwadi workers, and then we are at that stage, and that the project was in 2012 to 2015. We have closely done this project where the NCD project were there in the maybe in the pipeline, and there are only 4 districts has been covered by this NCD project of the government, and we had taken another 2 districts, another 3 districts per se, Mehsana rural area, Ahmedabad slum area, and the Baroda tribal area of Gujarat. And what we had done is that we had trained the doctors, trained the paramedical workers. The project actually came in the mind that at some meeting, someone has said that the government doctors cannot provide the treatment to the diabetic patient. And afterwards, we had initiated this project that if the properly trained doctors are there, because all of them are the MBBS doctors, so if they are properly trained, then they can also provide a primary care to the diabetic patient if the medicines are available. So what we had done that different awareness programs in the community, in the rural area, we had done the pamphlets and the banners at the slum, in the dairy area, or maybe the another mandis or like that. In the tribal area, we had done the skits in the local language. In the urban area, we had distributed the pamphlets to each home. And we had trained the ASHA workers and the Anganwadi workers. We compile all the data. We had done the screening camps. We compile all the data. We are presenting that data to the government of Gujarat. We had also compiled the data of the NCD project of other 4 districts for the government. And we had compared all the data, and we had sent that data to the government authorities. After that, what is the outcome? That they also understand that if properly trained, their task force is there, then they can also manage the thing. So first and the biggest outcome of this project is that ASHA worker, you know that they are the incentive-based workers. They get the incentive for each and every activity, whatever they are doing, either in the nutrition part or in the antenatal part or the vaccination. So government has decided across the state that every Asha worker will get the 10 rupee incentive for a new patient, new diabetic patient that they mobilize from the community to the PSC or the CSC center. And the 5 rupee incentive to the Asha worker if they mobilize a follow-up patient, follow-up diabetic patient to the PSC in the CSC center. So this is the biggest achievement of that project. The second thing is that government has some allocation for this non-communicable diseases. And from that they have allocated 40% of total non-communicable disease budget to specifically only diabetes. And so this, and the third thing is that after that the project, the government has done, they had purchased maybe around 10,000 glucometers and 5 lakh strips for the entire state of Gujarat, and that given to the female health worker of entire state of Gujarat. And right now they all have, at all the PSC level and all the CHC level, they have that glucometers and the strips available with them to screen for the diabetes. So if properly presented data to the government, then they are also sensitive enough to take care of that thing.
Wonderful, Sushil bhai. So गागर में सागर भरा आपने. It is very difficult to summarize. A lot of work done.
So we had done this project along with IIPH Gandhinagar. That Saxena, who is a leader in this project from the IIPH Gandhinagar, and Dr. Mayur Patel, who is a leader from our institute. And in collaboration of both this organization, we had done this project.
I am impressed by the presentation of Dr. Deepak specifically. The way I was looking forward when we were thinking of this topic, exactly pinpointed. You have given which are the institute, what kind of training opportunity, what to do. Everything was there in that. I'm impressed. So with that, I would like to conclude this panel. We had a long day today. At the same time, I would also like to mention, since our topic of discussion within this panel was there, so learning from each other on this, we have one very exciting lecture, learning from module in cancer care in 8 states of India, 200 districts. They have implemented for last 7 years. Doctors, like Sushil bhai was sharing, doctors have been trained for giving chemotherapy. Cancer, they were trained for 2 months about cancer chemotherapy, 1 month hands-on there, and now they are giving chemotherapy. That includes state of Gujarat, Madhya Pradesh, Odisha and all. So if cancer therapy can be given, and that's under government, these doctors are being trained, have been trained, government has purchased chemotherapy and every month they are giving it. And this has been useful very, very specifically in last 1 year, especially when people could not travel to, metro cities. There only you have cancer treatment available. So these doctors have served thousands of patients. So similarly, we have very, very exciting lectures tomorrow, including how to generate crowdfunding. Since you mentioned funding is an issue, we have somebody very senior person from Kitto to talk about crowdfunding. Sushil bhai, I'm taking liberty to give little excitement about tomorrow's good session. So how to engage on CSR opportunity and a lot of good things. So with that, I thank my all panel member very much learning for me also. I hand over to Dr. Neera.
Thank you, Rajesh. Thank you, Dr. Anil sir. Thank you all the panelists for wonderful discussion. With this, we now come to an end of day 1 proceedings. We had great scientific interactive sessions, humanitarian sessions today, a lot of learnings to take home indeed. We enjoyed highs of laughter, science, art, spirituality, innovations, digitalization, and clinical research, and not to forget education. So with this, I know that we have exceeded the time by 40 minutes, but thank you for being so patient and being with us. We look forward to seeing you tomorrow. Stay safe, stay happy. Bye-bye, good night, and good day, different geographies. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you.